of the Association of Surgeons of India 2025. Today marks the beginning of an important gathering, a forum where the past, present, and future of surgery intersect. In this room, we have with us distinguished group of surgeons, researchers, educators, and students who have come together for a shared purpose to advance the science, the practice, and the human impact of surgery.
This year's theme is delivering value-based surgery at your doorsteps. With this in mind, let us use this opportunity not only to learn, but to connect, to find common ground between specialities, institutions, and countries. In doing so, we uphold the spirit of surgical progress, one that thrives on curiosity, mentorship, and a constant drive to improve our outcomes. As we now begin the sessions, I invite all of you to take part with openness, enthusiasm, and the shared commitment that defines our profession. For the first session, I would like to invite our distinguished chairpersons, Professor Dr. Mumtazuddin Wani, former head of the Department of General Surgery, Government Medical College, Anantnag; Dr. Subhash Abrol, Senior Consultant Surgeon; Dr. Tashi Motap, Senior Consultant Surgeon at SNM Hospital, Leh; Dr. Gulam Jilani Zargar, Senior Consultant Surgeon.
Congratulate the Department of Access Surgery, Government Medical College, who has tremendously organized this Jakasikan. I welcome you all, including the Professor Iqbal Salim Saab and his colleagues from JMC Srinagar, to this the event of Jakasikan 11th, which is being conducted in the auditorium of the Government Medical College, Anantnag. So without wasting much time, I would like to call upon the first speaker, who is Dr. Rais Ahmad Khande, who is the Senior Resident in Department of Surgery, GMC Anantnag, and his topic is Surgical Management of Gastric Carcinoma, our experience. So he will be presenting his experience from GMC Anantnag. Dr. Rais.
Respected chairpersons, teachers, and your colleagues. I am Dr. Rais, Senior Resident Department of Surgery.
I request the speakers please be restricted to your time limit because time is short. We have to run very fast. Be restricted to your time.
Okay, sir, I'll try. I'll be presenting surgical management of gastric cancer and our experience in GMC Anantnag. As you know, gastric malignancy is very common, particularly in South Kashmir. All over the world, its incidence is around 875,000 annually. And though the location is still more common in distal stomach, but the proximal stomach incidence is increasing. All over the world, high rates are found in Japan, East China, and South America. And diagnosis of gastric cancer is done by upper GI endoscopy and combined with biopsy. When we take 4 to 6 tissue samples, the accuracy of the biopsy goes up to 98%. Once the diagnosis is done, then we go for staging. The most important tool in staging of gastric cancer is endoscopic ultrasound. Besides providing the depth of the tumor and extent of perigastric lymphadenopathy, it accurately stages up to 82% for T staging and reaches up to 90% in N staging. It has the highest sensitivity among all modalities for N staging of the disease. These are some of the pictures of the endoscopic ultrasound. The picture A represents normal mucosa, submucosa, and muscularis. In picture 2, you can see a mass that is reaching up to submucosa. Then in picture 3, you can see mass reaching up to muscularis propria and lymph node as well. Second investigation that is done in staging of the disease is CST abdomen. Its sensitivity reaches up to 66 to 70, 80% in T staging, and for N staging it reaches up to 86%. Besides the T and N staging, it helps in identifying the liver and peritoneal metastasis, local invasion, and ascites. However, it has a limitation of in detecting early gastric cancers and small peritoneal and hepatic mets. This is a representational pic that shows multiple hepatic hypodense lesions, likely metastasis. Though MRI is slightly better in T staging of the disease and than CCT, however, N staging is lesser than it. But because of the low availability of this MRI and increased cost and increasing techniques and increasing sensitivity of the CT, CT is getting better and more equipped for this. Positron emission tomography, though routinely not done in gastric cancer staging, however, NCCN guidelines recommend that any disease that is more than T1 and there is a clinical suspicion of metastatic disease, and we are planning neoadjuvant therapy, it is better to go for PET scan. Further, it can help in assessing the response to the therapy as well. Tumor markers, usually CEA, can be combined with CA19-9 and CA15. These help in prognosticate the disease. They may reflect the tumor burden and may reflect the response to the therapy. And now staging laparoscopy has become a part of the routine management of the gastric cancers. It helps in upstaging of the disease and detecting very small volume liver and peritoneal mets. It is sensitivity in detecting small mets reaches up to 90%. Besides upstaging the disease and sparing patients for unnecessary laparotomies, we can do peritoneal cytology, we can do diagnostic lavage and laparoscopic ultrasound because of it as well. And this slide represents AGCC 8 staging of the stomach. You can see it has changed from T4 and T4B and N1. N1 is now T2. This is reaching up to 2 nodes, and 2 is up to 6 nodes, and N3, 7 or more nodes are involved. Then clinical pathological classification of gastric cancers, Lawrence classification is commonly used. We have 2 types, type 1, type 2. Type 1 is intestinal, more common in men. And then again, classification, Japanese classification for early gastric cancers. You can see type 1, type 2, type B. In advanced gastric cancers, we have Borman classification, you all know that. Then comes the management of the gastric cancers. One is adenocarcinoma, stage the disease with CT endoscopic ultrasound. Then if the patient is having metastatic disease and there are symptoms present, then we subject the patient to this palliative resection. We may do palliative resection, we may do palliative bypass. In asymptomatic patients who are having metastatic disease, we send them to medical oncology for further treatment. However, if patient is having a non-metastatic disease, we plan him for staging laparoscopy and then proceed further. Depending upon whether patient is having early gastric cancer or advanced gastric cancer, we plan accordingly. Early gastric cancer is defined as a disease that is limited to mucosa, submucosa, without lymph node status. Early gastric cancer is more commonly diagnosed in Japan, and around 10% of such patients will have lymph node metastasis. 70% are well differentiated and 30% are poorly differentiated. In early gastric cancer management, we have different treatment options. We will have endoscopic mucosal resection, submucosal dissection, then limited surgical resection or gastrectomies. There are clear-cut guidelines for endoscopic mucosal resection. The tumors that are less than 2 centimeter in size, confined to mucosa, no lymphovascular invasion, no ulceration, or moderately or well differentiated are subjected to endoscopic mucosa resection. This picture demonstrates how endoscopic mucosa resection is done. You can see saline is injected, tumor lifted, then a snare is put, and resection is done. Complications that are related to endoscopic mucosa resection include bleeding, perforation, incomplete resection, high recurrence, and incomplete staging. In stage 2 and stage 3 disease, gold standard still remains the surgical resection. Complete surgical resection with R0 resection is attempted and adequate lymphadenectomy is done. These are different types of gastrectomy that we can do. Depending upon the location, if the location is mid-body or proximal, we do total gastrectomies. If distal tumors are present, we can do subtotal, distal partial, or total gastrectomy also. Subtotal gastrectomy is preferred over total gastrectomy because 5-year survival is equivalent. There are fewer complication rates. Patients having better nutritional status and shorter hospital stay. Reconstruction can be done with these types of gastrogenostomy procedures. Commonly, we do Roux-en-Y, we do Birotteau, we have done Braun also. Now, there's the concept of multivisceral resection in patients who are having P4B disease and the organs involved are resectable. It is better to go with multivisceral resection. Multiple studies have demonstrated benefits with these procedures. Resection should be, as margins should be 5 to 6 centimeters. Now the lymphadenectomy that has to be adequate depending upon the stage of the disease. If mucosa is involved, the nodal involvement will be 5%, if submucosa 25%, and more than that, there are 90% chance of lymph node involvement. These are lymph node stations. Then lymphadenectomy is classified as D0, D1, D2, and D3. D0 is when no attempt is made to remove lymph nodes. D1 is when perigastric lymph nodes are removed. D2 is extended D2 is when after station 12 is removed. In D2, we go for lymph nodes that are along named blood vessels like celiac, splenic, gastric. D3, even extended D3, even periaortic nodes can be removed. This is commonly done in Japan. Now there has been a debate going on with D1 versus D2 resection. Earlier it was said D2 resection is not that helpful. There are increases in morbidity, mortality chance. However, modern studies have demonstrated that mortality and morbidity is equivalent in both, and D2 may offer survival advantage. These are some of the comparative studies that have been published. So based on available data, a D2 resection without routine splenectomy, pancreatectomy should be performed wherever possible. AGCC 8 has recommended that at least 16 nodes should be removed. These are complications, this is prognosis. Now our experience at GMC Anantnag, since 2019 we have done 41 cases, males were 24, 17 females. Age ranged from 40 to 80 years, average age was 62 years. Most common location was distal stomach and propyloric region in 25, proximal was in 15, and one gastrogenostomy site was having malignancy. That patient was operated 10 years before for benign disease. Presenting symptoms included gastric outlet obstruction, anemia, GI bleed, pain, and constitutional symptoms. After diagnosis, patients were subjected to staging, and once staging was done, patients were sent accordingly to neoadjuvant, upfront, or palliative surgery. Baseline investigation was done, and CA were done. Procedures we did were distal gastrectomy, total gastrectomy, and subtotal gastrectomy. Palliative gastrogenostomy was done in 2 patients. We commonly did here Roux-en-Y reconstruction, though Birotteau was earlier done in around 17 patients. Braun was done in 1. Hospital stay ranged from 7 to 21 days with average of 9 days. Following discharge, they were subjected to medical oncology for further follow-up.
Time is over.
This is some of the slides, specimens that we have done.
Thank you, Dr. Reyes, for this presentation. Malignancies are very common, especially in this region, and you have talked about in detail about the gastric carcinoma. I think questions is at the last of the session or the last? Okay, last of the session. So we'll call upon the next, thank you. Next speaker is Dr. Adnan Rashid Mattu. We will talk about the effective trolley management in laparoscopic surgery. He is consultant surgeon and faculty NB DHSK DH Gandharbal, District Hospital Gandharbal. Dr. Adnan Arshi.
कंट्रोल मेरे पास है अच्छा मेरे पास है Respected colleagues, my teachers, friends, I am Dr. Adnan. I am a consultant surgeon at District Hospital Gandharbal. Today I'll be speaking about effective trolley management in laparoscopic surgery, which is the basis for effective surgery. So, why a surgical trolley matters? A good surgical trolley improves your efficiency in surgery. There's better infection control. It increases your instrument longevity. It improves team coordination, and there is emergency preparedness. Some common challenges in trolley management. The most important, especially in minimal access and laparoscopic procedures, is lack of familiarity with the instrument placement. Wasted time and increased risk of contamination, and in the end, it impacts the morale of the whole team. So the solution will be recognize these challenges as learning opportunities to build better habits early in your career. So for simplicity, the 4S framework for a laparoscopic trolley management should be followed. The 4S are standardization, sterility, segmentation, and simplicity. So by standardization, we mean we should use a consistent layout for every procedure. In this trolley, we can see the first one, that the ports and the varus are placed on the left side, the hand instrument below the trolley, and the telescope on the upper side. So that whenever there is an emergency, your assistant has ease of access. He is not confused. Sterility, it should have strict adherence, especially in laparoscopic procedures, because port site infections are very dreaded complications. Segmentation, we should group the instruments logically. For example, here all the tooth forceps have been grouped on one side and the non-tooth on one side. And simplicity. The left side of the trolley, you can see all the laparoscopic instruments arranged in a simpler way and a defined way, and the right side is a mess. And usually in emergency surgeries and big surgeries, we follow the right side of the trolley. So, first one should be done, not the second one. So, setting up of the trolley. Most important is pre-surgery planning based on the procedure. So we as general surgeons, especially we beginners, we are just familiar with lap cholecystectomy and lap appendectomy. So we know all the 4 or 5 instruments which is to be used. Whenever we have to do a different surgery, everybody gets confused. हमें कहाँ पे क्या रखना है? So pre-surgery planning is important. You should discuss this with your staff, with your theatre assistants, that tomorrow we are going to do such a surgery and I need such things. We should segregate the instruments into trays, cutting tools, and graspers. We should verify the functionality of all the instruments. Usually what happens in setups like us, we have limited trolleys, limited laparoscopic instruments. On table we start doing a surgery and suddenly suction नहीं चल रहा है, Maryland नहीं चल रहा है, ये दूसरा दे दो, assistant बोल रहा है एक ही है हमारे पास, और फिर हम जुगाड़ करते हैं. So we should verify the functionality of the laparoscopic instrument before starting the surgery. And always position the trolley which is ergonomically accessible to the assistant as well as you. Tip is encourage teamwork between surgeons, scrub nurses for efficient setup. We should not just yell at our assistants. What are the scrub technician tasks? First is check functionality of the reusable instruments, check free movement of the instruments, handles, check sealing caps, check openings, check to ensure the instrument cleaning channel and screw caps are in place. We should check the he should check the varus needle for proper plunger and spring action and ensure easy flushing through the stopcock or needle channel. If Hassan's cannula is to be used, ensure availability of stay sutures and retractors. Check valves, plungers, spring, and ensure tight seals on the reusable Hassan's cannula. We should close stopcocks of all the ports. We should check the laparoscope for clarity of vision. We have a local anesthetic of choice and injection syringe available. If contrast is to be used, for example in cholangiography, we should keep the adequate dilution mixed appropriately before the surgery has started and evacuate all the air bubbles, tubing, syringe, and catheter. So what are the basic steps in setting up a trolley, especially a laparoscopic trolley? First is the clean work area. Start by cleaning the surface where the sterile trolley is to be placed. Use a disinfectant or wipe down the surgery thoroughly. So this we usually don't follow, especially nowadays in private hospitals. One patient comes up and second one is taken on the bed without even cleaning. So we should gather the necessary equipments and supplies, collect all required sterile equipment, sterile supplies, sterile gloves, sterile gauze, sterile drapes, dressings, sterile syringes, antiseptic solutions, alcohol and betadine, sterile instruments, and sterile trays. Everything should be sterile. We should open the sterile package carefully. Sometimes we follow good sterilization techniques, but when the sterilization package is opened, for example, at our hospital, we have lots of students. They open it up and then bring it contaminated to you. So always a senior scrub technician should open the sterile trolleys. Avoid touching the sterile instruments. We should arrange the items in the trolley in the designated areas, as I already told. We should cover or wrap the unused items. If there are items that won't be immediately used and need to be remain sterile, cover them up, because the theater atmosphere is not usually 100% sterile. And labeling and documentation is important. If required, label the items or containers with relevant information. Ensure that any documentation or labeling is necessary for the procedure readily available. Replace any expired items or those that are no longer sterile. So we should always maintain an expired items box or somewhere where they are not reused. Sometimes they get an expired item again to be used. Labeling, especially in laparoscopic instruments, we use Sidex for high-level disinfection. So we should always label the Sidex tray when the Sidex has been changed. Usually it is not followed. Your assistant tells you, "Ye humne kal hi change kiya," and we believe him. There should always be labeling. So whenever there is troubleshooting and real-world application, what happens there? If an instrument is missing, not function, have a backup plan. So you are doing a laparoscopic cholecystectomy, your 4 hand instruments in hand, keep 4 extra so that in emergency you need it. Maintain a good communication with the scrub nurse, follow sterility protocols even under pressure. Suppose you have bleeding and your instrument falls down. In emergency, we just take it up, clean it with the sterile wipe and use it again. So it damages your whole sterility change. Clear communication during surgery. Again, place tools for ease of access and use. And maintain a neutral arm position. So ergonomics is important. When the surgeon and the assistant is at a neutral position, he will be able to deliver better. So, and once you finish the case, then you should always have lessons from your practice, what you did. What was before and what happened. Did we do it well or something went wrong? And if something went wrong, we should document it. And whenever we are doing a new case, which we are not familiar with, because laparoscopy is all about ergonomics, so we should document. This is briefly how we should document. We should do instrument mapping. We should have a continuous teaching. And we should always have a post-operative recovery which is optimized. This is an example for a sample documentation. So you are using a scrub nurse which is new to you, who doesn't know how to do this procedure. Make this beforehand and show him that you have stand on this side and trolley on this side and surgeon on this side. So when we started with doing lap hernias, myself and my assistant was always confused. He used to tell me, last time I came on your right side. I used to tell him, no, you came on my left side. I was also confused from which side he came, because we are not regularly doing these procedures. So if we make a sample documentation, yes, this position is better for me, and always follow this position. So key takeaways. Effective trolley management enhances surgical efficiency and safety. Embrace the 4S framework, that is standardization, segmentation, sterility, and simplicity. And teamwork and communication is critical for improving the patient outcomes. Thank you.
Thank you, Dr. Adnan. We will have questions at the end of the session. Then we will call upon the third speaker of the session, who is Dr. Arshad Ahmad Baba, who is again a consultant, Director of Health Services Kashmir, District Hospital Kulgam. He will talk about the management of laparoscopic management of incidental Meckel's diverticulum.
Respected chairpersons, colleagues, and teachers, Assalamu alaikum. I am Dr. Arshad. I am working as consultant surgeon in District Hospital Kulgam. Today I will be speaking about laparoscopic management of incidental Meckel's diverticulum. It's the congenital diverticulum arising from the antimesenteric border of terminal ileum, originally described by Fabricus in 1598, and it was named after John Frederick Meckel, who established its embryonic origin in 1809. During the 8th week of gestation, the vitellointestinal duct normally obliterates, but failure of this obliteration results in various congenital anomalies, and one of the commonest among them is Meckel's diverticulum. Most common congenital anomaly of the gastrointestinal tract and contains all the 3 layers of the bowel with an independent blood supply. If Meckel's diverticulum is found in an inguinal or a femoral sac, it's called Letter's hernia. Now, these are various presentations of this embryonic malobliteration of this vitellointestinal duct. You can see it can result in intestinal fistula, umbilical sinus, an intra-abdominal cyst, or an intra-abdominal band. Now, as far as epidemiology is concerned, the rule of 2 is easy to remember it. It's present in 2% of the general population. 2:1 is a male-female ratio, usually located 2 feet proximal to the ileocecal junction. 50% are symptomatic under 2 years, about 2 inches long. In adult patients, it is symptomatic only in 2%, and it has 2 heterotropic mucous tissue present, usually gastric and pancreatic. Now, most of them are asymptomatic, and if symptoms are there, they may be like hemorrhage, intersusception, Meckel's diverticulitis, chronic peptic ulcer, or intestinal obstruction. Now, they are usually diagnosed by their presentations, like if there is this intestinal obstruction because of the volvulus or entrapment of the intestine by the mesodiverticular band, intersusception of the diverticulum, or structure secondary to chronic diverticulitis. In this picture, you can see a mesodiverticular band running from mesentery to the diverticulum, and there's an entrapment of the bowel. Now, one of the important modalities of diagnosis is this technetium scan. It's positive only when the diverticulum is associated with gastric mucosa, which is capable of uptake of this tracer. Now, differential diagnosis is intestinal obstruction, hematochezia, appendicitis, intersusception, lower GI bleed, angiodysplasia, malignancy, or arteriovenous malformation. Complications like ulceration, hemorrhage, small intestinal obstruction, diverticulitis, and perforation. Now, since most of them are asymptomatic, the indications for symptomatic one is hemorrhage, obstruction, diverticulitis, fistulas, and perforation. And for asymptomatic or incidentally detected during other laparotomy due to other things, indication for surgery is patients who are under 50 years of age, diverticular longer than 2 centimeter diverticular with narrow neck, diverticular with fibrous bands, suspected ectopic gastric tissue, or inflamed or thickened diverticula. Now, management is always surgical in symptomatic patients. Now, you can do small bowel resection in patients who are presenting with bleeding, strangulation, or obstruction. But if it's incidentally detected, you can do this simple diverticulotomy. It's not playing.
Thank you.
It's not
Questions later on after the session.
playing. I just want to play this video. Just there.
Okay.
This is a patient who was a 21-year-old female who was diagnosed at acute appendicitis and was operated for same. And once we were doing some diagnostic laparoscopy to look for the terminal, we found this diverticulum, and it was longer than 2 centimeter, and patient was younger age, so we decided to do a resection. So we resected it and removed the specimen. Then we used this barbed sutures, 2 barbed suture, 15 centimeter length, and closed the defect. Then after cleaning, you just look for the integrity of these sutures, check them. Just checking for the same integrity, looking for the sutures, and then you clean the region, and then place a drain. I think I'm ahead of time. So if there are any questions.
Questions after the session?
Okay. Thank you.
Well done. Next speaker is Dr. Yunus Kamal, Associate Professor and Head of the Department of Orthopedics, GMC Anantnag. He will talk on management of pelvic injuries in Department of Orthopedics and Spinal Surgeries, GMC Anantnag.
Professor Yunus Kamal is a very good academician. He is professor and heading the Department of Orthopedics and an excellent surgeon, excellent spine surgeon, I should say. So we will be listening to his.
Excuse me.
He is really Kamal.
He's not coming. करो इसको. Extended. Screen mirroring. इधर. नहीं आ रहा. आगे आगे. Respected chairperson, respected teachers, dear colleagues, assalamu alaikum wa rahmatullahi wa barakatuhu. I, on the behalf of Department of Orthopedics and Spine Surgery, GMC Anantnag, congratulate Professor Nazir and entire team of General Surgery for conducting such a wonderful event here. Even though there was a setback last month, but he has come up. This is the courage I have taken from him. Another point, this is the first time we are conducting this event will be remembered for ages. This is the first event we have conducted in this hall. And I thank Dr. Nazir that he has given me the privilege to present him some of my cases here. And I know that surgery is the mother of all the departments, all the surgery departments. And it is always good to go back to your mother department and present some of the cases. It is very difficult to find my position here, but still, I am going to present few of my cases for your appreciation. I thank Professor Mamtazi. He has been our guide here. He has been the pioneer of this upcoming medical college. And I thank him for his words. Thank you very much. I'm presenting few of the cases. As we all know, this is a new medical college, and our priority is to make a zero referral center towards this, other cities, other tertiary care hospitals. That has been our priority from last 1 month. Since we have been retaining many of our patients now, which are high-risk patients, and among those high-risk patients, we have pelvic injuries. We have taken up these pelvic injuries from last 1 month since the start of ICU also. So we have been able to manage few of the patients, luckily, and I'm going to present few of the cases. Since these injuries are visually associated with higher energy trauma, motor vehicle accident, motorcycle crashes, fall from height, crash injuries, few of the elderly patients who have osteoporotic wound have a trivial trauma and they present to us. They are frequently associated with the head injuries because of the high energy trauma, abdominal injuries, urogenital injuries. That is why I'm presenting it here, spine fractures, chest trauma. And usually whenever these patients come up to our casualty, they are associated with hemodynamic instability. So managing these patients is another level in a hospital, another level we need. We need a team of work from anesthesia, surgery, general surgery, and specialty branch. It is also associated with high mortality rate. Usually it is between 80 to 30% of rates. And major determinants of these fractures are like hemorrhagic control, associated injury management, early stabilization of the pelvic injuries, and access to a trauma care level center where there are multiple departments working together. Sir, my first case will be this 23-year-old, is not working properly. 23-year-old male with no comorbidity, road traffic accident, trauma to pelvis. Patient is hemodynamically stable, pelvic compression distraction tests are painful. Right lower limb shortening is 2 centimeter. This is the X-ray. And this is the CT scan showing a vertical shear type of injury. He underwent a surgical stabilization. We are doing a unique procedure in these patients. We are calling it inflix. We are doing a sacroiliac joint fixation with an inflix putting subcutaneously because it's a minimal invasive procedure. These are the all X-rays we have done, and this is the final X-ray in October 22. And he has recovered very well. Functionally almost normal. This is another patient who has a 55-year-old male with history of fall, developed a pelvic vestibular fracture, anterior column fracture. This is a CT scan. We did a surgical procedure like we have used the anterior intrapelvic approach, what we commonly use as STOPA approach. I have done a fixation of the vestibulum through pelvis, and this patient recovered very well. This is another patient with a history of fall from height, with a pelvic injury, with this pubic symphysis disruption, and with a sacroiliac joint disruption posteriorly. With a vertical shear injury, we have done a fixation posteriorly, a sacroiliac joint, and as well as this pubic symphysis was fixed. These are the serial X-rays, and patient recovered very well. This is a unique patient who has an 18-year-old female with a history of fall from 3-story, with a spine trauma, with a neurodeficit, with a pelvic injury, with a calcaneal fracture. This patient was also hemodynamically unstable, and we stabilized it. After stabilization, we took this patient for surgery. These are the CT scans showing a severe compression fracture of L3 with cord compression, with pelvic injury, with calcaneal fracture. In one sitting, we did this patient. We have done all the 3 procedures. We did spine stabilization, we did pelvic stabilization, as well as calcaneal fixation. This patient is recovering very well. She is 6 months follow-up. She is walking on walker right now, but persistent neurodeficit is there. There is another patient, 45-year-old female, male from fall from history of fall from height, previously operated for fracture shaft of femur with a vestibular injury, anterior column. I did an anterior intrapelvic approach, what we commonly call as an STOPA approach, because I know on the back of my side is there is a surgical department. If anything problem, we can go back there and tell them to help us. That is why we are confident to go for intrapelvic in these patients. Luckily, we have been able to do few of our cases and fixed these patients through a very difficult intrapelvic approach. And this is the fixation we have done. And this is the poster. It's like same as cesarean. With cesarean people are using the incision, same incision, and patient recovered very well. This is another patient, 60-year-old female, history of fall from one-story building, uncontrolled diabetes, having a pelvic injury, lateral compression injury, underwent fixation. This is a 40-year-old female, history of fall with previous LSCS. Because why I'm mentioning LSCS, because LSCS patients, these are contraindication, we cannot go intrapelvic. So we have done this minimal invasive fixation, both posteriorly and anteriorly. She recovered very well. This is another patient from Riasi. We are seeing these patients from different areas, history of fall, laborer, with both pelvic and vestibular injury. So with calcaneum fracture also. So we have done same anterior intrapelvic approach, fixed the patient both anteriorly and posteriorly. He underwent 2 surgeries and he has recovered very well. I thank you all for patient hearing. I thank you for the opportunity. Thank you very much.
Thank you very much. Thank you, Dr. Yunus. Now, the next speaker is Dr. Umar Yasid, Associate Professor of Dermatology, GMC Anandak. He is speaking on redo hair transplant procedure.
Good morning, everybody. It's a huge pleasure to be here today. I'm highly thankful to Dr. Nazir Saab, Dr. Khalid, Dr. Zahid, Dr. Manmohan, and all your team for making this conference happen here, despite hurdles there. So congratulations to all of you. And thank you for having me here today. Respected chairpersons, I also want to thank Mumtaz sir, Tashi sir, and Ghulam Jilani sir for asking me to come over here. Thank you, sir. So I'm a dermatologist and I'm doing hair transplants since last 12 years. And I'm a member of an association known as International Society of Hair Restoration Surgery. It's a global authority on hair restoration and hair transplants. So my topic is redo or revision hair transplant. I have no conflicts to disclose for this presentation. So I'll begin with an educational video from this society because I'll just introduce brief terms which will make it easier to understand this video. This we call what's known as a fraudulent hair transplant. By fraudulent, we mean the transplant which is being done not by the doctors, but by the technicians. So there's a campaign worldwide going on, which is to make aware our patients that this is a fraudulent hair transplant. This is not a legal transplant. So let's have a look at this video. Audio, please. So this is the campaign. This is fight against fraudulent illicit global hair transplants. So we're making aware of patients about these fraudulent transplants. And you can have a look, if you want more information, you can go to the website and check more details. So what can go wrong? Post-transplant, we have seen a lot of complications happening like this. It's an atypical mycobacterial infection. and scalp necrosis. What happens there is because in the center of the scalp there are end arteries. So if there is compromise in the vascularity, after transplant you may have scalp necrosis. Another case, so natural versus unnatural hairline. Even if everything has been done right, so what happens there is the hairline goes down, if you can see on the right-hand side, and it's going up in the left-hand side photo. So there's from a distance, the patient can make that the transplant has been done, and it looks unnatural. So coming to what transplant has come a long way, from doll-like hair to finer hair transplants, from disfigured donor to not so noticeable donor, from greater downtime to short recovery, because when the transplant process started in 80s, 70s, they used the bunch of hairs were put on the scalp and it looked like a doll-like a hair. So they have come across and it has changed to finer hair transplants. The donor area was ruined in the earlier transplants. Now it's said that its donor area should not be noticeable. From greater downtime to short recovery, and from just hair growth to natural hair growth. According to the survey done by International Society of Hair Restoration Surgery, 51% ISHR's members reported there are black market clinics in their cities. So the revision surgeries have increased during each passing year. When performed by qualified doctor trained in art and science of hair transplantation, hair restoration surgery is an excellent procedure for treating hair loss safely and effectively. In wrong hands, hair transplants performed by non-qualified technicians can have devastating results. With the growth of the clinics where doctors don't perform the surgery, the unnatural look is back. What is the basic cause? What can be done to avoid it? What instrument should be used? So we may answer these questions. So there are two main causes of poor results. One is error in assessment, the progression. The doctor fails to understand that the hair loss is progressive condition. Transplant has been done at a very young age. There is error in hairline design and unable to perform trichoscopy to identify if there are any inflammatory scalp conditions where hair transplant cannot be done. Another is error in surgical technique. The plug grafts have been used, placing 2 or 3 hair grafts in the anterior hairline. Poor understanding of the angulations and directions, including frontotemporal angles and temporal points. Donor over-harvesting and age inappropriate hairline. So who is looking for a revision hair transplant? Patient who has failed hair transplant, if there is poor growth, good growth but not natural looking, or a complicated hair transplant. So these are the challenges in a redo surgery. The skin is already scarred, there's fibrosis, there's poor blood supply, and difficulty in extraction of wrongly placed grafts. This patient was promised 5,000 grafts but couldn't get a satisfactory result. Donor area has been over-harvested here. He has thinned out hairline. This is punch harvesting done long back. After the first session, and he's looking for a revision. So this is after the first session, done from somebody else. So in this patient, if you see there's good growth, but the principles of natural hairline are not followed. The hairline is going down, and there are thick coarse hair at the front hairline. So this is again the same patient. This is poor growth after first session. Donor area has been completely annihilated. So once such patients come to us, how we proceed in these patients? We do a careful analysis. We do trichoscopy. We evaluate the patient for any inflammatory skin condition, which may lead to the failure of the transplant. We check whether donor is available. We ask for, we check whether it's realistically possible to do. We can use the body hair, we can use beard hair, and not to forget the medical management. So understanding of the hairline design. So hairline has certain points which need to be identified, and they have to be marked once we start making the hairline. So first is the mid-frontal point. It's 7 centimeters above the glabella, and then comes the transition zone, which is just beneath the interior hairline, which has to be little thin, and then comes the defined zone in which we have to place the good thick hair grafts. In the transition zone, we have to place the single hair grafts to make it look more natural, and there are certain micro and macro irregularities in the scalp, in the hairline, which have to be followed. And then there's frontotemporal angle, which has to be there in case of males. So frontal, another important point to understand while making the hairline is angle and direction. The angle of the frontal hairline is 15 degree anteriorly. It increases angles as we move backwards. But there should be gradual transition. If we make 15 degree, we can't make 25. We have to just keep on increasing the degree of the angles as we move posteriorly. So we try to avoid adrenaline as much as possible because already the blood supply is compromised. We remove the 3 hair grafts using 0.8 millimeter punch, and to avoid the scarring as well, we split the grafts under the microscope to make them single and then put back. So, can I play this video? No? वीडियो नहीं चल रहा है? ठीक है. हाँ जी? अच्छा अच्छा. No, it's not there. No. It's not in the folder. Anyways. So we harvest the grafts from the anterior hairline. If you can see, these are big grafts that have been placed in the hairline. And that makes it very obvious to the onlookers. So this is again the graft dissection video. I'm not able to play it. So this is immediate post-operative. And this is the top view after the surgery. And this is the graft chart, how we maintain, like how many single grafts have been placed, how many double grafts have been placed, and how many triple grafts have been placed. So this is the view where we have removed the thick 3 hair grafts from the anterior hairline. This is again the right side view, same patient. This is crusting after 3-4 days. So these are few of our results after doing revision surgery. These grafts have been taken from the beard and put in the frontal scalp. So this is hairline correction after removal of 3 to 3. This is after revision surgery again. So after a few deaths were reported in India after transplant, National Medical Council came up with the guidelines. You can ask me, I can share if you want, somebody wants to have a look. So where things go wrong, the use of technicians to perform hair restoration surgery, which should be only performed by properly trained doctor, places patients at the risk of misdiagnosis, failure to diagnose hair disorders and related systemic diseases, performance of unnecessary or ill-advised surgery, all of which jeopardizes patient safety and outcomes. So in conclusion, these steps should be performed by the doctor himself and to prevent any mishap. Pre-operative diagnostic evaluation and consultation, surgery planning, surgery execution, including donor hair harvesting, hairline design, recipient site creation, and management of other patient medical issues and possible adverse reactions. Thank you all for your patient listening.
Thank you, Doctor. Final speaker of the session, Dr. Tufail Ahmed, Assistant Professor, Department of Microbiology, GMC Anantnag. MRSA in surgical site infection, a microbiologist's perspective for surgeons.
Good morning, everyone. I'm Dr. Tufail, and be deviation from the routine, I'll be presenting my microbiological perspective on surgical site infections. Now, MRSA is the major cause of SSIs. It leads to higher morbidity, longer and greater hospital costs. So, surgical site infections complicate up to 5% of all surgeries. It's the leading cause of nosocomial infections worldwide, and it presents a really virulent and a treatment-resistant organism. So 20 to 30% of all surgical site infections are usually caused by MRSA. There are 2 variants, which is the hospital-acquired MRSA and the community-acquired MRSA. Now the key factor is the colonization of the patient before the surgeries. Although MRSA can be acquired via the hands of healthcare workers as well, but studies have demonstrated that the endogenous colonization is a major risk factor. So what does it do basically? The adherence to wounds, the biofilm on prosthetics, toxins, especially the MACA gene, which leads to the MRSA production. And it not only is resistant to the mainline antibiotics, it's resistant to the most of the antibiotics which are being used for treating infections. What are the risk factors for MRSA? It's prior MRSA colonization, ICU stay, prolonged stay, invasive devices, poor prophylaxis, and inadequate decolonizations. So the diagnostic approach can be the samples received as wound swabs, aspirates. The testing, it can be either conventional or it can be rapid testing. Screening of all patients, especially nasal and skin, and those admitted in ICUs. Now, what has been suggested as part of prevention is pre-op administration of muprocin, chlorhexidine washes. Intraoperative, we can add vancomycin if colonization is present, and post-op isolation and hygiene bundles. Now, our experience, our department was set up at the time when GMC was established. Unlike other departments which were pre-existing in this district hospital, we started from the scratch. Now, we have been dedicated to providing essential diagnostic services, research services, actively contributing to infection control. Now, with a commitment to advancing healthcare, the department offers wide range of high-quality testing services, including bacterial, viral, fungal, and parasitic diagnostics. So these tests are critical in identifying and managing infectious diseases. So the department plays a vital role in infection control within the hospital, supporting surveillance and prevention strategies to limit healthcare infections. Besides that, we also are involved in active community education and conducting various workshops. So these are the various achievements that the department has done. We have established a COVID lab. We have running the VRDL section. Besides, we have individual laboratories for different organisms. So this is the data that we have, the tests that we have done. As you can see, in the initial years, most of the focus was in for the COVID. But as the time has progressed, we have started to including a wide array of tests in our investigations. So we conducted a study wherein we actually saw that the increase in MRSA infections, despite the fact that COVID was here, increased use of PPE was done. So we noticed that although the total number of infections that we reported went down, however, the proportion of MRSA in those infections has tremendously increased from 60.5% in 2018 to 78.1% in 2021. A snapshot of what we have received in GMC Anantnag is, as you can see, the majority of the samples we still receive are pus and urine. Amongst them, Staph aureus has the highest number. It's more than 80% of what we have received. And as you can see, the cefoxitim, which is the surrogate marker for MRSA, has the highest percentage of only 15.8% being sensitive to cefoxitim. So what we are suggesting is that before all surgeries, essentially carriers have to be detected, because we have moved from a perspective where open laparoscopic surgeries were being done, and we are trying to minimize the hospital stay, the complications. So what needs to be done is that the surgeons need to collaborate with the microbiologist. Now, certain private hospitals have already initiated the process of screening all patients before surgeries, and it has proved wonderful for them. I guess we need to adapt this, because preventing infection is not just a protocol, it's a promise we actually make to every patient. Thank you.
Thank you, Doctor. Thank you, Dr. Tufel, for this presentation. So this is the lunchtime. Okay, the question answers will be during the lunchtime, because we are running short of time. With this, we come to the end of the first session, conclude the first session. Thank you all for your patient listening. Thank you.
Thank you, sir. It was a wonderful. Yes, sir. I would now Thank you, sir. Now I would like to request Professor Dr. Iqbal Salim Mir to felicitate our worthy chairpersons. Dr. Mumtaz Deen Wani, sir. Dr. Tashi Motap. Dr. Gulam Jilani Zargar. Thank you, sir. Now I would request Dr. Amir Yusuf Wani, Head of the Department of ENT, to felicitate our speakers. Speakers. Sir Dr. Rais Ahmed Khande, Dr. Adnan Rashid Mattu, Dr. Arshad Ahmed Baba, Dr. Yunus Kamal, Dr. Umar Yasin, Dr. Umar Yasin, Dr. Tufail Ahmed. Thank you, sir. Hands-on workshop has started in Hall C. Postgraduate residents and students and senior residents can register on the first come first serve basis.
Speakers. So we are waiting for the speakers. Moving on to the second session of the day, I would like to invite on stage our esteemed chairpersons, Dr. Mahmood Rashid, Dr. Anjum Shamim, Dr. Varun Dogra, and Dr. Nisar Ahmad Shah.
You are welcome. You are the guest host here. I am HOD anesthesia, so you are welcome.
Good morning, Our speaker is Dr. Gulzar Ahmad Bhatt, consultant and faculty, NB, Department of Surgery, SDH Kupwara. He is speaking on laparoscopic biliary tract exploration with clearance of stones by rigid ureteroscope. Dr. Gulzar, please.
Second session कहाँ पे? Where is the second session? हाँ second session है. इसी में Day-1 में. Second session ऊपर ही था. बाहर था. अच्छा ये वाला?
आपकी वीडियोस भी है ना शायद.
बस ठीक है.
यहाँ पे वीडियो नहीं है, मैं दिखा देता हूँ.
वीडियो बहुत बाहर हो रहा है. इसमें हो जाएगा अपने.
यहाँ पे ये सेकंड सेक्शन में मैंने आपका अलग रखा है डॉक्टर गुलजार, और इसी में आपका ये भी
प्रेजेंटेशन किया ना इसी पे. बस ठीक है. Assalamu alaikum and a very good morning to all of you. It's my pleasure to be here in front of you presenting video presentation here. So I congratulate Team Anantnag, Nazir sir for conducting this conference. So I am Dr. Gulzar, consultant surgeon and faculty at SDH Kupwara. So my presentation is laparoscopic biliary tract exploration with clearance of intrahepatic stones with a rigid ureteroscope. So choledocholethesis is reported in 3 to 22% of cholecystectomies world over, and complications, most common complications are cholangitis and acute pancreatitis. So biliary stones, as all of you know, are classified into cholesterol and pigment stones, and choledocholethesis is classified as secondary or primary stones. So going to the diagnosis is usually suggested by clinical history, examination and baseline investigations, but the definitive diagnosis is done by magnetic resonance cholangiography. You can do an endoscopic retrograde cholangopancreatography or EUS and intrahepatic cholangiography. So MRI usually is the most sensitive and routinely done. Endoscopic has an advantage of stone extraction also. So treatment of the biliary tract stones is the removal of the stones, and most commonly it is done by endoscopic retrograde pancreatography, and most of the stones, usually up to the 90% of the stones are cleared by this technique. But there are few cases where the stone extraction is not possible even after multiple attempts. In those patients, the option is surgery. Initially, it used to be the open surgery, open CBD exploration, but nowadays it has been almost replaced by the laparoscopic CBD exploration and at most of the centers. But this technique usually requires many gadgets and the expertise of the surgeons. So in difficult stones, what to do? If you are not able to extract the stones, what is the option? You can go for the lithotripsy. Although if flexible cholecystoscope is available, but most of the centers, especially the centers we are working at in the peripheral hospitals, sub-district hospitals and CHCs, these facilities usually are not available. And what to do at that time? So I would like to present a few of my cases which we have managed at Kupwara at sub-district level, where these patients had multiple failed ERCP attempts for extraction of CBD or intrahepatic stones. So we took those patients. I will be presenting two cases only here. So our first patient is a 41-year-old female who presented with classical features of choledocholethesis, especially actually already diagnosed as a case of choledocholethesis. She had undergone, went for ERCP, but they had 3 failed attempts of cannulating the CBD. So this patient, the baseline investigations were normal. Ultrasound showed choledocholethesis. CBD diameter was 2.1 centimeter, 21 mm. MRCP findings were consistent with USG findings, and patient had been subjected to ERCP, but 3 failed attempts to cannulate the ampulla as it was in deep in the D3. So it was an anomaly actually there. So this patient was worked up, planned for CBD exploration, and the exploration was done, but we were not able to retrieve the stone as it was a large, around 2 centimeters stone, impacted deep in the distal part of the CBD. So as I told you that this opening of the CBD was in D3, so it was very deep. So what we did, so we brought in a rigid ureteroscope and crushed this stone with a lithotrite and took out the fragments. Case 2 again was a 45-year-old female, and she again had multiple stones in CBD in the right ducts and the left ducts. She had underwent 2 attempts of ERCP, but they were not able to retrieve the stones. This patient was again worked up, planned for CBD exploration, laparoscopic CBD exploration, and CBD exploration was completed with using a uteroscope. So one thing I want to highlight here that while using a ureteroscope in CBD, it's not like in urology where you have a continuity in the system. Here, you need two screens to see and to cannulate the CBD. First, one is the laparoscopic view, and the other one is the ureteroscopic view. So I would like to play a video here. In this video, we have already gone into the CBD, and I think you can appreciate the stone there. So this stone is in the right hepatic duct. Most of the stones came out, the small stones came out with the flushing only. And this one stone, which was a large stone in the segment 5 duct, it did not come out easily. So we had to crush it there and take it out. So initially we tried to catch this stone with a tripong, but the size was huge. It did not come in the tripong, but one advantage was that the tripong broke it into fragments, and those fragments came out with the irrigation only. So these are the right segmental intrahepatic biliary radicals. You can appreciate the stone was impacted here initially, so there is a bruise. So we are looking into the other segments, the ducts, secondary ducts, trying to see that all the stones are out. Most of the stones came out initially with the irrigation only. So this one stone is there. We try to flush it out with the irrigation only. So that's why we are just, we have gone beyond this stone. We try to bring it out with the irrigation only, but it was not coming out. So what next is we brought in, I will just fast forward it for you. So now we are just trying to catch it with the tripong here. But the stone is fragmenting, and the fragments are coming out with the help of the irrigation only. So most of it will come out with this, but the core is hard and it will not, we are not able to catch it and take it out. So now what we did, we put in a rigid ureteroscope and a lithotrite to break it. So this stone is impacted in a small duct. So what we will try to do is to break it with the lithotrite. I think I have missed that in editing. So we have delivered a shock here, and this stone was broken into the pieces, and those pieces, yes, the lithotrite is in. So we will be breaking it and taking out the fragments. This is just this. I showed the only this stone here because otherwise it would have been a long presentation. Then the advantage of this using this uteroscope was to see for the distal clearance. So we put the ureteroscope distally, and you can see in one of the cases we were able to go as far as into the duodenum. So in this patient we did primary closure of the CBD, but the patient who had multiple intrahepatic stones, we had to add a drainage procedure in the form of docoduodenostomy, laparoscopic. Thank you.
Thank you, Dr. Gulzar. An excellent presentation and a unique experience, especially in peripheral hospitals, where we have limited resources and limitation of instruments also. I think questions will be at the end of the session, but we are interested in knowing, while negotiating this ureteroscope through CBD, there is any difficulty we encounter during because being a rigid instrument.
Yes, sir. If you have already planned to put in a ureteroscope, that time you have to modify the port position. It is not in the conventional position. The epigastric port is to be put at least 5 centimeters to the right of the midline, and for going up, you can go reverse the optical port and the functional port. You can put the ureteroscope through the umbilical port, and then. But yes, definitely there is, the angulation is there with the rigid ureteroscope, and it becomes difficult. One more thing which is very difficult is that you cannot maintain the pressure here. So what you have to do, you have to hold the coldocotomy with a grasper with your left hand. So you are working with a single hand practically here. One hand is for holding the CBD.
Right, thank you.
Thank you, sir.
The next presenter is Dr. Naveed Nabi. He is Assistant Professor, Department of Surgery, GMC Handwara. Topic is on silent gallstones. Should we operate?
Assalamu alaikum, and very good morning to all of you. Distinguished chairpersons, esteemed faculty members, and other illustrious colleagues. It's a real honor to be here at this prestigious conference. I'm bringing you greetings from Government Medical College, Handwara. I'll be talking about silent gallstones, should we always operate? So going into the background, the global prevalence of gallstones is 10 to 15%. If you zoom in to the Asia, which is considered to be a lower prevalence zone, it is only 4 to 5%. And as per the health technology assessment by ICMR, the prevalence in India ranges from 5 to 20%. But majority of the studies done on natural history of gallstones suggest that only 2.5% of the patients become symptomatic annually, which means 80% of the patients remain asymptomatic over a period of 20 to 25 years. And despite this fact, around 7 lakh cholecystectomies are done annually in the United States of America, as per the Digestive Disease Statistics 2021, and which amounts to a whopping amount of $9.9 billion annually. As all of you know that after the introduction of laparoscopy in 1990s, the Journal of Community Health, within a period of 4 months, showed 28% escalation in the cholecystectomies. As per JAMA 1993, the rate of cholecystectomies increased by 40% over a period of 5 years, which increased the annual expenditure by 11.4%. So coming to the natural history of gallstones, majority of the studies, as I already told you, in NEJM also, 1.3% of the patients only become symptomatic per year. Look at this. Asymptomatic patients, only 1 to 2% become symptomatic. Say, for example, biliary colic develops only in 1 to 2% of the patients per year. And in only 0.2% of the patients who develop infective complications, which we are worried about, like acute cholecystitis, cholangitis, or pancreatitis. But once the initial sinister has occurred, the rate of recurrent symptom development is 20 to 50%. This curve also suggests that the rate of symptom development in asymptomatic patients is roughly 1.5 to 2% annually during the first 15 years of observation. But after 15 years, look at the flattening of the curve. It means that after 15 years, the rate of symptom development annually falls to less than 1% even. So who is really symptomatic for gallstones? As we all know that laparoscopic cholecystectomy is considered to be the gold standard for symptomatic gallstone disease. But we need to understand whether it is a true biliary pain for which we are operating the patient or it's a non-specific abdominal pain. Rome's second criteria has given some features of true biliary pain. It is usually episodic, it is colicky, it remains for more than 30 minutes, and it has some accompanying features, maybe nocturnal onset, maybe associated with nausea and vomiting, or might radiate to the right inferior angle of scapula. Based on this criteria, a secure trial was done in 2019, which was actually published in 2019 in Lancet. We showed that the patients who fulfill the Rome criteria, if they undergo cholecystectomy, they have the best results. Post-operative results are the best in those patients. And another benefit of adopting a restrictive strategy is the number of cholecystectomies reduced by 7.7%. So we need to adapt a restrictive criteria while defining a patient for symptoms of gallstones. Then implications of the trial are that symptomatic gallstones might be an epiphenomenon. What symptoms we are considering are because of gallstones might not be because of gallstones, and we will subject the patient to cholecystectomy, and after cholecystectomy, the symptoms will be persisting. This is about symptomatic gallstones to differentiate between true biliary pain and non-specific abdominal pain. Now coming to the silent gallstones, because of the widespread of ultrasonography, nowadays we are encountering so many patients who do ultrasound for another disease and come up with gallstones in the gallbladder. Should we offer them treatment, and what kind of treatment should we offer them? We need to strike a balance between risks of treatment and potential benefits of the treatment. Why do we operate? Because we fear that he might develop complications. He might develop biliary colic in the future. He might develop infective complications or a gallbladder cancer. Once a patient listens about gallbladder cancer, he tells, no, I want to get operated. So what is the real incidence of these complications? About the biliary colic, I told you it is 1.5 to 2% annually. And about the serious complications, cholecystitis and pancreatitis, it is half of that, less than 1%. And the risk of gallbladder carcinoma is less than 1%. But this data of gallbladder cancer is from the West. We don't have our own data. In North India, probably the incidence is more. Now, if you offer a preventive cholecystectomy, what are the possibilities? The most dreaded complication which we fear is bile duct injury. And the incidence is 0.2 to 0.9%, almost equal to what we fear. We fear he might develop infective complications, but the risk of bile duct injury is the same, 0.2 to 0.9%, and more than 1% in Indian scenario. There is some data shown from SGPGI which shows 1% of bile duct injuries. And other complications are there always. Complications related to the entry, then mortality of 6 to 12% has been seen in injury to the IVC or aorta. Then duodenal thermal injuries, and then anesthesia-related complications. Another enigma is, as meta-analysis was published in Public Library of Science in 2017, we showed that cholecystectomy has a positive relationship with the risk of colorectal cancer, especially ascending and descending colon cancers, with a risk ratio of 1.22. Ethical complication, again, likewise, for example, in patients who have BRCA1 mutations, the risk of developing breast CA is around 80 to 90%. we offer them a prophylactic mastectomy, which is ethically justifiable. But the cumulative risk of developing gallbladder cancer in cholelithiasis patients is less than 1%. Is it ethically justifiable to quote this reason? Now, what should be our way forward? Our way forward should be a risk prediction model, which was published in Clinical Gastroenterology and Hepatology in 2023, so that we identify the patients who are at increased risk of developing symptoms and subject them only to the treatment. And it should be a shared decision between the surgeon and the patient, explaining all the complications. One of the remarkable findings in this risk prediction model was that the use of statins was associated with decreased risk of development of symptoms in asymptomatic patients. There are some established risk groups in which a preventive cholecystectomy is offered, like chronic hemolytic syndromes, transplant recipients, abdominal surgery for unrelated cause, diabetes mellitus and cirrhotic, again a debatable thing whether to go for it or not. Then the risk groups for gallbladder cancer, which is usually quoted in front of the patients, gallstones with an coexistent polyp. Yes, we should go for a cholecystectomy. Then stone size of more than 3 centimeters. Then packed gallbladder. Then Native Americans. And I have put a query on North Indian females because we don't have a local data that would support us. In Chile, which is a South American country probably, they are advocating a preventive cholecystectomy because the rate of gallbladder cancer there is very much. So coming to the conclusions, no doubt that laparoscopic cholecystectomy is the gold standard for truly symptomatic gallstone disease. But we should adopt a restrictive strategy to diagnose a symptomatic patient so that our long-term post-operative outcomes improve. So before hammering out a silent gallstone, risks and benefits should be discussed in detail to reach at a shared decision. Mark Twain has said, to someone with a hammer, everything looks like a nail. I think we should not fall in that category because some nails are sometimes innocent, which don't deserve to be hit. Thank you very much.
A wonderful presentation. We welcome you from Handwara. You're from Handwara.
Thank you.
GMC Handwara. So our sister hospital. So it was an elaborate and wonderful presentation. So let's bring on. Thank you.
Thank you, sir.
May I invite the next speaker, Dr. Akhtar A. Ganai. He is Senior Consultant and Faculty at NB JLNM Hospital, Srinagar, and he will be talking on the topic laparoscopic cholecystectomy in acute cholecystitis.
Okay. Good morning, chairpersons. First of all, I would congratulate Dr. Nazir for organizing a wonderful conference and thank them for giving me an opportunity to have a deliberation on laparoscopic cholecystectomy in acute cholecystitis. So as you know, early cholecystectomy for acute cholecystitis is being performed for a quite long time. Laparoscopic cholecystectomy can also be performed safely in patients with acute cholecystitis. Although some studies have shown conversion rate to open surgery higher than that of elective cholecystectomy, but there is no difference in the complication rate. Early surgery is technically more demanding and time consuming than late surgery in some cases. However, patients enjoy the advantage of less post-operative pain, low morbidity, and short hospital stay, since it is a single hospital stay and is not associated with higher complications nor higher conversion rate. Initial conservative treatment followed by delayed interval surgery cannot reduce morbidity and conversion rate of laparoscopic cholecystitis for acute cholecystitis. So early operation within 72 hours of admission has both medical and socio-economic benefits and is preferred approach for patients managed by surgeons with adequate experience in laparoscopic cholecystectomy. This is a case who was admitted with acute cholecystitis. Ultrasound was showing around 5 mm wall thickness with pericholecystic fluid. She was looking sick, her counts were high, so we thought we will go in. You can see how much pericholecystic fluid is there. Gallbladder was tenuous, wall thickness was around 9 mm. We deflated, there was a mucocele, and you can see the adhesions are really flimsy. They can be detached easily without much cautery. You can see how that deflation will make it, sorry. You can see easily without any bleeding or any cautery using any. You can see callus little edematous, but you can identify cystic duct and cystic artery nicely. Full critical view of safety was followed, and then gallbladder was dissected out using. There is another patient, female patient. Her counts were again high. We thought she was febrile. Gallbladder was on operative finding. The gallbladder was tenuous and gangrenous. Another patient, 45 years female. She was again diabetic with high counters, febrile, third day of admission. You can see ecchymotic wedged over common bile duct and the whole porta hepatis. But however, cystic duct and cystic artery was delineated separately and dissected out. You can see how gangrenous was gallbladder. So there is a comparison of videos. You can see this patient had an acute cholecystitis, somehow could not find a place in the OT for emergency elliptic cholecystectomy. She was operated after 6 weeks, but adhesions were definitely very hard, very tenuous, and she had pus within the gallbladder. We had to struggle on the catheters. You can see pus coming out of the catheters. And this patient landed into, we can say, is near total cholecystectomy. We could not find the catheters normally. If you see again a patient of, same patient with almost same age, same profile, but she found a place in the OT for an emergency cholecystectomy. You can see adhesions are very flimsy, avascular almost, can be dissected easily, and safe cholecystectomy performed. Again, here is another video. There is another video. This is a patient, male patient. Again, did not find a place in the emergency setting. You can see how dense and tough are the adhesions. The adhesions are very of the same, almost male patient with same profile, with almost same ultrasound findings, was operated in the emergency room. You can see how nice are the adhesions, how avascular are the adhesions. You can find the callus triangle easily, and you can have a safe cholecystectomy. These are patients of the almost same profile. Male patients, about 2 patients were female patients. These videos are showing the comparison, how easy it is to do in an emergency setting if you have OT facility available. This is our data, around 42 and 44 patients. early cold strain 42, 44. There was no statistical difference between the two groups. Total hospital stay in early cold strain was around 2 to 4 days. In delayed cold strain, it was around 5 to 9 days. Post-operative stay was 2 to 3. In delayed cold strain, however, it was 2 to 4. We had one biliary leak in early cold strain 1 and one conversion. Then was used almost around 50% in early cold strain and around 43% in. Port enlargement was around 30% and 20% in the group alternate. So what is our message? Our message is acute cholecystitis is being managed by early cholecystitis for a quite long time. Laparoscopic cholecystitis in acute cholecystitis is safe and has added advantage of minimal surgery and a single admission. Therefore, I would advise laparoscopic cholecystitis should become the standard surgical procedure for acute cholecystitis if you have available emergency OT. The way you are managing acute appendicitis, the way you should manage acute cholecystitis. So with an experience of more than 20 years performing laparoscopic cholecystitis, we believe initial conservative treatment followed by delayed interval surgery cannot reduce morbidity and conversion rate of laparoscopic cholecystitis for acute cholecystitis. Thank you very much.
Thank you, Dr. Akhtar. A nice presentation on operating in acute cholecystitis, usually a tough job for a surgeon. Thank you. I think questions will be at the end of the session.
No, that is what I am saying. If you have available OT,
yes,
you should treat him acute cholecystitis as acute appendicitis. Single admission and sincerely, we should see, if a patient comes with an acute cholecystitis, you have to understand. If a patient comes with acute and you think it is difficult, it will be difficult in the 6 weeks. Definitely, it will be difficult. See, one if it is mild acute cholecystitis, it will manage. But if you think the patient in acute cholecystitis is difficult, you operate them in the acute stage because it will be difficult at 6 weeks.
Yes, yes.
That was how I showed the comparative.
But practically speaking, a very tough job once we find a calot strangle is frozen and dissection is very difficult. Not so easy.
There are, see, that is what I am saying. There are situations I have shown that elective cholecystectomy, we could not go to the calots.
Right.
But same patient in acute stage, we could find the calots. There are there. You can have conversion rates. You may land into partial cholesterol, but that can happen in elective also, or that can happen in.
Definitely. I think the threshold for conversion in very difficult cases should be a bit lower.
Should be lower, definitely.
Lower.
Definitely.
Thank you. However, any other questions?
ये कैसे निकालेंगे? How to remove it?
Our next speaker is Dr. Adnan Rashid Mattu, consultant surgeon and faculty NB, District Hospital, Ganderbal. He is speaking on lasers and proctology. Dr. Adnan.
Day-1 section, second section. Adnan Rashid.
Good morning. Again, I'll be talking on laser proctology, the way forward. So what are the basics of lasers? Lasers is light amplification by simulated emission of radiation. A high energy beam of light that can be used to safely cut and burn the target tissue with absolute surgical precision. We use the diode laser, 980 or 1470 nanometer. Applications of lasers in proctology, we can use it for hemorrhoids, fissures, fistula, pylonal sinus. As we know, this is a very common disease with surgeons, anal fissure, fistula, hemorrhoids. So what are the procedures in laser proctology? This is a laser hemorrhoidoplasty. We use a 1470 nanometer usually beam. So this is the on-table result before and after surgery. The surgery took 10 minutes. This is a laser-assisted sphincterotomy. What we usually do, we use a laser. So laser is very precise, so there is early healing. A laser surgery for perineal fistula, we can do a laser-assisted fistulotomy, we can use a laser-assisted fistulectomy, or we can do a FILAC, what is known as fistula laser-assisted closure. So this is a sphincter saving procedure usually done in transsphincteric fistulas. Or we can do laser surgery for pilonidal sinus, which is called as SILAC, that is sinus laser-assisted closure. So why should we choose laser over conventional surgery? There's a greater surgical precision, it's minimal invasive, and a short procedure timing. Minimal scar, minimal blood loss, minimum post-operative pain, reduced risk of infection, minimal recurrence rate in experienced hands, minimal chance of complications, less hospital stay, can be done under local anesthesia even. So if lasers are good in proctology, then why the negativity around? Cost is higher than the conventional surgical procedure, lack of proper training facilities, and a learning curve. Certain myths around laser surgery, high chances of recurrence, high chances of stenosis, and lasers is just like electrocautery. So laser in proctology is in the beginning in our part of the world. When I was not doing lasers, patients used to come to me, do laser, I was telling them laser is not a good procedure. Now I'm doing laser since 2 years, so now I am telling them it is a good procedure. So laser versus cautery. Laser emits a control energy with the tip temperature of 80 to 100 degrees Celsius, while in electrocautery it is almost 300 to 400 degrees Celsius. So it is a non-contact tool, so minimal damage, and there is minimal collateral damage, whereas in cautery there leads to lateral spread of the current. Is it entirely safe? This is the brief, what almost 96 cases I have done using lasers. 78% had no complications, 8% had hematoma or bleeding, 4% had ulcer, 8% had abscess or a fistula, iatrogenic, 5% had recurrence, 2 had fissure, and there was no stenosis. Beauty is that these all complications were managed conservatively. None of them needed a second surgery or something. These are some on-table results of my patients. A grade 2 hemorrhage done by laser. This is another patient. This is a thrombosed pile with internal pile mass. You can see there is no external wound. That is the beauty. Another case of hemorrhoids done by laser. One more, almost grade 4 prolapsing hemorrhoids. Another patient. So this is on-table picture. Laser takes almost 4 to 6 weeks to act. So by 4 to 6 weeks, this residual swelling also goes. This is one of the cases in the beginning of my starting lasers. We try to use overzealous energy. So the more energy you use, so this is laser-induced burn all over the perineal area. This is a case of recurrent pilonidal sinus after a Limburg slap. So I did this almost 6 months back using a laser. So these are basic steps of a laser pilonidoplasty. We identified the TAC. We use skin punch biopsy forceps to excise the pits. Then we do irrigation using betadine saline and hydrogen peroxide. After that, we use laser fiber, which emits energy radially. So we are using a laser to close. At the end, we do cooling and a small pack is done, or an anal tampon is used. So this is the same patient after 7 days. After 7 days, I lost the follow-up, but telephonically he was doing good. So this is a basic tool how we do curettage in laser. I can't get it. So this is called a fistula brush. We use this is a simple brush we use to clean bottles. So this can be used to clean the fistula tract and the pylonal sinus. This is a video of classical laser hemorrhoidoplasty done in grade 2 and early grade 3 hemorrhoids. You can see there is no external wound. All the energy is delivered internally through the dentate, through the mucocutaneous junction. This is another case. We are excising the external pyelomass using laser. So people not doing laser will tell you are still giving a wound, but still this wound heals better than a conventional wound made by an electrocautery. And at least a patient done by laser, when he comes on the 7th day, he can sit on the stool during follow-up, whereas the open person does not want to sit down. So conclusion, laser proctology is a blooming branch, gradually being looked upon an alternative approach for conventional surgical procedures. We need proper training programs and we need inclusion of laser proctology in the curriculum. Thank you.
Thank you, Dr. Adnan. I think use of lasers in proctology is a field where there is a scope of lot of advancement and research. But one point of worry remains always there about recurrence in fistulas, hemorrhoids. Any study done in your patients which were operated?
I showed you almost 80 cases done by me. I have not published. You can see there is a recurrence rate of 8 to 10%. And that was during my initial 3 months of doing. And gradually when I started doing, I started seeing what wrong I was doing. And these recurrences were in the first 4 months. In last 6 or 7 months, I do not have any recurrence till now.
Sir, how long have you been practicing the lasers?
Almost 3 years.
Almost 3 years. Okay. So majority of complications, recurrence that comes after 2 years,
Yeah.
as seen in the research that has been done till today.
I'm still following.
Yes. So exact data will be available only after 1 or 2
Yeah,
years.
this is my data in 3 years. Maybe in future I'll see.
All the best, sir.
Thank you. So this is lasers. People asking why you do not conventional, why it is costly. So all of us, will you want to sit in this bus or this bus? So lasers is an air-conditioned bus.
Thank you, Dr. Adnan.
Adnan, I have a question. Although I don't know much about the proctology, laser proctology, but you tell me basically pyloradial sinus is basically foreign body granuloma,
Yeah.
if you can say properly. How you are sure you have removed the foreign body, number one. Number second, our motive should be to change the line, natal cleft, so that orientation of the hair will be changed.
Yeah.
That is right.
Dr.
Just-
Mukhtar, the session, question answer session should be after. We have kept it. You have come late, so
Okay,
that will be done
Okay,
later
thank
on. Thank you, Dr. Adnan. Our next speaker is Dr. Tashi Motub, Senior Consultant and Laparoscopy Surgeon, SNM Hospital, Leh, Ladakh. Gallbladder calculus disease in Ladakh, disease scenario, trend and development in its management.
ठीक है आगे. Respected Chairman Jakasi, Dr. Salim, Organizing Chairman Dr. Nazir, and Chairpersons. So, I am representing SNM Hospital Leh, and I extend my greeting, July, to all of you. The Leh, Ladakh, that is a land of endless discoveries. I will tell about my experience with the gallbladder stone diseases, the incidents, presentation, and the changing trend of the disease and complications related to gallbladder stone disease management and the developments in the management of gallbladder stone disease at Leh. So, gallbladder stone disease is the commonest surgical disease that represents around 1/3 of the hospital admission, and the incidence overall is around 28%, and the average gallbladder stone admission is around 1,700 around annually. Around 2% of the complicated cases of the gallbladder stone disease are seen, like CBD calculus, a complicated cholecystitis like lymphoma, perforations, and fistula formation, and gastroenteric are also seen. So, histological report commonly is the Zinker degeneration, but around 2 to 3% of the patients after every 150 to 160 gallbladder diseases operated, there shows malignant changes, and as Dr. Naveed in the same presentation said that it is around 1% in the West. So I have seen it in my around 25 years service. Around 150 to 160 cases you operate for gallbladder stone disease, and 2 to 3 patients turns to have malignant diseases. So, etiopathogenesis of the gallbladder stone at high altitude Himalayan region of Ladakh. The standard predisposing causes for gallstone disease doesn't fit there. No fat, fertile female arena. It is just lean, thin, and skinny, and not fair. Female patients are predominantly affected. And one of the studies done in Ladakh shows that commonly the legumes consumption and the increased intrahepatic biliary circulation due to transient disturbing the bowel transit habit in females, particularly residing in villages, are very common predisposing factors. And people in Leh Ladakh are found to have emulsified butter tea that also increases sodium intake, and the dry, cold, and poor hydration in the dry climate of Leh is also one of the predisposing factors, and chronic hypoxemia, polycythemia are also additional factors, and lack of protective element in the diet, fresh vegetables and other good trace elements or vitamins are also lacking in the normal routine diet, and females are more affected than males. So laparoscopic gallbladder surgical procedure at a hospital is a recently developed procedure for the management of gallbladder stone diseases, and nowadays we have taken it as a gold standard management for the gallstone disease management. So there is an evolution of management related to gallbladder stone disease. So initially it used to be the standard right hypochondric large incision followed by mini lap, buttonhole, keyhole surgeries, and we also have been going through all these procedures, and we have been refining our technique, and nowadays only the laparoscopic cholecystectomy is the standard procedure. So we have a very well equipped laparoscopic surgical operation setup. So initial state of anesthetizing patient, and we have the capacity facility of providing nasal intubation and sometimes awake nasal intubation too. Then after that placement of the 4 ports, then proceeding with the laparoscopic procedure and removal of the gallbladder with the stones. So these are the standard steps in the laparoscopic procedure when we perform. So I will just highlight one thing that in this last 2 to 3 years, I have seen a lot of changes in the gallbladder stone disease presentation at Leh, Ladakh. So it is mainly the children nowadays which are being affected too much, and I have seen these female patients around 10, 12, 6 and 14, 15 years predominantly affected with gallstone disease. So these are the patients, and we have performed laparoscopic procedure in children even 14, 15 years very successfully. And these are the patients who just 13-year female and having a lot of plenty of cholesterol stones, and only the factor in these children are that they are a little bit overweight and obese than the normal children. So these are the male patient affected with gallstone disease, and same female 16 year and more female patient. And the tragedy is that more and more younger patients are being affected. So it is also a teenage female that are being affected. And nowadays around 8 years female patients, 10-year female patient, 12-year female patient. And we have successfully performed gallbladder calculus management laparoscopically in as old as 68-year-old male and 12-year younger female patients. So these are the very, very tender aged patients who are having gallbladder stone disease, and we have done laparoscopic as well as keyhole, buttonhole colostomy surgeries. And here the last boy is having GB stone as well as choledochal cyst. So this the smallest child is 1 year 10 months. And recently, last month, I did laparoscopic removal of largest number of calculus. There is around 1,071 stones that is counted and authenticated by my staff nurse. And this is the young 46-year female male patient. And the largest gallbladder calculus is 5.5 centimeter that we have removed. So these are the patients. We perform in each OT around 7 on an average laparoscopic colostomies per OT. I get 3 or 4 OTs in a month. So this is one of the patient who is having a small biliary leak, and we developed a biliary stricture, and it was complicated, and we dealt with ERCP. So there is an advancement in the laparoscopy procedure we perform. We do appendectomy and a very good follow after 1.5 years. I removed this ovarian cyst, complicated, painful, and twisting ovarian cyst, but it's of benign pathology. So one more advancement is the performance of the nephrectomy for SEG-like non-functioning kidney that was painful and symptomatic. So this is one of the young patient still admitted in our hospital. He is having chronic hypoxemic exposure and sickle cell trait positive, and he developed spleen infarct. So next week I plan to do lap splenectomy. So there are a lot of challenges in the learning curve and your working scenario. So never stop learning and never afraid of complication, and be prepared for deal with the complications. Complications are part and parcel of your activity. So we develop a lot of biliary leaks, strictures, and I do manage them with positive attitude of Roux-en-Y hepaticogenoscopy. Sometimes ESCP also fails, and they also come with cholestasis, cholangitis, and severe jaundice. So these are the patients who come with biliary leak, stricture anastomosis, and follow-up with T-tube cholangiogram. This is one of the patients who developed gallstone ileus after cholecystostomia fistula. These are the patients with hepatitis B infection that we deal with cholecystomies. And these are the malignant diseases of the gallbladder presenting very complicated cases. These are combo surgeries, doing cholecystomy with ovarian cyst removal, cholecystomy with appendectomy, and cholecystomy with inguinal hernia repair. And these are the academic activity we do. We explore the possibilities of learning. And these are the continuous surgical medical education at Leh. These are our some guests, and Dr. Founder, President, Dr. Nisar, Dr. Fazil Pare, and Dr. Ganai, all are present in our activity. So this is a welcome to our guests from abroad, as well as our workshop activity at SM Hospital, and they are being blessed by our Guruji. So this is a meditation course for the guest. So thank you very much. all for patient hearing.
Thank you, Dr. Tashi. I think a 10-year period is a long period, and any comparative study done in about prevalence of gallstone disease in Leh compared to different regions of Kashmir Valley? Because in North Kashmir we have a high prevalence of gallstone disease.
Yeah, Kashmir, mainly this gallbladder stone disease in our setup is high in the fact that there is a unrelated predisposing factors. As I told you that fire, fight, fatal, and all this there are very less. But comparatively in Kashmir, I think population wise, the incidence of gallbladder stone is much higher in Leh than Kashmir.
My colleague has some ethical observation about slides. Just.
It was a wonderful presentation, absolutely wonderful. Your work speak volume. But I have an observation, and it is an recommendation that we should not show the identities of our patients.
Yeah,
in a
that in my previous slide it was all blurred and they were blurred and covered. So in a transfer of the from laptop to my pen drive, so it all disappeared. So I'm very sorry for that. Next presentation I will close it anywhere.
Thank you, sir. Thank you. Wonderful presentation.
A wonderful presentation from Dr. Tashi. Doing such wonderful surgeries in Ladakh, a far area, is commendable. Thank you, sir.
Thank you.
Thank you. Our next speaker is Dr. Shakib Nabi, consultant JLNM Hospital. He is speaking on TAPP versus TEP for inguinal hernias, our perspective. He has worked for he has a long working experience in North Kashmir at District Hospital Baramulla with us about management of hernias. Dr. Shakib, please.
Good morning to the honorable chairpersons, esteemed senior faculty, respected colleagues and dear friends. It's an absolute privilege to be standing in front of you. I would like to congratulate the organizing committee for organizing such a beautiful conference. As Mark Twain once remarked, it isn't what we don't know that gets us into trouble. It's what we know for sure that just isn't so. This is a sentiment that resonates with the surgical community rather well in an ongoing debate between TEP and TAPP. This topic has long been at the crossroads of laparoscopic hernia repair, one that continues to spark debate, guide decisions, and shape training protocols. So, TEP versus TAPP, a comparative review and surgical consensus. In an era where patient outcomes, surgical ergonomics, and evidence-based practice converge, this discussion seeks not just to compare the two procedures, but to explore where they diverge, where they align, and ultimately where our consensus as a surgical community lies. Groin hernia, as we know, it's one of the most commonly performed procedure by general surgeons globally. The prevalence of inguinal hernias is 27% in men and 3% in women, with risk increasing with age. Traditionally, open mesh techniques were primary, but laparoscopic approach in the form of TEP and TAPP emerged in the early 90s as minimally invasive alternatives. I remember when I was doing my post-graduation, this was a benchmark to assess the competence of a surgeon, how good a surgeon was doing a TEP or a TAPP. So the laparoscopic approach for groin hernias was introduced to the surgical community in the 90s. Gerb first described the laparoscopic hernia repair, and in 92, Arigui reported on the TAPP repair. So we all know the basic definitions and the anatomical approach for both the procedures. So in TAPP, it's for the residents. In TAPP, it involves accessing the peritoneal cavity, incising the peritoneum, placing the mesh, and closing back the peritoneum over the mesh. And in TEP, it's a completely extraperitoneal procedure, avoiding violation of the peritoneal cavity with the mesh placed outside of the peritoneum. TEP is considered technically more difficult than TAPP, but may reduce risks of internal organ damage and adhesion formation, issues sometimes linked to TAPP. So who can do it? Who do we call expert surgeon? For how long do we need proctorship? The learning curve is significantly, it impacts complications in operative time in laparoscopic hernia repairs. The EHS guidelines suggested a learning curve of 50 to 100 procedures. And Endo Hernia Society and Hernia Surge 2018 guidelines define expert surgeons as those with 30 to 100 procedures. Patient selection, which is very important. For unilateral hernias in male patients, TAP and TEP are comparable to Lichtenstein repair with low risk of post-operative pain and hematoma, though higher seroma formation and costs may take place. For unilateral groin hernias in females and bilateral groin hernias, laparoscopic approach is strongly recommended due to complete control of the myopectineal orifice and femoral region, and of course the ability of the surgeon to use same accesses for bilateral defects. Laparoscopic approach is also advised for recurrent hernias after previous open repair. Now, there are no absolute contraindications to doing a laparoscopic repair, except if there is some contraindication to general anesthesia. And while I was going through literature, all the relative contraindications to laparoscopic repair are based on the expertise and the stage, the stage of the career where the surgeon is. So, say for example, the age-old teaching is that newcomers should not attempt large inguinal-scrotal hernias. I was told, when I was learning, I was told, look for bubinoceles. So, relative contraindications mostly depend on where we are in the learning curve. So, patients on anticoagulants, they pose a relative difficulty for a newcomer, so it should be managed by somebody who is an expert. A patient with a history of a pelvic surgery, that can affect conversion rates from laparoscopic to open, and should only be managed by expert surgeons. Over the years, the laparoscopic approach has become the gold standard for the emergency treatment of many conditions, including appendicitis and acute cholecystitis. However, the laparoscopic treatment of incarcerated or strangulated groin hernias, one of the most frequent causes of emergency department access worldwide, is still debated. Latest WSCS guidelines are still cautious about this topic and suggested laparoscopic approach only in the absence of strangulation, and the hernia surge group underlined that no randomized study focuses on laparoscopic techniques in emergency. Now, there are some guidelines which we are following. The hernia surge guidelines for incarcerated or strangulated groin hernia recommend laparoscopic technique with mesh repair if the surgical field is clean or clean contaminated. Laparoscopy allows for direct inspection of the femoral orifice, and we can also explore the herniated viscera and see the viability of the bowel. TAPP is considered the best minimally invasive option for emergency inguinal hernia treatments for obvious reasons. We can check the viability of the bowel, which is very important, although TEP is gaining popularity for incarcerated femoral hernias. So this is a slide showing a TAPP procedure. I'm not going into the details of the procedures. Our idea is to, so this is a very common thing which haunts us in the outdoors, especially at the resident stage. So this is a decisional flow chart on groin hernias. Patients with bilateral hernias or unilateral hernias, if they are fit for anesthesia, a laparoendoscopic repair can be considered. And personally, in patients with BMI less than 30, with a direct femoral or obturator hernia, not an inguinal hernia, no previous abdominal surgeries, I would rather prefer a TEP. And in patients with BMI greater than 30, patients with complete inguinal hernias, previous abdominal open surgeries, I would prefer a TAPP. So this is some of the data which has been done in our center in the year, these cases have been done in the year 2022 and 23. So we were comparing a total of 132 were eligible candidates were randomized into two groups, TEP and TAPP. And the baseline parameters in in both the procedures were same, with recurrence at 1 year, 1 case in both the groups. If we see our results compare with the global data, major systemic reviews and meta-analysis have compared TEP and TAPP outcomes. Recurrence rates are almost similar. Early post-operative pain, chronic pain, and operative time generally show no significant differences. So my conclusion for this would be that TEP and TAPP are both established laparoscopic procedures with over 30 years of them being in practice, demonstrating comparable safety and efficacy. Evidence-based selection should be guided by surgeon expertise, patient characteristics, and available technology, not by our ego. Further comparative analysis or randomized control trials between TEP and TAPP may be unnecessary due to existing conclusive evidence. Thank you.
Thank you, Dr. Shakib. Excellent presentation. Any study done about recurrence rate in abdominal approach versus extraperitoneal approach in your case series?
Yes, sir. If we compare both, there is no statistically, even the global data shows there is no difference between the recurrence rate.
Right.
So in ours, we had a sample size, it was not a very big sample size,
Right.
around 160 cases over a period of 2 years. There was one recurrence from each group.
Okay. Is the learning curve different for the two procedures?
Yeah, in
I
TEP,
think
it may be
extraperitoneal
slightly,
approaches. Yes.
TEP at the start of doing laparoscopic hernia repairs, TEP would be slightly difficult vis-a-vis access. But I think eventually when a person does 20-30 cases from both the arms, I don't think it should be a problem after that.
Okay. Thank you.
Thank you, sir. Thank you.
Our next session, I think it is about panel discussion from 12 to 1. Thank you.
There is one thing that TAPP has a port side hernia. So I would advise to close 10 mm port side always before concluding the procedure.
Thank you. Thank you. That was indeed an enlightening session. To felicitate our worthy chairpersons, I would like to invite on stage Dr. Mashkoor Ahmad Beg, Head of Department Internal Medicine, Government Medical College, Anantnag. Dr. Mahmood Rashid, Dr. Anjum Shamim, Dr. Varun Dogra, Now, I would again request Mashkoor Ahmad Beg sir to kindly felicitate our speakers for this session. Dr. Gulzar Ahmad Bhatt, Dr. Naveed Nabi, Dr. Akhtar Ahmad Ghanai, Dr. Adnan Rashid Mattu, Dr. Tashi Motab, and Dr. Shakib Nabi. Thank you, sir. Now we shall begin with the panel discussion, for which the topic is management of groin hernias. Is laparoscopic surgery marching towards gold standard? I would like to call upon stage the panelists for this discussion. Professor Dr. Iqbal Salim Mir, Professor, is that it? Okay. To moderate this session, we would like to call upon stage Dr. Arshad Rashid Kema, Associate Professor, Department of General and Minimal Access Surgery, GMC Srinagar.
Can we have this remote?
Good afternoon, everyone. It's really wonderful being here. A great job done by Nazeer sir and his dynamic team. A wonderful job. Please give a round of applause, please. Okay. So, till we get our bearings right, are we connecting? Okay. So, this is a very interesting topic that has been allocated to me. It is management of groin hernias. Is laparoscopic surgery marching towards the gold standard? Are we on? Goa? Okay, fine. Thank you. So, to help me arrive at this, I have an elite panel. The panel who need no introduction, but it's my job as a moderator to introduce them. So first I would like to call upon Professor Iqbal Salim Mir, Chairman Jakasi and Head Department of Surgery, Government Medical College, Srinagar. I have been told that Professor Ejaz Ahmed Malik is on way, so I'm announcing his name, and I will request the other panelists to keep a seat vacant for him. Ejaz Ahmed Malik sir, Dr. Rajandeep Singh Bali. He is an assistant professor at the Department of Surgery, GMC Srinagar. Dr. Akhtar Ahmad Ghanai, a dear friend, a senior consultant and faculty NBE at the JLNM Hospital. Then I should say younger brother, Dr. Shakib. Please welcome him. Senior consultant and faculty NBE at JLNM Hospital, faculty NBE at JLNM Hospital, Srinagar. Okay, as I always say, I start with Ghalib because Ghalib gives us some ideas regarding things that we should know and that we should not know. शुरीदगी के हाथ से है सरोबाल दोष, सहरा में ए खुदा कोई दीवार भी नहीं. The relevance here is that in this uncertainty, in this desert of uncertainty, whether laparoscopy is the gold standard or open is the gold standard, this elite panel will sail us through this desert, hopefully safely. So esteemed panelists, distinguished colleagues and friends, it gives me immense pleasure to welcome you all to this focused discussion at JACASICON 2025. Well, all of you know that groin hernias represent one of the most commonly performed general surgical procedures. And whereas open surgical repairs like the Liechtenstein have stood the test of time, but definitely the advent of minimal access surgery has dramatically changed the surgical landscape over the last 2 decades. And today we are standing here in the morning session. Dr. Shakib was talking about TAP and TAPP, where we do TAP and where do we do TAPP. So here we'll be deciding whether to do a laparoscopy or to do an open repair, and you all are going to participate in it, believe me. So the questions remain: is laparoscopy universally suitable for all groin hernias to be called as a gold standard? And are outcomes reproducible across varied surgical skill levels and healthcare settings? So to deliberate this, I request you all to be kindly attentive to this, and request all of you to please, if you have any questions, please route it to me, so I'll be posing them to the panelists. So my first question, I'll go in that particular order. What are the current global trends in groin hernia repair? Open vis-a-vis laparoscopic. Dr. Shakib, you could take a mic.
Good afternoon, everybody. So, when Liechtenstein was for a very long time a time-tested gold standard for groin hernia repairs. So in 90s, when the advent of laparoscopic hernias started, there was a strong tendency among surgeons to compare any new procedure. So we're talking about the advent of laparoscopy here. So there was this inherent bias among those who were already doing very good with Liechtenstein, with those who had just started doing laparoscopic hernia repairs. So the comparison was between TAP, it didn't matter, we'll call them laparoendoscopic procedures, versus Liechtenstein. But as time evolved, as procedures evolved, as the techniques bettered, people got the idea of a myopectineal orifice, people got an idea of how hernia is not like plugging the small holes. So with time, I think if you're asking me what are the current global trends,
yeah, current trends.
The current global trend is that laparoscopy is at par as almost about a gold standard with when we compare it with Liechtenstein.
Let us discuss about the gold standard later, but as per the trend, as per the numbers, you believe that laparoscopy and open are 50-50?
Yes, I would say that.
Okay.
Yes.
Dr. Rajandeep, could I have your opinion, please?
Same.
Same.
It's all about feasibility. See,
Okay.
if you are in a setup where you don't have accessibility to laparoscopy, so you can't do it there. If you have accessibility to lap, you will do it. For me, hernia repair should be done at a center where you are well versed with the procedure, and whatever is the best standard there, you should go for that.
Okay. Professor Iqbal, sir, could I have your wise words?
Well, I would like to differ, okay? Because Liechtenstein was my thesis, and we were doing it under local anesthesia. What we have unfortunately done, we have taken away a procedure from our postgraduate curriculum, and we have put it into the consultant's basket to earn more money, to gain more experience, but we have to evolve with time. Yes, laparoscopy over the long period of time has shown us that the benefits far outweigh the risks. And certainly at this point of time, in 2014, the NICE guidelines were different. 20% of the surgeons were doing laparoscopy for hernias. And currently, I think it's around 50 to 60% of the surgeons are now doing it laparoscopically, because over the long period of 30 years, the results are so good that certainly I would advocate that yes, laparoscopy is a better form of procedure, considering what Dr. Rajan said, that you have a good surgeon, you have a good setup, and the patient is properly chosen.
So if we could have numbers from your side, what do you believe? Lab versus open? Trends, current trends.
Internationally, we are still looking around 40 to 50% is being done by laparoscopy, but in some centers where you have majority of the people, they can even be touching 80%.
Okay. Can I have the opinion of Akhtar sir? Akhtar sir, please.
Sir, if you talk of global trends, unilateral inguinal hernia, I think still anterior approach is being done more oftenly than laparoscopic. But few centers like, see, JLNM is almost, it is around 90% hernia. But we do sometimes open hernia if they are not fit for general anesthesia and to show out postgraduates. But I believe personally that if you have a
Sir, kind permission. I would like to request Ajaz sir to please join the panelists on the stage.
If you have a unilateral inguinal hernia and you think it is direct one, better go for a laparoscopy.
Okay.
Posterior.
Ajaz sir, we were discussing about the current global trends in groin hernia repair. This is a panel discussion on whether laparoscopy will be a gold standard in groin hernia or is it already marched towards it. So my question is, sir, what are the current global trends in groin hernia repair, open versus laparoscopic? What is your opinion, sir?
I think both the procedures are being done everywhere in the world. In fact, if you go to countries like England or US, even this time, you will see open hernia repair institutions.
Yeah, absolutely.
So they don't touch laparoscopically. But at the same time, laparoscopy since has got into the way of managing these hernias. So this would be one of the ways to manage hernias. There are definite indications where it is really good as compared to open like bilateral or recurrent.
We'll be coming to that. So as of now, what do you think the numbers? Open vis-a-vis laparoscopy. If we could have some sort of numbers from your side, what do you think globally? What are the trends?
Still high for open.
Still number is high for open.
Yes.
Okay, as all of you must be aware that groin hernia repair is globally performed in around 20 million patients per year. That's a huge number, 20 million hernia repairs a year. And there was a registry, that's an international registry going by the name of Hernia Med. 18,000 patients were evaluated, it was published, and out of those 18,000 patients, 60%, as our elite panelists were saying, 60% were done by Liechtenstein and 40% were by laparoscopy, either a TAP or a TAPP. We are not going into details, TAP or TAPP, we are just discussing laparoscopy versus open. And finally, a recent study published by the European Association of Endoscopic Surgeons, a survey was carried out and they said that they have gradually shifted now to endoscopic procedures with 60% going towards laparoscopy and 40% remaining with open. Okay, so definitely in Europe more than 50% groin hernias are now repaired laparoscopically. Okay, the second question, I guess Shakib in his talk talked about learning curve. How does the learning curve impact the adoption of laparoscopic groin hernia repair? Because we all agree that it's a bit difficult to do a laparoscopic hernia repair as compared to an open repair. Open repair is a resident's job, whereas for laparoscopy hernia you have to call a consultant. So I start from Akhtar sir. Akhtar sir, kindly, with your wisdom, what do you say?
Definitely, the impact on the procedure which a person will take laparoscopically will depend upon his learning. If you are taught in a center where TEP is done most of the times, he will adopt TEP. In centers where TAP is done, they will adopt TAP. I will tell you my experience. I used to do TEP from the beginning. But when I thought nobody else is going to learn it, I turned to TAPP because it is very easy to teach to the undergraduates. And since then, we are doing mostly TAPP than TEPP. You can see that from what's called Shakib was present, you saw 64 TAP and only 54 TEP. This is how your training will impact you.
So, Ajaz sir, what do you think is the learning curve of laparoscopy?
See, I'll tell you one thing. There are so many laparoscopic procedures where everybody has gone into. This is one of the procedure which is not being adopted by most of the laparoscopic surgeons in most of the hospitals. The reason being, you have to go into a space which has very low area of working. And then you have to make the space. This is not like peritoneal cavity or thorax, where you have hands-on, you can do everything. So there is a factor of learning curve more as compared to other laparoscopic procedures.
If we could have a number cases, how many cases would you suggest ideally for a person to be called a proficient laparoscopic hernia surgeon?
See, ideally, even in literature, people say that more than 100 cases you should be called that you are a good laparoscopic groin hernia surgeon.
Iqbal sir, could I have your opinion on this?
Well, it was 2003 and I ventured into this field. I didn't have any exposure of doing laparoscopic hernias. Videos were there, very poor quality videos, but the desire was there. We started with TAPP, and it used to take a good bit of time, sometimes 2 hours, and then understand we didn't have tackers. I'm giving you a real life scenario. So that time, 2 surgeons would do one procedure, me and my colleague. Sometimes I would do the dissection and he would just close the peritoneal breach. But we understood that this is the way forward and we stuck to it. Then came the TEP. Yes, certainly it's a lot better, a little bit more difficult. But if you go through a phase of doing a TAPP around 20 cases, then you shift to ETEP around 10 cases, and selectively choose patients for TEP, I think your learning curve within 30 to 40 cases will be over, and you will understand which patients to take by which route and what will be the result. And believe me, it's a very good procedure.
So Iqbal sir, you have actually introduced a new thing, the ETEP that you said. So you have used it as a bridge. You are telling the residents that it could be a bridge between TAPP and TEP?
For me, it was a reverse engineering.
Exactly, because it has started in 2011 or 12.
So, but we find that ETEP gives you a wider area of dissection. It gives the sword fighting that is normal in TEP is less by ETEP, and the negative thing is that the dissection is more.
Please, Ajay sir.
I think most of the laparoscopic surgeons who have ventured into different areas and want to take up hernias, I would suggest whether you do a TAP or you adopt TAP, try to do hernias which are direct.
Okay.
It becomes easier, and time taken is less. And you also come to know about making of space and then putting mesh, everything, rather than going into the inguinal area.
So definitely the first hernia laparoscopy that you do should be a direct hernia, preferably on the right side, preferably a young male, if I could put it like that. Yeah. Dr. Rajan, could I have your opinion on the learning curve?
Now, whatever I say, it will lead towards no one. Amongst the panelists, I would say they are elderly people. 3 of us are very senior amongst the panel. Na? So there's an age-old adage saying it's very difficult to teach an old dog new tricks. When I started doing hernia, I started observing people doing hernia in the Liechtenstein type, okay? I never did a Liechtenstein in my post-graduation time period. When I went to MAMC, there was a different thing. The only procedure done for laparoscopic repair of hernias was TEP. So we started with TEP. Dr. Arshad even started with TEP. So I didn't even see or observe or do a TAP procedure. I knew nothing about it. So for me, the learning curve was around 8 to 10 cases. After that, I started doing it free. Maybe Shakib will concur with me. All the 3 of them, they started from the Liechtenstein era, even from the Bessini era. So they have been learning new things with age. We, on the other hand, we started with the laparoscopy first. Then we had to learn the open system. So I think it is not open is bad or learning curve is more in laparoscopy, TPT, TAPP. It is it all depends on what you are well versed with at the end of the day. What you are seeing, what is being done in your department. Now see, nowadays they'll agree, it is very difficult to learn to do an open cholecystectomy rather than a lap cholecystectomy. We have residents, they'll be well versed with doing laparoscopic cholecystectomy. Anywhere between 10 to 15 minutes, they'll do it. But you tell them to even give an incision for open cholecystectomy, they don't know. So this learning curve, this is a diabolic type of thing for me. Because if you are learning laparoscopy from the beginning, now the worst thing about Dr. Iqbal Salim sir's unit is, they do not do open hernia. So you ask their residents to do open a hernia, it will be zero. Their learning curve will be very long. But you ask them to do a laparoscopic hernia, they'll be very cool with it.
Okay, Dr. Rajan. Let us not divulge from the details of the question. It's a simple, straightforward question. What is the learning curve for an average individual who comes, who sees, and when do you say that a patient, you will allow a resident to venture freely into hernia surgery?
See, the moderator is going to give us stats all of so many years, decades. Huh? So they'll say, okay, it is more for laparoscopic hernia, less for open hernia. I do not agree to that. I again say, your learning curve is exactly, it's a mirror copy of what your institution or what your guide is doing. Simple.
Okay. Dr. Shakib.
I concur with my previous panelists. If you're asking me a direct question about this learning curve, I think the EHS guidelines 2019, they suggest that 50 to 100 cases is required. And the LaproSurg group, they put it 30 to 100 as somebody who can be called an expert. I would just add one thing with what Professor Iqbal sir said. There has to be a structured mentoring during training about laparoscopic hernia repairs. I think most of us sitting here are either, there was no structured training, more so for these people. I always talk to Dr. Akhtar sir, we should have immense respect for them. There was nobody to teach them. So yes, Rajan is right, figures, stats may say something else, but there was nobody to teach Professor Iqbal Salim, there was nobody to teach Dr. Akhtar. Thank you.
Thank God.
But I can speak, okay. As I said, teachers can't be taught. But there are teachers who need teachers. Then there are teachers who are teachers of teachers. And there is always a scope of discussion on this. But if I say, if I have to give a certificate of credentialing someone as a laparoscopic hernia surgeon, I would be only giving him a certificate, I will only certify him as a lap hernia surgeon if, as per the EHS guidelines, he has done a minimum of 50 laparoendoscopic hernia cases.
So what is the learning curve for open hernia repair? You never said that.
I'll tell you. There is actually, the learning curve for open hernia has been discussed, and it was found it was 5 cases. It was 5.
When?
The literature says 5.
When?
Actually, see, whenever the open hernia cases started, first it started with Bassini. If you go back in history, it started with Bassini. Then Lichtenstein came, because Lichtenstein or Scholdice or, you see, many repairs came. And these were taught to residents. The open hernia cases were the bread and butter. Once we were residents, we were doing open hernia cases. And once we shifted to our age, our group of people saw a transition. The transition was from open to laparoscopy. And that is when actually it changed. If I say currently, if I have to train my resident in open hernia surgery, at least 5 cases he has to do before I can say that he is well versed with open anatomy. Again, if I have to tell him that he is well versed with lap hernia, he has to at least assist me in 25 to 50 cases before I say that yes, you can go ahead. That is the idea, basic. And it was actually started by Bittner. Bittner is a person who has done probably the most number of taps in the world. I remember in 2011, he published some 23,000 cases of TAPP. That is a huge number. And he actually has mentioned these guidelines that minimum 50 cases. Sir, you want to say something, Aja sir? Okay. So let's shift.
See, one thing I just want to add here. Don't get bluffed. What Dr. Rajan sir has said is okay, acceptable. But at the same time, just go to various hospitals. अपने ही यार दोस्तों को देख लो, कितने कितने अच्छे वेंचर्स किए, अच्छी लेप्रोस्कोपी की, कोलोरेक्टल किया, एब्डोमिनल किया, बाकी चीज़ें की. अब उनसे आप पूछो यार हर्निया क्यों नहीं करते हो? The first thing they will say that यार पता नहीं यार मुझे टाइम लगता है इसमें. It seems to be difficult. उसमें maneuverability नहीं है instruments की. This is the common thing what I have seen from most of the advanced laparoscopic surgeons.
I would just add.
Wait, please. Yeah. Can I have the mic on, please? Yeah. I would agree with Ajaz sir in saying this, that most people are reluctant in taking up hernia surgery because definitely hernia surgery is challenging because of space constraints. And I remember in one of the conferences, people were discussing about triangle of pain, triangle of doom, and someone was really saying, is it the triangle of doom in hernia? Please change its name to something much better, so that people are not afraid of taking up hernia surgery. And they were suggesting that Carrat's triangle should be named as triangle of doom, because obviously if there is a biliary injury, all of us know it is almost a death warrant. So, Shakib, you wanted to come in?
Yeah, I was just adding to what Dr. Ejaz sir said. I think Iqbal sir also agree with me. Over the time, the kind of paraphernalia used to do laparoscopy, I think the cost has lessened definitely. Like sir mentioned about ETEP. In ETEP, you literally require nothing. You can just use a polypropylene mesh and normal laparoscopic instruments. But yes, there is some paucity among surgeons, especially who don't have exposure to mentors. There is a paucity in accepting the procedure. For that, I think we have had discussions multiple times with sir also, that some structured program would be need to made for that.
So I guess there is some sort of mentorship or standardization of training that you want. Obviously there should be that, because for proficiency you need hands-on training, you need a proper mentorship. I'll come to Iqbal sir. In your practice, what are the definite indications where you would prefer laparoscopy over open, and conversely, where you would prefer open over laparoscopy?
Well, first I'll go to the open. First is, again, I'll go, what is your setup, what is your level of expertise, and what is your equipment like? Like if you have a single chip camera and you're thinking of doing a laparoscopic TEP, you will not be able to do it. So first thing is, you have to understand what are your limitations. If you have mastered the art of suturing, you can do TAPP. If you have mastered that area, Frochard's area, and you understand where the structures are, you can do TEP, fine. But if you have a hernia which is very large, which is a scrotal hernia, do not attempt it. You will struggle, you will have a lot of difficulties. Take it once you have reached a stage where you have done 100 cases. Then it becomes easier because you know how you have to manipulate the instruments. And even then, do a TAPP. Now if we go to open, if we have an obstructed irreducible hernia, the best possible would be an open procedure. If you already have a patient who has undergone laparoscopic TAPP or TEP repair, open would be a better, because a posterior repair is done. But once you're growing in your expertise, once you have that confidence and you have the backup, whether you have a bilateral hernia, you have a larger hernia, it doesn't matter. Then if you want to do a TEP or TAPP, it's an on-table decision. If you have a shorter space between the pubic bone and the umbilicus, ETP would be the best form of repair, because it will again not leading you to get irritated. The problem is irritation of the surgeon. जब वो टकरा जाता है इंस्ट्रूमेंट्स है ये कसा खुश कर क्या करना वो बताइए दिस इज एग्जैक्टली व्हाट हैपेंस एंड दिस इज व्हाई एग्जैक्ट पीपल डू नॉट लाइक टू डू इट
Ajay sir.
See, I am a proponent of both the surgeries.
Okay.
I have done so many open hernia surgeries that I have now modified it into a 1 centimeter. Most of the residents here who were my juniors here must have seen. I have reduced it to a 1 inch open Lichtenstein repair. With retractors, I try to go to the deep inguinal ring and also the superficial inguinal ring and try to do all repair. With just a stitch, no drain, and patient can be sent home. At the same time, I am a proponent of laparoscopy also, because we are having a minimal access fellowship.
Right.
And we have been doing laparoscopy. So we have to add on, we have to do this procedure also. We have done both TAP as well as TAP, but most of the surgeries in our case are TAP. Because I have learned from an institution where TAP was mostly done. That is what Dr. Rajan has said. It is the mentoring where you have been exposed to a particular procedure, then you try to do same procedure at your center. And people are also learned, we have done some studies also regarding hernia. What are the different modes, what are the different types of meshes, then mesh infection. But still in 2025, I can tell you that there are clear-cut indications for open hernia repair.
Yes, that's what I want.
You cannot omit it. I request all the residents in surgery to learn hernia repair open as well.
I want to hear those clear-cut indications, sir.
That is very important. See, once you have an obstructed hernia, you have a strangulated hernia, you have a complete hernia, you have a W obstruction hernia. There are so many indications of open hernia repair. And if a person is not well versed with anatomy of the inguinal canal, please do not go into this area. Because the inguinodynia, which is the only complication of open hernia repair, I have seen in some patients, it is so much terrifying and difficult to manage that I cannot explain it here.
Inguinodynia is more in, sir?
Open.
Open.
Open. So you have to be careful there. You have to know the ilioinguinal, iliohypogastric, all the nerves there. Do not cut even the superficial nerves.
We'll be coming to those. We'll be coming to the
So
complications
both the
later on.
procedures, I'm a proponent. I'm not against anything.
No, I'm not saying anyone is against. Okay, Akhtar sir, please take the mic.
Sir,
Could you please tell me the definite indications where you would prefer a laparoscopy?
Right. See, a unilateral inguinal hernia.
Okay.
The first thing is the patient choice.
Patient
if
choice.
Patient says laparoscopy, I will do it.
Okay.
Number one. Number two is if there is a recurrence after anterior repair, I will go for definitely laparoscopy.
Okay. Very good point.
To bilateral inguinal hernia, I would definitely offer a laparoscopic approach.
So a bilateral hernia, a hernia
Bilateral.
previously repaired by an anterior approach, recurred now.
Is will laparoscopy.
Okay.
Definitely. And a patient unilateral inguinal hernia, young male with a direct hernia.
Okay.
I would definitely offer him laparoscopy first. Direct inguinal hernia I have seen because recurrence, whatever is anterior approach, is from the direct hernia, not from indirect inguinal.
Dr. Rajan.
So for open hernia, it
Yes.
will be recurrent after laparoscopic. I will give him open approach. Unilateral inguinal hernia, indirect, I would give him an open but patient preference is the first.
Okay, Dr. Rajan, Akhtar Saab said about patient driven desire. Could you tell me about, is there a bias from academic surgery centers towards laparoscopy?
The bias is in the opposite direction. We would prefer to teach students open hernia as well as laparoscopic. For me, the first thing that comes to mind when the patient comes to me is, it's the patient's choice, as long as it's not endangering his life.
Perfect.
I got a patient from Ladakh. I told him, you will not be able to afford a laparoscopic hernia in the private sector. He said, no, you are nobody to decide for me. I'll manage, I'll get the money. So it's the patient choice. Second, if you have a recurrence, try the other procedure, whichever has been done in the first time. And then there are contraindications to general anesthesia or to pneumoperitoneum, which you have to follow. Nothing more than that.
Dr. Shakib, could you add on some things?
No, I think already enough said about
Perfect.
this.
I'll just give a bit of stats. Actually,
Bilateral hernias, recurrent hernias are preferred, but again, recurrence could be by laparoscopy, then you go in via the open approach. And there was a published consensus of guidelines in surgical endoscopy in 2020, and they found that primary bilateral hernias are recommended to be repaired laparoscopically. There was a 91% level of this coincidence between the guidelines. And what about females? We are not touching them, sir. We are being biased.
Lap.
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 Lap. Ajaz, sir?
I think I have two cases I have done, lap in female.
Okay.
And in fact, one among them was a femoral hernia.
Okay, perfect.
Femoral, I would give.
No, we don't know, sir. Groin hernia, groin encompasses direct, indirect, femoral. Sometimes we say it's a direct, it turns out to be indirect. I know you people were very blessed to be clinically good. We are not that much.
Hernia, I would prefer an open.
Open.
Open, it will be a small 1 or 10 mm incision that will be smaller than the trocar, 12 size trocar. But if it is femoral, I would prefer for a laparoscopy.
Dr. Rajan? Lap. Shakib?
Lap.
Well, as we have 77% here, so are the guidelines. 77% laparoscopy for females.
But I tell you, Akhtar sir does a very good laparoscopic hernia in females.
No, I am not doubting those things. That's why he is in the panel. Okay. So, regarding a resource-limited area like ours, our country is a developing country, what is the cost effectiveness of laparoscopic vis-a-vis open inguinal hernia repair? Is it scalable as a standard of care? Rajandi, please take a call on it.
Well, in the government sector, it is laparoscopies, they are both same because the cost is borne by the government. But if you think about a private sector, everything, lap is definitely costly. As for the initial investment you have to do, you have to get the machines, the instruments, the tackers and everything. Open hernia, I would rather not say. In UP, you can get an open hernia Liechtenstein done for $5,000. It's impossible to do it here.
Okay, Shakib. Shakib, please.
I think this question will encompass a lot of things, right from starting from training, Arshad. As I said that, there has to be a lot of emphasis on mentoring.
No, I think
surgeons.
I'll
come to that. I'll come to that. The thing is, when laparoscopy started, as Iqbal sir said, there were no tackers. Then there was problem of which meshes to be
currently,
used.
what you are having
Currently, I feel that we are already on that path where we're upscaling it to the level of a Liechtenstein repair vis-a-vis the number of cases. I'll tell you about my hospital. It's a small hospital. It's a resource-limited setting. But we had to make an effort to keep some open patients for students. But yes, the resource constraints which were previously, I think slowly they are coming down. People are not even using tackers now. They can use a simple vicarial suture to, even if they want to fix the mesh.
No, I am just talking about the cost feasibility. Ajaz sir, could you take a call on this?
You see, taking into consideration the resources available, the facility available at a particular hospital where you are doing it, and then the people's choice. Okay? Overall, laparoscopic procedure is costlier as compared to open. This is to be kept in mind.
Okay. Akhtar sir.
Sir, it depends upon the situation. See, in a place where the days of work matter, definitely laparoscopic will not be that costly. But if you are talking
That's a very important point, actually.
If you are
a very
talking
important point.
about our society, there is no, you cannot say much. But in a place where the days away from the work matter, laparoscopy is definitely a better option.
Can I have a final word from Iqbal sir on this?
Before that final word, I'll just share with you something.
Okay, sir.
There was a Westernite. I know him through some source. So we were together. He had a hernia. He is working basically in the this high sector, engineering sector. So we made him understand what is laparoscopic hernia repair and what is open repair. Ultimately, you know what did he do? He said that I want to go for open hernia repair.
That's a good thing.
There are two things. At the time of the surgery, laparoscopic hernia repair is costly, and we are making it costlier. A mesh which used to cost 15 into 15 mesh, 3,600, what we have done, we have gone to the 3D meshes and they are costing 14,000. Now tackers, of course, majority of the people have stopped using them. TEP, you don't need them. TAPP, one suture is more than enough, but open procedures, the mesh costs around 1,200 rupees, and one vial of, you can even do it under local anesthesia, which is not possible by laparoscopy. But what Dr. Akhtar rightly pointed out, the days of the work, certainly for an open procedure, the days of the work, they are more, and this was one of the factors in my thesis, that Lichtenstein's repair, the work days off are less, because you're doing it under local anesthesia, and there is no tension in the inguinal canal. So that is one of the factors. If your patient is a breadwinner, better give him a laparoscopy.
There was a trial, there was a study published by Mishra sir, and he concurs with most what you have said. Initially, the laparoscopy is more expensive due to equipment and anesthesia costs, but indirect costs like the sick leave and days of work, they offset the costs. Sir, I'll go to next question because I can't.
Last point, one
Okay.
more point I want to share with you, because most of the people are working here in periphery. I tell you honestly, we have seen so many recurrent cases of hernias which have been previously operated by laparoscopy.
So that's unfortunate because I will always believe recurrences are not due to the procedure. Recurrences are the proper problems of the surgeon. He should be properly trained. Definitely patient factors do play a role, but I think proper training and proper mentoring cannot be justified. It cannot be justified. The recurrences.
Arshad, one last question about the previous question. you were
I think we can
discussing.
discuss that later on because I have paucity of time.
Okay, we can move ahead, please.
Okay. I go to Iqbal sir. What is your experience vis-a-vis literature as regards to advantages, disadvantages, and complications? Laparoscopy versus open.
Well,
speak about advantages. Let you talk about advantages.
Discussed about the advantages here. Certainly, the days of the work, the pain is less, vagara vagara, all that cosmetics, fine, that is all. But the complications are more. Definitely, complications are more. If you are not well versed with the anatomy, you have to know where the inferior epigastric artery is. You have to know the circle of death. You have to know whether you should tack or not. And then how are you using the instruments? If you are using a lot of cautery, that patient will have post-op pain. But what we have surprisingly seen, the inguinodynia that was being claimed as a major factor for not doing laparoscopy is less, and it is substantiated in literature that open procedures, because of the exposure of the nerves, you're going directly into the inguinal canal and you're exposing the nerves. The inguinodynia is more in open procedures. So I would say overall laparoscopy certainly scores over open procedures, and it should be if you are doing it properly.
Ajay sir, what about the recurrences? Because you spoke about recurrences.
I think both procedures are nice, no problem. But what I have seen in the hospital, the complications of laparoscopic hernia are very high. And one of the most important complication what I have seen is, and which was with difficulty manageable, is the mesh infection. You know, in tap and tap, you put the mesh retropubic. So portion of the mesh which gets infected, whatever the way you adopt laparoscopy again, you adopt open procedure, still the portions of mesh are still there. And you have a recurrence of sinus or fistula. I have two patients this time on follow-up who have been operated. One has been operated 4 times, another is due to the fifth procedure.
Okay. Akhtar sir, could you tell me about the seromas? Where do you find them more, open or lab?
I think lab has more, and we have observed TAPP in indirect inguinal hernia has a large number of. Here I would add, there are many complications, intra-op complications, but not reported. See, in the early phase, vast injury has been very common, but nobody reports them. Port side hernia is very common in what's called TAPP. That's what I advise you. You should always close it. Mesh related gut obstruction. We have faced one patient. We operated. There was a space. Then we had to refer that patient to the SMHs. We had a patient with gut obstruction. These are added than what is called in open. Seroma is definitely higher in laparoscopy.
Well,
we are putting a drain, JB drain,
in all
some,
hernias?
in some hernias, and we have found the propensity of developing this seroma is very less.
Okay. Dr. Raj, you want to say something, sir?
I do not agree here. The thing is that it is, once you're dissecting between the two layers of the fascia transversalis, that is going to weep. And it's going to weep more in direct hernias because the sac is usually larger. So if you use a good pressure dressing for the first 48 hours, you will not require a drain. It's not advisable, I would say, to put in a drain in such situations. Seroma will be there. Important is that the person, after he develops a seroma, goes to a surgeon who understands that this is a seroma. Because I have seen patients, unfortunately, being labeled as recurrence when they had seroma. So seroma is, there will be no cough impulse. That is the most important thing. And within a span of 2 weeks, it will go.
Well, speaking idealistically, in a utopian world, laparoscopy is better than open because a patient doesn't get too much pain. But what we have seen, laparoscopy can have disastrous complications, absolute disaster.
Shakib.
I think the advantages of laparoscopy are obvious, as have been already stated. I think the only disadvantage would be the previous slide, the costing as of now, and the longer learning curve for surgeons.
Okay, let me move to the next question because prayers are around.
There are a lot many learners
Right,
in our institutions, medical college institute. So be careful. Once they are learning, they do a lot of dissection.
Absolutely.
It is better, we have found it, two things can reduce the seroma formation. One, what Dr. Iqbal has said, putting a pressure dressing. Another one is once you are taking the pseudo-sac, you just take it and tack it. And third is putting a drain.
Currently, sir, I will just say to the esteemed panelists that we are not discussing the technicalities of the repairs. We could discuss them later on. As I am saying, both groups have set of inherent advantages, disadvantages. Like you can do an open and a spinal, and a local. You can't do laparoscopy. Recurrences and complication rates are absolutely similar. There is no difference in literature. But chronic pelvic pain is high. It's very, very, very high. It's almost 20% in open hernia repairs as per a recent study by Krokenberg. And it's only 4 to 6% in laparoscopy. This has been reported recently, sir. Again, I know I will draw a lot of flack on this question. Laparoscopy in emergency groin. Yes or no? Simple. Please take the mic.
There's not a lot. I think I mentioned about...
You say no. Yes or no?
Yes. No, not for now.
No. Ejaz sir, no. Akhtar sir? No. Iqbal sir? Big no.
I don't want to answer this.
Dr. Rajandeep?
No.
Okay. I somehow do agree with you, but a recent meta-analysis published, in fact it's published ahead of print only, it's not in, it's only on online version, it's not in the print. They said of 1250 cases they evaluated and they were saying the TAP is better, but I do not agree myself.
But this is why I said that I don't want to answer.
I do not agree myself. Finally, as a panel, can we arrive at a position statement? Is laparoscopy the gold standard today for groin hernia repair in 2025? Or does it remain a strong alternative in selected hands? I have attached a QR code. Please scan it. You can participate in the live poll, which will be broadcast it shortly. I will start with Shakib. Shakib, what do you say?
If I leave emergency part out of it, yes, I would go for it, yes.
Yes. Rajan, yes or no?
No.
No. Iqbal, sir.
The question is it a gold standard?
Look, we are having the
No.
polls already.
No, it's not a gold standard, but the discussion itself that is being held here with this line in mind, that is it the gold standard, means that we are going to look at it, and after 5 years, 10 years, certainly the idea will be different.
Okay. Ajaz, sir.
Yes, presently it's not a gold standard
Sure.
and
I'll
there is no perfect guideline, okay? But in future, yes, it may change.
Akhtar, sir.
That's why there is no.
The question was marching towards gold standard.
Oh yes, it is marching towards gold.
Marching. I am not saying it's a gold standard. Marching.
Marching towards gold. Definitely.
Okay. Can I modify my statement? Marching?
Yes, it
Because
is
the topic was
towards-
marching.
It is marching towards gold standard. There's no.
Rajan.
I actually. I actually have a
Look, the
problem with
percentages
this.
are changing rapidly.
Yes, yeah. I actually have a problem with this gold standard thing. This thing should not be there.
Okay.
Thing should be standard of care. See, you say laparoscopic cholecystectomy is the gold standard for cholecystectomy, okay? But when you are in trouble, then you go back to open cholecystectomy. So how can it be gold standard? So nothing is perfect. This gold standard thing is not good.
Okay.
Does it remain a strong alternative in the selected hands?
That is the question, sir.
Yes, it is gold standard in selected hands. Every laparoscopic surgery is gold standard in selected hands. And that suffices the purpose of what Rajan was saying.
Okay, are you agreeing, sir? You are agreeing that in selected hands it is marching. I have heard not your vote, sir.
It's marching, and 5 to 10 years, we will have a different perspective, and we'll be again discussing it in a different forum.
Okay. So,
what does the audience say?
What does the audience say? It's there, sir. It's in front of you. I have to agree with the audience.
We are not getting it here.
No, I know, sir. Dr. Sanjay is scanning. He wants to vote.
Okay, he wants to vote.
Ajaz sir has also scanned.
Naseeb sir could also scan, sir.
Okay, as of now, 47% audience says no. So, 35% says yes. 18%, like me, undecided. No, sir, it's undecided is a separate option. Sir, undecided.
That is a swing vote.
Undecided means that they are not taking it as gold standard. Finished.
Sir, Wapis?
I think we should not make these gold standards, because when we fall, then we have a very difficult time to protect ourselves. I think it should be standard of care, yes, agreed. But I think you can march towards a particular, more standard of care rather than a gold standard. Yes.
Okay, you want to say, sir? Iqbal, sir, please.
Let's now try to finish. Because
because prayers are around. Okay, no is 50% now. So we are more with no. But I have to tell you the guidelines, I have to tell you the literature. Laparoscopy is the preferred approach for bilateral, recurrent, young acute patients where expertise exists. Very important is that expertise had to exist. Otherwise, don't do it. Open Liechtenstein remains the standard for primary unilateral hernias in resource-constrained settings. To the skeptics of laparoscopy, I would just say it's not the technique. That's the problem. It's the training. It's the training.
Doctor said the panel was not good. Panel was not good because we concurred on everything. We didn't have any.
There was no fight.
There was no fight. How can it be?
We
You'll
can
have to
always
start
have a
something.
cordial panelist. We can always have a cordial panelist. So I could only say, to conclude, I would like to say laparoscopic groin hernia is marching, but it's not a gold standard as of now. Very important is to understand training, standardization, and surgical audit are absolutely crucial to ensuring patient safety and outcome. Laparoscopy has a benefit as regards to chronic inguinodynia. I have put it as a separate conclusion because I know I myself was not convinced with this. I had to go into literature, so that's why I put it there as a separate conclusion. Ladies and gentlemen, I would like to thank you all. And I would like to thank the organizers of this conference for this wonderful presentation. Thank you so much. I'd just like to conclude with one statement that I always say whenever I talk about hernia. A hernia repair cannot be idealized. We cannot have an ideal hernia repair. It needs to be individualized, tailored to each patient, tailored to each person, tailored to each situation. Thank you so much.
I congratulate you for carrying out this nice panel discussion.
Thank you, sir. Thank you, sir.
You need to learn something from Arnab Goswami, huh?
I am learning from you.
Thank you. That was indeed a riveting discussion. I would like to invite on stage Dr. Sanjay Kumar Bhasin sir to felicitate our esteemed panelists. Professor Dr. Iqbal Salim Mir, Professor Dr. Ejaz Ahmad Malik, Dr. Rajandeep Singh Bali, Dr. Akhtar Ahmad Ghanai, Dr. Shakib Nabi. Now I again request Dr. Sanjay Kumar Bhasin sir to kindly felicitate our moderator for this discussion, Dr. Arshad Rashid Kema. Thank you, sir. This conference so far has been a vibrant conglomeration of experts and their acumen, and there's still much more to look forward to in this conference. But before that, we shall be having a lunch break. The lunch will be served at the catering area outside. The lunch break will last for an hour and a half, and the presence of our esteemed delegates in the hall is anticipated by 2:30 p.m. Thank you, ladies and gentlemen. Please enjoy your lunch.
Who basically envisioned surgical gastroenterology in our part of the world and managed to train people in that, who started his own method of doing this Whipples. May I invite Professor Dr. Umar Javed Shah for his lecture, Journey of Pancreatic Surgery in Kashmir. I'll rename it, if I may, sir, with your permission.
Thank you very much. It's a pleasure to be with you all, the stalwarts of surgery here. We have very senior faculty from Jammu region here. I can see lot many from Kashmir, and I can see my dear faculty also around, as well as our students also around. The best part of my life has been my students. Okay. The story of this journey, which Professor Salim Iqbal started with just on the mic, dates back around my whole life, in fact, as a surgeon. I joined SKIMS in 1984, and then I went on doing residency, and then senior residency, and then I shifted to medical college, GMC, for another registrarship, and then became a lecturer for 2.5 years. Then due to circumstantial pause in between, I had to go back to SKIMS. And I still remember Dr. Nazir Mir and Dr. Munir Khan. We shared the room together. They didn't want me to go to SKIMS, but I had to join. So the story started from 94 in SKIMS, 1994. I joined as a, now what we call as assistant professor there. And I was lucky enough to be there amongst the best people. I joined with him. I had a long run with him right from 1984. He was somehow related also to me, and he was my guide also. And he was a stalwart, one of the best surgeons I have, whatever limited experience I have. Seeing others also, very less people I have seen operating. I rate him number 1 in my life. And it was from his, inspiration doing surgery on the pancreas, what initially in the early 80s I saw him doing. He had just returned from England, and he was fantastic. There was no doubt about it. So probably he is the man who initially inspired me to go ahead. And the best part of this great man was, if you were on the right track, if you were doing the correct thing in life, he would allow you. Otherwise, he would stop you. That's what we call professionalism. So that started with Professor Vani. And it was always like that, initial days of life, that think big, always. And of course, once you think, you dream big. And finally, you believe in big, and your results are big. So this started like that very early in life. And once you think big, dream big, challenges come, especially when you are starting your career. Those of you who take the challenges, they reap the benefits of challenges in later part of their life. And this is the only way of growth, the proper growth, what we call, not the abnormal growth. Then came a period in 1999. I was sent by the SKIMS that time. I was in general surgery. I was sent to GB Pant Hospital. There were 2 stalwarts there that time. Both are living right now. Dr. Sareen was there on the hepatology side, and Dr. Adarsh Chaudhary was there. I went there for a short course with them to learn portal hypertension surgery, because we used to refer patients from this part to that center usually, or to AIMS, where Dr. Nandi used to do a lot of work, but they had a huge waiting list. So Dr. Others had a long series, as well as Dr. Shiv Sareen. They used to do these cases very efficiently. So I was a part River cuts through the rock, not because of its power, because of persistence. This persistence keeps you going, especially the surgeons. You end up in a very bad situation while operating. But those of you who pass that bridge of persistence, they usually come out with success of the procedure. And then pancreas, what we started, I still remember, Ejaz is here. I did my first Whipples, independent Whipples with Ejaz in 1997. And that was a great day for me because our stalwarts had gone to Delhi for a conference and we were alone to do it. So he told me, should we go ahead? I said, yes, we go ahead. By that, the time had matured enough for this procedure. And we know the story of Whipples. Everybody has gone through it, whosoever knows Whipples. First stage, two stage, need not to be talked here. And of course, the thing is that there's a big series by Cameron. This is a study.
This is 42-year study. And this is quoted all over the world. And John Cameron is still living in Baltimore. Of course, he has retired long back. 2,000 cases from 1969 to 2012. Morbidity, look at the morbidity, 45%. And mortality came down to almost 1.6% in later part of, let's say, last 15 years. But there has been a lot of struggle in getting this morbidity and mortality down. Next, please. And it's because of this, many surgeons abandoned this procedure because of the high morbidity and mortality. They used to say that it was a nihilistic approach. But since then, previous one. Since then, a lot of improvement has occurred in surgical technique as well as post-operative care. So the mortality has come down from 25% to less than 2%, and especially at the high volume centers, while morbidity is still high, and that has remained unchanged. That is our target where we got to do. But then again, this has gone through a lot of strategical work, especially with the physiological selection of patients, preoperative staging, imaging, technical improvements, as well as pre and post-operative management of these cases. This sort of work, once we were traveling in the schemes, it was in 2005 that the Department of Surgical Gastroenterology got its inception in that part of the world. A small team of hepatopancreatic biliary surgeons was identified and were made responsible for the work. And within a very short time, I would say within, I think, not more than 5 years, it became a referral center, especially from the Kashmir Valley, as well as from the adjoining areas, for most of the pancreatic and hepatobiliary work. And that time, it's a much earlier slide. More than 70 research publications came out from there, and most of them were international publications. And we started our postgraduate courses for doing DNB. Here I would mention Professor Nandi came himself that time, and he gave 2 candidates for DNB surgical gastroenterology in 2012. And we trained quite a bit, I think around 20 who are working all over the country right now. Some of them are here also. I can see 2, 3 are here in Medical College Antnag, and some of them have gone off now. I have been very fortunate to select myself, some person in Jammu Ames, Sahil. He's selected there as an assistant professor. He is there. And some of them are in South. They are working. They are doing good work. And it was later a part of my life. Once I was the director as well as the dean, I took the opportunity that I said that, no, let us relinquish the DNB course. Let's go for MCH. And lucky enough, again, others came in between. Others was very, focused. I told him he was that MCI chairman was his close. He told me, take this opportunity. He's an actor, basically. He makes things happen. So he told me, you get it. So we got 2 seats for MCH, surgical gastroenterology. Next. And look at the cases spectrum. This is an old, actually, about 8 years back slide. You can see the proximal splenorenal shunt, almost 130. I think you can add 1 or 2 more in that. And then portal hypertension, I can see Manmohan's thesis was on portal hypertension. It was almost 500 cases. We did that. And then here I want to mention the, what you call it as 2 procedures. The pancreatic procedures, and they are almost 600 cases. And phrase, you can see 200 cases of phrase, pancreaticogynostomy. I don't know where is that pancreaticoduodenectomy. So, thoda sa adjustment karna padega. I think that was also almost that time 290 cases. I think I got involved later part of my life at Medical College, Srinagar. I think I assisted or did a little more than the other person. I think 5 cases. Next slide. Give me a few minutes more, I'll conclude. And why it happened, necessity is the mother of all inventions. It was necessary for us to do something here in this part of the world and to make the procedure popular. Next slide. And we published some very good papers. So the volume increased, we had to do these cases. So we published the superior approach technique of pancreaticoduodenectomy. This shortened our time, this shortened our blood loss, quality of the work improved. I used to do 2 Whipples, some of them who were doing with me, 2 Whipples within 4 hours or 5 hours time. And that was the story. We used to finish by 3:45, and everybody would leave, especially the anesthesia people were very happy to do that. Next slide. And this is the technique. I don't want to get into this detail. Next slide. And next slide. Next slide. And then we saw the evolution from a low volume to a high volume in it, where we got the mortality, morbidity down with the passage of time. Next slide. And this is the low volume, previous slide. Low volume, medium volume, and high volume. We went on to doing 40 to 47 cases in a year in a high volume unit, and there were few people doing that. We didn't have much of staff. I think Dr. Sadaf was with me. She used also to do sometimes, and I was the major. This is the data with me in my mobile right now, with names, MRDs, and everything there, and dates also, including the numbers, contact numbers. Dr. Mujtaba is in contact with most of the follow-up patients, and we are seeing a great survival in this technique. That will come later in, probably we'll like to publish that. Next. And this was the mortality, morbidity. And most of the pancreatic tumors were pancreatic adenocarcinomas, ampullary, and distal cholangiocarcinomas. Next. This is a very good study, actually. We should have time for this. Next. This you can see the time duration, as well as the blood loss, as well as the complications, morbidity, and mortality. We had very less mortality. It was around 2%. I still remember 7 patients I have lost in my life. I remember their names. I remember their everything. Last night, I was just traveling to Srinagar. I was at Delhi airport. I was in the flight, about to take off. I received a message from Dr. Atri that I am doing this head transection. Portal vein is exposed, and I'm proceeding. He said it. I just was taking off, and they are these days very strict in cutting off the mobiles and other things. They become overcautious. I told him just preserve head and do a pancreaticogynostomy. I landed, he had sent a message, he has done the same. I was the happiest man. This was a 9-year-old child because I did a mistake in my life. That patient died. That was in 1997. I lost a patient like this. He was from neighboring area of institute. And he was a 27-year-old boy who had been hit with a, what you call it as a kick while playing a football. Somebody had kicked his abdomen. I had a transection. I did a Whipples on him. We got a post, I don't know Ijaz members, he got a fistula. I think he died on 27, 28th day. So that mistake, I saw that this person didn't do it. And that's what is important in your life, to bring your mistakes back for the next generation to learn. I was so happy. I was looking for Atri today here. He was not here. Anyway, next slide. And this is the downing the blood loss, duration, and blood transfusion. Next. Next, fistula. Next. This was another study. I will not get into that. Next slide. Next. So anyway, this is a technical thing. How did we centralize the issue? Because we are centralizing certain areas in the country. Dr. Shalish and myself, we are writing something on pancreas, asked by some organization to write it, how to centralize these procedures. So we are on that center. This is the slide from there. Next. This is the hub and spokes phenomena. Anyway, next. I then finally will speak on this. Once I retired, I was talked by John Cameron's, one of the fellows in America. What's his name? He's in New York. He was just taught. He's Christopher Wolfang. I was chairing his session from PGI Chandigarh, me and Shalish. He said that, have you retired? I told him, yes, I have retired. He told me, what are you going to do? I told him, I'll just enjoy my life. He told me, go back to your school. So that's what I did. This gentleman requested me to come to medical college. I was very happy to be with them. So that's how it happened. Their series came. They're doing fantastic work laparoscopic. You should see them doing laparoscopic surgery. And you will be amazed to see pancreatic duodenectomy being done in my lifetime here, where we started. I had a laparoscopy in 2010. I gave it to my colleague because my focus was open. Because laparoscope was not up to pancreas till then. I had calculated it. But then again, he gave me an opportunity. His team gave me an opportunity. Dr. Mushtaq Chalku, Dr. Salim, Dr. Atri, all his team, Arshad, my own Samuna, everybody, fantastic surgeons. I have seen them doing good work. Next slide. And this is his team. This again, I think 3 years back. Photograph. Next. Anyway, next. And these are their cases. 53 cases in a short time. Calculated, MRD, age. Kisne kiye hain, kya nahi kiye hain. I think I figure in, 6 or 7 cases with them. So this makes me beyond 300 cases in my lifetime. So it could be not 300. Triple century is very difficult to do. Only very few people in test cricket have done. So I had done 290 odd. It was because of them. I crossed in my lifetime. And that's what I can enjoy right now. This is their work. But then one thing, one message I want to tell you, you are the leaders here. This is a very new medical college, an upcoming medical college. So many young minds here. Remember, you must know why these birds are flying in a V-shaped form. There must be a reason in the nature. Next slide. This V-shape is because of they create currents on the sides. The youngsters are always in the front, in the back. They feel it easy to go. Less of energy is needed. This is teamwork. Next slide. Next slide. Huh? And like the geese, we must know how to go together. We can make our journey very easy and success will be yours. Next slide. Next slide. And you know the journey of a surgeon is very tough. It is but the river finds its way. Next slide. It may be difficult, but the river finds its way. Next. And once you are tired, reflect, rejuvenate, and what you call it as do it again. These are the slides from Professor Jagannath. I must admit it. These slides are from Sir Jagannath. These basically were by Avinash Rupe, who had been to Ladakh. So this is Jagannath I have stolen from him. The future of pancreatic surgery lies in borderline tumors, local advanced tumors, and of course minimal invasive surgery. There is no but. Laparoscopy. Open is not the procedure now, except in certain, I know Sanjay is here, liver transplant can't be done with that as yet. But robotics, of course. Robotics on the right side of the pancreas, because of the vascular resections, precision, left side will be dominated by laparoscopy. And this is what I said. This is Swamika Vivekananda's. Things must of necessity be slow. And that's a fact. Next slide. And remember, old soldiers never die. They just fade away. You should have seen Douglas MacArthur in World War II when he was brought back from Vietnam area. He didn't want to come back because he had lost many soldiers. Thank you very much.
Thank you, Professor Omar Saab. It has been a very nice, educative, and a lecture with full of words of wisdom. We could have listened to you for a long time, but I think there are time constraints. We are already running short of time. Those of you who have some queries, want to some consultation from Dr. Umar Saab, I think you can have that during tea time or otherwise. We thank you again, sir, being with us and guiding us. And now I will request Dr. Sanjay Goja, who will be talking on management of cholangiocarcinomas. Dr. Goja is director and lead liver transplant at National Health Group of Hospitals, New Delhi. He will be talking on a very, very treacherous tumor, I call it, which can just be a cause of pyrexia of unknown origin or may come as a obstructive jaundice, and people may be baffling, and the tumor may have already metastasized. With these words, I will request Dr. Goja to stick to the time so that we can finish this session within time only. Thank you very much.
Just 1 minute. Okay.
I take this opportunity of welcoming Dr. Madhumita, who is the secretary, who is the treasurer of ASI, to this conference. Dr. Madhumita, a big round of applause for her. It's not easy coming to this place this time, so it takes a lot of guts. So we must appreciate that also. Thank you, ma'am. Thank you for coming here.
Good afternoon, everybody. After listening to such a wonderful talk of long journey, a treacherous journey, and inspiring journey of Dr. Umar Javed, my close friend. This may look like we're a little less than that, but it's okay. We are all on the journey. So I will be essentially talking about the cholangiocarcinomas. What we are looking at is not, there are issues in the cholangiocarcinoma. We don't look at the cholangiocarcinoma like the way we look at the gallbladder cancer or the liver cancer. They are different tumors, they have different prognosis, and they need different sort of mindset and aggressive mindset. Because if you can take out the hilar cholangiocarcinoma patient, the survival is nearly 40%, 5-year survival, 20 to 40%. So they are the ones you should never turn your head off from them. Just go aggressively after them. As you know, cholangiocarcinoma is a tumor of the bile ducts, and it can be from the top to the bottom. Although they are the tumors of the bile duct, but different places makes them prognostically different. Whether it's intrahepatic cholangiocarcinoma, hilar cholangiocarcinoma, and lower end CVD carcinoma. Lower end CVD, Dr. Umar Javed has talked about. You need a Whipple procedure. Intrahepatic cholangio is altogether different ballgame. What essentially we see in the study is the hilar cholangio. So patient comes with the jaundice, he has fever, he has multiple drainage. They have tried ERCP. We don't know what to do. and it goes with the classification like the stricture only, the same guy, Bismuth classification, that how much is the hilum preserved, because it determines the extent of the surgery, type of the surgery, the likelihood of involvement of the vessels. It is like that. It is type 1 to type 4. If it is type 1, it is CBD more than 2 centimeters margin up, less than 2 centimeter margin up, involving the right ductal system, involving the left ductus, and involving the both. Why is it so difficult when we tackle hilar cholangiocarcinoma? If you go to this picture, right down there, it is all intricate web of vessels, blood vessels, portal veins, biliary tract. It may seem that is simple, but every time there are variations. Bile duct may divide early, there may be multiple branches, there may be accessory ducts, then portal vein may have multiple branches. So one needs to be very proficient in the biliary anatomy to handle these tumors. And these tumors are fibrosing tumors. They will cause a lot of stiffness and likelihood of encircling the portal vein. When we look at the hilar cholangiocarcinomas, what we essentially look is it resectable? The first management in the hilar cholangiocarcinoma is surgery. So the resectability of the tumor is very, because it determines the prognosis of the patient. So we have to make sure, first we have to determine whether it is resectable or not resectable. After resection, we go for the other modalities of treatment. Whether it is nowadays immunotherapy, chemotherapy, but overall, all the hepatobiliary surgery, all of you, they are not very chemosensitive tumors. So what we see in when the patient comes, they are usually in the sepsis. They have some sort of drainage. So control of sepsis is a very important thing when managing the hilar cholangiocarcinomas. So preoperative cholangitis, we have to see that they are on the proper culture sensitive and antibiotics. Okay. Then what is more important when you plan the surgery, what type of surgery you are planning. It is also very confusing when we see the CAVD, whether we have to resect right side of the liver, whether we have, how much liver we have, whether we need at all the liver resection to do. These are all. We have to see the remnants of the liver volume, and we don't do here ICG clearance, except ILBS does for the academic purpose. We don't do it, the Japanese ICG clear. We don't do ICG clearance here. What we essentially look is the future liver remnant volume, which is by the CT scan. And we usually aim at around more than 40% of the future remnant volume. Before surgery, we cannot do any liver surgery. If you see the Makuchi's that algorithm, anybody who has more than 3 grams, there's more than 3 bilirubin, he cannot have more than one segment resection in the liver because they will go into the liver failure. So we have to make sure that bilirubin we bring down. How will we bring it down? There are different modalities, where it is by ERCP. Usually they are hilar cholangiocarcinoma. They will not be doable by the ERCP. You have to do some sort of percutaneous biliary drainage or endonasobiliary drainage. Nutrition is very important in these patients, and nowadays we see what is most important, because they are chronically debilitated, they are losing bile in the PTBD, they are malnourished. Nutrition forms an important role in the preoperative management of the hilar cholangiocarcinomas. So how we do is, we do first imaging. After imaging, we assess what is the extent of the tumor. Then we do the biliary drainage, try to bring out the. Never do volumetry when liver is cholestatic, because cholestatic liver is distended. It will give erroneous values. When the bilirubin comes down, then we do the CT volumetry, and we aim, as I said, we aim at the future liver remnant volume of more than 40%. As Dr. Umar said about the pancreatic surgery, and the godfather of the cholangiocarcinoma is Nimura, Japanese Nagino, and he is the king of the cholangiocarcinoma. They are the ones who have advised all what should be done with the cholangiocarcinoma. Their evolution has been evolution of the surgery for the cholangiocarcinoma all over the world. All over the world, whether there are surgeons from US, IMED, UK, all have gone, including me, and visited him. And we need to see how the system works, how they operate, to see actually how cholangiocarcinomas are done. You see, it has been over the years, the evolution of the surgery. They used to do PTBD, now they do endonasobiliary drainage because of the infection part of it. Then over the time, the nutrition has taken a main hold of pre-operative management of these patients. And of course, in initial days, they would do abdominal angiography, and it has now, we have MDCTs or triphasic MRIs. So how does it look like it is? I mean, your liver, this is like, how does it look at the hilum? And when we resect it, it's just a pictorial depiction of it. So what actually we are aiming in the surgery of the hilar cholangiocarcinomas? Actually, we are aiming at tumor-free resection, like any other any other tumor. So hilar cholangiocarcinoma being adjacent to the liver, and it is over the caudate lobe. So what actually determines the resection-free margin of a tumor? Whether it is 5 mm, whether it is 1 centimeter, whether it is 2 centimeter, and these carcinomas, they have a tendency to grow sub-epithelially, sub-endothelially. Even if the epithelium is normal, because they are fibrosing tumor, the fibrous tissue seeps inside the bile ducts, and the margin, you may seem to be, it is normal, it may not be normal in the biopsy. So every time we have, when we are doing, we have to do frozen section biopsy to see that resection-free margin at least 5 mm is there. But there have been instances where longitudinal margin has been between 6 to 2 centimeters. So actually there is no certainty. But to bring this certainty, the liver resection, advisability of the resection has increased over the years. That is why we do, it is not tumor of the liver. Still we do liver resection. Why? Because we do for this thing only to gain the resection-free margin. This is the Kaplan-Meier analysis. It depicts if you have resection-free margin, survival is going to be better. But one very important thing is that even if you have R1 resection margin positive, it is exceptional in cholangiocarcinoma. Even if on the final biopsy, resection margin comes positive, still the survival is better than not doing the surgery. It is, I think among all the tumors, it is only surgery where even if resection margin is positive, it is advisable to do it because the survival is better than not doing the surgery. So what type of, you should do surgery, whether you should do right hepatectomy, left hepatectomy, it depends on the site of the tumor. If it is 3A or 4 tumor, we do right hepatectomy. If we do is 3B or 4 tumor to the left side predominant, we do left hepatectomy. But when do we do extended, majority of the hilar cholangiocarcinomas we cannot do by simple right and left hepatectomy. Important thing, we land in doing extended right or extended left hepatectomy. Extended right is more common because the length of the right left hepatic duct and left portal vein is long. So the likelihood of getting the resection-free margin without liver resection will be higher in right extended hepatectomy because the left duct is longer. I hope you are getting my point, what I'm trying to say. What about the caudate lobe? I mean, the same numera advised that we should be doing caudate lobe because, you know, there are like 8 to 10 caudate lobe ducts which drain majority on the left side of the duct, but some drain in the right side of the duct. But there are a lot of anatomical variation, and we don't know which caudate duct it is going on. So it is nowadays a standard practice. Even if we're doing right hepatectomy or left hepatectomy, we have to do caudate resection along to prevent recurrence from the caudate ducts. And the results are obvious. If you have a caudate lobe resection with or without, obviously the survival is better with the caudate lobe resection. Then second, you know, like any other malignancy, we look at the lymph nodes. You see, if we have a gallbladder, we have aortocaval lymph node, it is distant disease. If you have a HCC, you have a portal lymph node, the prognosis is different. Does the same stand for cholangiocarcinoma? It doesn't stand. Initially, people will not do lymphadenectomy. Now, more data has come from them only. The lymphadenectomy, hilar lymphadenectomy helps in the cholangiocarcinoma surgery. The survival is better. I mean, these are now guidelines. We have to do lymph node clearances also. The evolution of the surgery, as again, so it comes from the same center. I am quoting it saying because this is the gold standard worldwide of this center. And whatever they say, you have to listen to them. Whole world listens to them. So the survival over the years, the resection for the cholangiocarcinomas, the extent of resection has increased. the adventures in the hilar cholangiocarcinoma surgery have increased. We are doing more and more complicated patients. We are trying to do arterial resection. We do portal vein resection routinely. We are doing cable resection, but whatever is involved, do it, because the survival is better than resected group. This is one reference. It came from the Germany, Peter Neuhaus group. I mean, they thought that when you do cholangiocarcinoma, don't touch cholangiocarcinoma, because if you do dissection around with the right angle, it will disseminate this one. So they have a technique which is called a no-touch technique. So they will do distal control, proximal control, and don't touch the part of where the hilar cholangiocarcinoma. So obviously, if you are not touching that part, every surgery has to have portal vein resection, because then you have to separate portal vein from the bile duct. Their theory is don't separate from the this portal vein from the duct, do routinely portal vein resection. But there are not much takers of this technique over the years, because that liver transplant, as it advanced, living donor transplant, people have become technically very advanced, and across Japan, every Asia, we are not doing this routinely. Vascular resection is something which is, I mean, if you have CHGB, you will always hesitate not to do, because the patient is not going to do well. Pancreas, we are doing more and more, but we don't know how much it is going to help. But there is enough data in cholangiocarcinoma where vascular resection really helps and people do well. This is one of the, how we do this is a proximal and distal end of the portal vein, and when we anastomose, it should look like a C type. There should be no tension on the portal vein. It should be bleeding. There should be a good growth factor. This is one of my cases. I mean, I have a video of that. If the time allows, I will just play it a little bit. So just 1 minute only. So hepatectomy with simultaneous resection of the portal vein hepatic artery for advanced hilar cholangiocarcinoma, over the years, it has increased. And what is the advisor? If you do the vascular resection, there are higher chances of R0 resection. Although without vascular resection, the survival is better, but still it is better than not doing anything. And it has to be in a high centralized, that what he said, spokes and hubs type, it has to be centralized. Then there came once, I did 1 or 2 or 3, but it was that ALPS procedure. If the laminate is not, we will divide, we will ligate the portal vein and then come back and do after 8 days. But after 8 days, every patient went into sepsis and nearly didn't make it. And I remember clearly 3 patients I did, and post-op they didn't do well. But then came the paper that it has a septic complication, and it is not the procedure which should be followed in the hilar cholangiocarcinomas. I mean, you can see the data, it is the survival is not that. Then there is the liver transplant. Do we need do liver transplant? More and more centers are now saying that we should be doing liver transplant for the hilar cholangiocarcinomas. So there is a technique which is called Mayo's technique, where we put on the neoadjuvant chemotherapy, radiotherapy. If it is unresectable tumor, we do transplant. The criteria is we have to be 100% sure that it is cholangiocarcinoma. So likelihood somebody has a primary sclerosing cholangitis, the likelihood of cholangiocarcinoma is high. So majority of the patients who undergo liver transplant from the cholangiocarcinoma are for the PSC only. Exclusion criteria is just like any, if you have extrahepatic metastasis and patient is not fit for the surgery. And it has to be graded. It has to be external beam radiotherapy, brachytherapy, chemotherapy. After that, we do diagnostic labs, see that it has not spread. But many people don't reach that stage to undergo liver transplant. Obviously, if you have unresectable hilar cholangiocarcinoma, transplant will have a better survival. And that they are for the unresectable tumor, and more patients across the world for unresectable are going for the transplantation. The summary, hilar cholangiocarcinoma is the most common malignant tumor affecting extrahepatic bile duct. Surgery is the mainstay of the treatment. Aggressive surgical approach with R0 resection is the aim, but even if you do R1 resection, that is good enough. Extended liver resection and caudate resection should be standard procedure. Extensive resection, vascular resection, combined liver resection, ex situ resection, they are at the advanced centers where we do living donor liver transplantation. Thank you very much.
Thank you, Dr. Sanjay Goja. You make this liver resection look like a lab coli. Speaks volumes about the experience that you have and how simply you are doing a wonderful job. Thank you very much, sir.
Thank you, sir. Thank you.
Now, may I
ask the audience to give a ovation to our guest of honor today, Professor Shaukat Jilani, who has been the principal of this college. And he was my head of the department. Thank you very much, sir, for coming. And founding principal of this college.
We now request Dr. Mushtaq Chalku, Professor and Head of the Unit, Department of General and Minimal Access Surgery, GMC Srinagar, well-known figure, a stalwart of laparoscopic surgery. He'll be presenting laparoscopic ripple surgery, the technical aspects. Excuse me?
Present Dunbar first.
You'll
Because
present
the next-
Dunbar?
Yeah. This time.
Okay.
Then next.
Okay.
I
So
will
please
present-
stick to the time. That would be fine.
Not take much time.
Thank you so much.
I'll directly go to the surgical aspects because that's what we require. We all are doing great job. Thank you, sir, for accepting my talk. And all of you, it's an honor to have all the teachers and stalwarts. And I feel honored to stand here. Now, why did I choose this as a presentation? I am 15 minutes, right, sir? Thank you. So I will.
13 plus 2.
Huh? Sir.
13 plus 2.
Huh? 13 plus 2. Sir. The idea to present this is because most of us understand and know that medial orchid ligament is a very ubiquitous thing. It takes quite a bit of understanding of the anatomy of these ligaments, as all you understand. Orchid ligaments are not there only in. I was confusing it with the umbilical ligaments, medial umbilical, lateral umbilical. That quite often happens. But orchid ligaments are in the joints and they make the disposition and architecture of aortic orifice, which lies at T12. So, by the way, I would just request and invite all of you. Most of us are doing this research work, and I have taken over for the last 8 months as a chief editor of this journal. So I will try my humble way to help all the papers that come to me as a reviewer, editor. So it is also a good journal linked to a good indexes are there. So I think that's for the promotional aspect, all of you. I'll inshallah try my best to push it in. If there is no good novelty and rareness of the case, even the charges could be exempted. So my thing was that it's a caged coin and needs a liberation by the blade of the blessed. So I think roads might be different. You might go by an open way or a closed way, but doesn't make the difference because the target is same, and there's no debate about that. As long as you are reaching the same target, that's how we differ, and we should respect each other's opinion, differences, and ideas. Now, just a point about what exactly makes this ligament is, the aortic orifice is the most posteriorly situated on the orifice. And this median orchid ligament makes the anterior architecture of this aortic orifice. And laterally, you have the medial orchid ligament, then you have the lateral orchid ligament. But median is the most important because the surgical importance of this syndrome, where this queen gets caged. Now, why this queen gets caged is because, I hope it's not working. Is it working? So, in my post-graduation, I just saw this syndrome but could not understand it. I just knew there's a syndrome like this. But it takes an age, as you understand, to know and understand a thing. But sometimes you understand, but you don't get a case, so you pass virgin. But thankfully, we got 3 cases in 1 year. 2 of them were referred to me from this hospital only by the gastroenterologist. And 1 we did on our own, reported. It's a diagnosis of exclusion. You don't jump to make a diagnosis. That is the important thing. And that, thankfully, to Dunbar, a radiologist basically around 64, he probably took it to the clinician that there could be a syndrome like this. And so CT angio, ultrasound, Doppler, or you can even have MR angio is the diagnostic of this condition. but clinical suspicion is important. How many of have this suspicion? A young age boy or a girl, predominantly girls, more common in females, 1:3, comes to you with, should I hear? Should come, and you will find, yeah, you can point it. Okay. Okay. It's okay. One of my postgraduates, I told him to present it as a poster. I hope he has presented and he has made a good work here. The important thing is that the queen gets caged because it is T12L1 where anterior branch, the first abdominal branch is the celiac trunk. And if it is a high origin or there is a lower investment, the decussation fibers of the right and left crust, it creates a compression. And this compression steals the blood. So your liver, your stomach, your mesentery is involved. So this is sometimes called as abdominal angina. So when they take food, pain starts. This is a classical, here the suspicion comes. You take food, you get pain. Because you need more blood. You need more blood. There's a steal. There's a stenosis. So that is the classical. So they keep on losing weight. They keep on vomiting and other things. This is a classical suspicion. So that's how you could do. Thankfully, we have published close to 536 videos of all kinds of surgeries. I would request all of you, I'm sure you will not waste time to go. We do a lot of this work. It's a very unpaid and thankless job which we have been doing. I'll just go to with the permission of chairpersons. If the time is there, I'll show you a small video. This is one case which came to us probably, don't know, it was 45 one or the one, which one? Yes, 18-year girl. 18-year girl referred to us. This patient has gone even to psychiatrist, endoscopies, CTs, gone to a psychiatrist, put on antidepressants, only saying pain, pain. Now the question is, one fine day she went to radiologist. It is a radiologist's domain. No wonder Dunbar is a radiologist who got us to us. Just a salute to him that this could be fought. So our ports will not make much into the ports. We go by 4 to 5 ports. I'll just go hurriedly to let you know where exactly is the problem and where should we go. A lot of precision is needed. So I am exactly at the superior border of pancreas at station 9 where celiac axis comes up from aorta. You are, please understand, you are 2 centimeters here down. So your precision has to be very quick. So the left gastric, the radiation of the celiac trunk, you have all the 3 vessels there. Now art lies in holding your left gastric. If you know the art of holding left gastric by your left hand, you will reach aorta. Aorta has to come to you rather you going to aorta. Because otherwise you will require 45 this laparoscope, or you may probably need a deflecting laparoscope. Since we don't have that, we have a 30 degree. So I would say that please make your left hand to do a little bit of exercise. So what are you doing? It's a coronary vein, left gastric vein. I will take this Krishner's membrane in a caudate way. I will remove it. Now I am entering the hepatogastric or lesser sac superiorly, not inferiorly. The idea is this is the best approach. You have an infragastric approach also, but the best way to reach is supragastric. So my dissection continues. I'm holding the left gastric pedicle up by my left hand. This is the superior border of pancreas. Now from here we have to go to dissect to the anterior surface of aorta. Now dissecting should be very precise. Anatomy has to be in mind. Your cameraman has to be in line. And it is a total wed situation between you and your cameraman. Before that, please don't go to this precarious area. You are seeing the right crust. I hope you can appreciate. You are seeing the right crust. I am dissecting at the same time, making sure that I keep my left hand up. Now, I have reached to the decussating fibers of the right and left crust, where the problem lies, which is nothing but the anterior notch of the this is nothing but the median orchid ligament. So I'm holding the fibers of the crust. Now, slowly you can appreciate that something is coming out. This could be probably the celiac axis. We cannot jump to say it is celiac axis. We go a little more ahead and remove this tissue, what is called, you can see the splenic artery is beating down on the superior border of pancreas. Left gastric is on my left hand. I am trying to go deep down. Now you can appreciate this is where I'm touching is the celiac axis. But here the question is the left gastric artery will move up. Common hepatic will go onto the superior border towards the right side. Splenic is here. This is splenic, and it is probably sitting on the superior border, moving to the tail. Now here the question lies that it becomes difficult here to go beyond, because your instruments in laparoscopy cannot deflect. That is the problem. So here the art lies in your left hand. Hold as much it up as you can. Be sure you will not cut the left gastric pedicle, but hold it up as much as you can. Go down, deep down, and study the anatomy of this condition. But you should be very clear that what you are doing is that you can slowly appreciate this is splenic, common hepatic on this side, which I am showing, left gastric going up. Now appreciate we are going down. As we go down, what will come? Celiac axis. It is just 0.5, sometimes 1.5, sometimes only 1 centimeter. Then it trifurcates, Mercedes-Benz, what you call, classical, 3 branches. So appreciate that there is a J-hooking of this median orchid ligament causing a stenotic lesion depending on the severity. If you study the PSV of this, then the velocity of the blood and through this, you will know what is the severity of this. Sometimes you have a post-stenotic dilatation. Okay? So what you do is that you cut these fibers all along the, which are crossing it, the celiac axis anteriorly. I'll go a little fast to show you. These are the fibers. Now what I'm trying to do, I hope you are trying to see we are harvesting the celiac axis. These are the branching fibers. You have to be very precise. Make sure what you are cutting, see it doubly before you cut it, because you are exactly working on the anterior surface of the aorta. Sometimes the serosa gets cut, because if you are not proper handling, vision is not clear. Please make sure you ask 10 times your cameraman, do it again, because one nick in aorta, you know what can happen. You probably pull up the whole blood volume in just 10 minutes, and we will lose the patient before you do transfusion. So what is the important thing? And reaching there by open technique will take you quite a bit of time. By that time, 2 points of blood might have gone in. So I would say that this is what I'm showing. See, we always have developed a technique, that's my needle holder. I believe this is the most docile instrument, which I do even in pancreas. Professor Umar has seen us using a needle holder, creating the plane of love tunnel, or if you're doing a splenectomy, huge spleens, creating a space between artery and vein. It's a very safe instrument. There's nothing, no spicule in this instrument. I don't believe using the right angles and all that. So as we go slowly up ahead, you can appreciate now, these are the fibers. This is the left pedicle coming, left gastric coming. This is aorta. And do a good bit of myotomy. Do a good bit. Go up. You can see up to where we have done a myotomy. Only the aorta is beating and is visible to you. So as you go ahead, you can appreciate now some fibers are here. So I would just take a minute for you to just be sure about the anatomy. Now you can appreciate these muscle fibers, decussating fibers of the crura are there. Now you can appreciate, now you see the queen is getting uncaged. These were the muscle fibers which were arching it over. Aorta is here, you can see. Aorta is here, and this is now the celiac axis. I hope it is being seen there. This is the celiac axis, and these are the muscle fibers. And we have done a good myotomy. Decussating fibers and crural decussations almost up to 5 centimeter. And distally also leave it. These are the fibers which we are removing. So this is classical Mercedes-Benz. When you do D2 gastrectomy, you have to steal station 9 from here. That is the time, and you will understand. You have to have a good hand before doing D2. Kindly don't go to this area. You will appreciate. Now you can appreciate at the end of the day, the queen is released from the cage, and the blood will flow back. And believe me, second post-operative, the first word, this girl came to me. She's from Islamabad only, and I'm thankful to Dr. Shafi. He's working here, gastroenterologist, very competent person. He said, Dr. Chalku, this is a thing. I said, I have never done it, but we'll try. We'll not give her a hope of a laparoscopy, because by open it would mean lot of dissection. But luckily, thankfully, don't know how we succeeded. Then we did 3 cases, because once you do a case, then you get the knowledge and experience and all that. So that's one. I would just give a rushingly 1 minute with the permission of the chair. This is another patient, but he was in a higher age group. They usually come between 20 to 40. This is a disease of young. This was a 45-year-old man. He had a cholecystectomy undergone. Now he is supine. I am coming between the legs, standing between the legs, going to dissect. Let us directly go where we have to go. Again, some adhesions here, again going to the pancreas. Appreciate the area where you have to go. Once you know this area, you will not be alien. You will visit this area with confidence and some positive results. So please appreciate, this is the girl, man, who you have to go between the, here the pancreas takes a tilt, a curve, then it again rides high up. So you have to go between this, all along the border of the left gastric artery. The dissection is carried. Now again see, this is the probably, we have to harvest. Sometimes it is so much buried, depending on the compression of this. Now you can see, you can appreciate here it is getting now exposed. This is the celiac axis. And all the vessels were this. Please appreciate one point that you need to do this dissection very wisely, precisely, avoiding the tremor. Now you can appreciate this is splenic, that is left gastric, and that is the celiac axis coming up. Now you can appreciate this is where we have exposed the whole area. We go a little bit more. Now you can see this is aorta. Can you see? This is aorta, and these muscles of decussating fibers of crura are cut. This is celiac axis. This is the splenic, and these are the fibers which are cut. A myotomy has been done, taken up to 5 centimeters up. Some fibers are still uncut. This area is T12L1, and you are just on top of the anterior border of the aorta, anterior surface of the aorta, where this is being done. A final look. You can appreciate all fibers removed, aorta seen naked, dancing. Now all fibers removed. This is celiac trunk. This is the left branch going up. This is the splenic coming down. Splenic will take a C curve. It will fall on the superior border of pancreas, then will turn to the tail. But in between going to the tail, it has a ride. It rides in between, then falls. Thankfully, the master is here. He can tell you better than what. Thank you, sir. If there are any questions for this, I am here.
Thank you so much. Now I'll request Professor Roof Wani, who is currently in charge of the colorectal division, and he is also professor of general and minimal access surgery SCIMS. He is going to tell us about something about a very important topic, that is management of appendiceal neoplasms. Dr. Roof, Professor Roof, sir, can you look this time?
Thank you.
Can you
Dr.
be in
Salim.
time, sir?
Yeah, sure.
Till now we have been blackmailed and we are not
I don't
able
have
to say.
the fancy slides, so it will be just pure academics.
Thank you. I'll be highly obliged.
So I thank the organizers, Dr. Nazir, Dr. Manmohan, Dr. Khalid, for giving me this opportunity to speak on this topic. My topic is appendiceal neoplasm. Why I have chosen this topic? Because it's rare. It's rare, but it's increasing from 0.12% per million population to 1.9 per million population in last 30 years. Almost 300% increase in malignant appendiceal tumors in North America. Appendectomy, one of the most commonly performed surgery, and 1 to 2% of specimens have some neoplasm. So we go by WHO classification of these tumors, epithelial tumors, that's appendiceal mucinous neoplasms, most common. Then we have appendiceal adenocarcinomas, then we have goblet cell carcinomas, and then we have neuroendocrine tumors. So the most common mucinous neoplasm we get, and the referrals we get are for LAMN, that is low grade
appendiceal mucinous neoplasms. HAM or high grade is rare and is very difficult to diagnose even by pathologists. And this is one of the most common appendiceal referrals we get to our hospital. Then goblet cell adenocarcinoma, it's a combination of adenocarcinoma and neuroendocrine, but its prognosis is not good as compared to neuroendocrine neoplasms. So clinical presentation, usually it may be asymptomatic or may mimic acute appendicitis, sometimes with pain or GI bleed or mass, or can present with pseudomyxoma peritoni. So how do we diagnose? By ultrasound. If on ultrasound we see a mucocele, we should always prefer to do a CT scan. And mucocele, we say it is a mucocele once on ultrasound, it's more than 15 mm. Appendix diameter is more than 15 mm. Then actually, histopathology is the definitive diagnosis that we get post-surgery only. And the tumor markers as in any mucinous tumors. So these are two CT scans. One on the on the left side, it is showing a mucocele, classical mucocele with round borders and smooth borders. While the one on the lower and right, they have irregular margins and there are features of calcification. So this is more in favor of carcinoma rather than a simple neoplasm. So what's the general principle of management is surgery, and it's based on the size, location, and subtype. Then invasion, margins, and perforation, whether it is perforated or not. So in short, low-grade appendiceal mucosal neoplasms, if they are confined, we do appendicectomy only. But if there is a spread, we should always consider cytoreductive surgery with high pack. And if there is adenocarcinoma, we should go for right hemicolectomy. Then in case of neuroendocrine tumor of appendix, if it is less than 2 centimeter and no invasion, appendicectomy is sufficient. If it is more than 2 centimeter with invasion, right hemicolectomy, then we have to follow the guidelines. So how do we do the surveillance of these neuroendocrine tumors? If it is less than 1 centimeter after appendectomy, we don't need to do any surveillance. You don't need to follow the patient. But if it is 1 to 2 centimeter, we do appendectomy. Once we suspect any tumor, we should always take a lymph node also. If lymph node is positive, we should do routine surveillance for 7 to 10 years. If it is not, then we don't need routine surveillance. But if we do right hemicolectomy and there are no lymph nodes, no surveillance. But if it is about 2 centimeters after right hemicolectomy, then we need to do routine follow-up for 7 to 10 years. So if you find a mucocele, what should you do? If we see a mucocele of appendix, it's not like a mucocele of gallbladder. So mucocele of appendix should be taken very seriously. If the base is free up to 2 centimeter, do an appendicectomy and do a lymph node biopsy also at the same time. But if there is a compromised base, if you feel that its tumor is arising from the base or you cannot take the base sufficiently, then it is better to do a partial cecectomy or typhlectomy, what is known as. If frozen section is available, well and good. If not, wait for histopathology. If it is benign and margins are free, don't do anything. But if it is malignant, we have to go for right hemicolectomy. So this is the most important slide. Once you see mucocele of appendix, what should you do? If you are doing a laparoscopic procedure, try to convert it into open. Try to convert it into open, unless you are very sure that you will not spill anything. If you convert into a open, mobilize cecum. Don't resect till you mobilize cecum. Get whole specimen outside abdomen wall. Just drape around it, then do a partial cecectomy, so that there is no spillage. Now, if you are doing a laparoscopic, then don't take hold of appendix. Take hold of mesoappendix or at the area where you feel that, yes, it is safe to hold, and get the specimen in some bag. Don't get specimen like this only. Because we are seeing, I'm getting referrals, appendicectomy has been done, a laparoscopic appendicectomy has been done. I have this time 2-3 patients on follow-up who have now pseudomyxoma peritoni and have stage 4 carcinomas now. So if you have a ruptured appendix now, what should we do? We should do an appendicectomy, a lymphadenectomy, and collect the mucus. If appendicectomy shows bowel carcinoma later, we can send patient for right hemicolectomy. But if it shows mucinous adenocarcinoma, do a lymph node biopsy. If lymph node is positive, do a right hemicolectomy. If lymph node is negative, you need to follow only, nothing more to be done. Then about the margin. Again, there's a confusion again. Once we do, we are getting referrals again from with LAMN. Appendix LAMN has been diagnosed. But pathologist does not comment on the base of the appendix. Please, once you see a mucocele, always please ask the pathologist to comment on the base, whether it is free or not. Now if it comes to be positive, even if it is LAMN, you have to do a partial cecectomy. If it is negative, then you follow on. Then about mucus, if it is positive, you have to send the patient for cytoreductive surgery and HIPAC. If it is negative, then HIPAC only. Now, adjuvant therapy depends on the grade and stage. Chemotherapy for adenocarcinomas and targeted therapy, they are under study. Follow-up and surveillance depends on histology and stage, imaging tumor markers, colonoscopy for endoscopy, monitor for recurrence and pseudomyxoma peritoni. Now, the recent advances are the HIPAC, which we'll be discussing soon. Now, if net is less than 2 centimeter, prognosis is excellent. Mucinous, it depends on spread, whether it has spread or non-mucinous, it behaves like colorectal cancer, and goblet cell carcinoma of appendix, it is intermediate and aggressive. So this is the algorithm for goblet cell adenocarcinoma. I will not go into detail. Now about cytoreductive surgery and HIPAC. It is used to treat peritoneal surface malignancies. Involves surgical removal of visible tumors followed by heated intraoperative chemotherapy. So indications are pseudomyxoma peritoni, peritoneal carcinomatosis from appendiceal, colorectal and ovarian malignancies, and malignant peritoneal mesothelioma. Again, I want to stress here, once we see, sometimes we open for something else. Suppose there is carcinoma peritoni. So don't label it as unresectable. This can be treated with curative intent. When should we label it as inoperable? Once there are extra-abdominal metastases that are inoperable, extensive small bowel involvement if it is there, or performance status is very low, or patient has severe comorbidities. So I come to this peritoneal cancer index. What is it? It quantifies tumor burden in 13 abdominal regions, and we score it from 0 to 39. And on this score, we see whether it is curative or palliative intent we go for. So if you are doing a diagnostic laparoscopy or you are opening a patient on laparotomy, you find that there are malignant spots all over the abdomen, what should we do? We should score it. We score it as it's shown in the figure from 0 to 8. There are 9 regions of abdomen from 0 to 8. Then there is upper jejunum, lower jejunum, upper ileum and lower ileum. Then we score each region with 0, 1, 2 and 3. 0 is no tumor, 1 is less than 0.5, 2 is 0.5 to 5 centimeter, 3 is greater than 5 centimeter. What we aim in cytoreductive surgery is CC0, that is no visible diseases remaining. So once we do cytoreductive surgery, that is peritonectomy and organ resection, whatever it is involved, the goal is complete macroscopic tumor removal, that is CC01. Then after cytoreductive surgery, we perfuse the abdomen with heated chemotherapy at a temperature of 41 to 43 degrees centigrade for 30 to 90 minutes. using mitomycin C. Usually mitomycin C is used these days. This is the high pack machine, and mitomycin C is, we have 2 tubes for inlet and 2 tubes for outlet. So we perfuse mitomycin C with sterile water for about 60 minutes, usually 1 hour. It may vary from 1 hour to 1.5 hour. And in intraoperative considerations, careful dissection to avoid injury, hemostasis, temperature control. We have anesthetist has to be good, who will maintain the temperature of the patient and the intraoperative fluid loss. So it's a multi-departmental thing, and we have to have a good ICU backup. Usually patient recovers within 2 to 4 years. Outcome and prognosis, survival benefit of up to 50% in pseudomyxoma peritoni. Once patient is low PCI for colorectal cancer is less than 12. If PCI is less than 12, prognosis is good. We can go for CRS and HIPAC. So CRS plus HIPAC is a promising treatment for peritoneal malignancies, require proper patient selection and expertise, multimodal care and long-term follow-up. So these are the guidelines I just added. They came yesterday only. This is yesterday's disease of colon and rectum, 2025 guidelines, that colonoscopy should be performed in patients with confirmed or suspected appendiceal neoplasm. Appendectomy should be performed if grossly abnormal appendix is encountered during unrelated abdominal operation. Interval appendectomy after complicated appendicitis is typically recommended in adult patients older than 40 years. If you have a patient who is older than 40 years and we have managed appendicitis conservatively, do an interval appendicectomy. This is a new guideline that came yesterday only. Then preoperative assessment of patients with appendiceal net should include physical examination, colonoscopy, CT, MRI of chest, abdomen, pelvis. Then cytoreductive surgery is indicated in select patients with appendiceal neoplasms and evidence of peritoneal involvement. This is the new guidelines that have come now. It's almost similar. There are some changes in it. Thank you for a patient hearing. If you have any questions, please, I will be able to.
Thank you, Professor Roof. Thank you very much. A very important topic and something that we do encounter freely. Thank you very much. And with this, we come to the end of this session. I hope the organizers try to finish off their side of the promise quickly. Thank you very much.
Thank you, everyone. We will now begin the felicitations for this session. I request Professor Dr. Shaukat Jilani to come on the dais and felicitate the chairpersons of this session. Professor Dr. Iqbal Salim Mir. Thank you, sir. Professor Dr. N.C. Digra. Thank you, sir. And Professor Dr. Mubashir Ahmad Shah. Thank you, sir. Kindly take a seat. Next in order, I request Professor Dr. Muhammad Yusufani to kindly join us on the podium and present a token of appreciation to our respected speakers. Professor Dr. Umar Javed Shah. Professor Dr. Mushtaq Chalku. Professor Dr. Sanjay Goja, Professor Dr. Roof Ahmed Wani, thank you so much, sir. As we continue this academic journey, we will now begin our next session, that is Master Videos. Hence, with great respect and anticipation, we now welcome the chairpersons to the dais to share their discernment. Professor Dr. Ejaz Ahmed Malik, Professor and Head, Department of General and Minimal Access Surgery, SKIMS. Professor Dr. Sanjay Kumar Basin, Professor, Department of General and Minimal Access Surgery, Government Medical College, Jammu. Dr. Shamsul Bari, Associate Professor, Department of General and Minimal Access Surgery, SKIMS Medical College, Bemina. And Dr. Manmohan Singh, Associate Professor, Department of General and Minimal Access Surgery, Government Medical College, Anantnag.
Good afternoon, everybody. The last session of the day, and congratulations to the organizers for a beautifully organized conference. We are almost 40 minutes behind schedule time. After this, we have two very important events. One is the inauguration, another is the executive body meeting. So 15 minutes means 15 minutes. And I am very, very hard taskmaster in that case. 15 means 15, and then the things are over. The control, please note it. The first speaker in this session is a video, master video. वो कहाँ गया राजन?
Thank you. Now I request Professor Dr. Mushtaq Ahmed Chalku. He will present a paper on laparoscopic Whipple surgery technical aspects. Dr. Mushtaq, please. Thank you.
Thank you, sir. This is possibly, thank you, Dr. Nazir. This is for adjusting my talk here. Tomorrow, I feel sorry, I would love to come, but I would be in theater. So that's why I'll just hurriedly give you an outlook of how we went to pancreas. We're 5 years old in pancreas, and thanks to Professor Umar Javed and Professor Iqbal, our head of the department, who initiated that we should get into pancreas. And the master was here. We took advices from him, and we went with his help. I said in the beginning the roads might be different, but the target is same, so we should not abhor and hate each other, as there's one God, roads are many. So I'll just give a brief description of how we go around pancreas. We have picked up a thesis for the distal pancreatectomy, around 12 cases already done. Whipples, we have done 9 cases, 1 mortality, of course. We have done PJs, almost 10. So I would just, before I would go to this, I think it's important to just give a highlight of the pancreatic work we have been doing. 15 minutes I have, sir. I have 15 minutes, sir? Okay, sir. Thank you. So, minimal invasive surgery for pancreas. I would just give you a highlight of this is our work. We are started somewhere in some 3 years before we started, 3-4 years before. We are not 4 years all experience. I think that's what we did. And these are the different things we have done. Cystogastrostomies, we started with for pseudocysts. We did ramps. In fact, one of the postgraduates my postgraduate is doing a research on it. 12 cases we have done. Spleen preserving distal pancreatectomy, we have done 3. PJs 6. Assisted pancreatic duodenectomy, Whipples 3. But totally laparoscopic 9, and we had 1 mortality. And then around 45 procedures. This is a single surgeon experience I will be talking about. This is how at the end of the day, the
incision would look like. This is a cystadenoma of a young girl, operated spleen preserving. I hope you can appreciate. This is MRI. And this has a communication with the pancreatic duct at the tail. This was one of the interesting cases. This is how, at the end of the day, the radical antegrade modular pancreatic splenectomy specimen will look like. You are removing almost 2/3 of pancreas here, and the spleen. This is what RAMPS is all about for any benign or malignant condition. So you can see this is how at the end of the day the specimen will look like and the incision. It's done by 1, 2, 3, 4 and 5 ports. That's ramps for distal pancreas, as we have Whipples for the proximal pancreas. And pylorus-sparing pancreatic duodenum classical Whipples, the specimen would be like this, the incision and at the end of the day would be like this. My channel, thankless job being done for last 12 years now. So let us go to see the technical aspects. Whipples is a legacy in SMHS. As you know, Professor Mahmooda Khan, our pioneer, but a name, international name. So I would say that we carried it only by a different way. That is laparoscopy. Otherwise, things are same. Gastric hitch, pancreas is, this is the head. So what I am doing is that I will do capsulotomy. This is a patient where there is a ductal dilatation in the body and there is a stone inside. It's a chronic calcific pancreatitis situation, bipolar in my hand, going all along. You know, the problem is how to identify the duct. Most of times you don't hit the duct. We have used PCNL needle. This is how sometimes you may not. If the duct is good size, then the job is easy. But if the duct, that happens even in the Whipples, when you are doing a pancreatic jejunostomy. Sometimes you do Duncan procedure, sometimes you do gas. It's very difficult for small ducts. So somehow, if you are lucky, you hit it, you do ductotomy, do a wide 5 centimeter ductotomy. What our idea is that we use a Fogarty vascular, we never get a biliary Fogarty. You see, I am in the duct and do flushing. This is a stone. Stones are always white in color. There's a pancreatic stone is different than gallstones. A ductotomy is done. You can put a cope there to see any further and do a flushing. That is the tail end of the duct inside, you can see. And I'm using a Fogarty to go to the head. If there are stones from the head side, you can extend the ductotomy, make it a J curve incision, but that is difficult laparoscopically. But if the stones are distally, they're all the more easy. But flushing is very important. We have used even the extracorporeal shock wave, mechanical lithotripter. All these things can be tried. First, go and take a loop 15-20 centimeter and do a wide jejunectomy. And then the anastomosis should be the non-absorbable. The best suture would be PDS. Here we are using non-absorbable barbed suture. Anastomosis is done classical type 4 layer. So firstly the posterior layer is taken, is completed, then you go to do the anterior layer. You need to be very proficient in your suturing, otherwise don't take this procedure. Open is equally good, but if you are proficient, you can make it, because there's a lot of manipulation of the needle and all that. Here we have all laparoscopic surgeons doing this procedure. They will agree with me. At the end of the day, the procedure is done. Then you can convert it. It's a classical way doing. You can convert it to Roe and Y type. It's your choice what way you want to do it. You want to do Pasteur type. You want to do Partington-Russell modification. You want to do any other modification. That is all is possible laparoscopically. There's nothing like this cannot be done. This can. This all reproducible. Can be done. I don't know what exactly I have done in this case. Is it the continuous or I have taken it as a Roe and Y? Yes, I have taken it as a Roe and Y. That's a Cannon loop. Now you are going down around 40 centimeters and you do jejunostomy. So the anastomosis is Roe and Y pancreatic jejunostomy done for CCP with intraductal stones. This is jejunostomy. You need just one fire and use a V-lock to close it. I think that's, I think we should go to ramps. Now, what is ramps is that if your tumor, whether benign or malignant, is restricted to the body and tail. In this part of the pancreas, you all know the tumors which are common or commonest, or the cystadenomas or neuroendocrine tumors, NET type, they usually will come to you and they will need two-third from the body go in and then do. I would not take the ports. Let me go fast because my chairman is angry already. He may not allow me then to stand here. So this is a tumor in the tail of the pancreas. You can appreciate the tumor down. So gastrosplenic is cut. I was just telling you how to make a love tunnel. That's very important because posteriorly you will be afraid. See the inferior border of pancreas and mesocolon is attached to it. Release this from the site of transection. Release it. This is the tumor. You can appreciate. 1 centimeter margin clearance in pancreas would be enough. But if you take a good margin, you will be on the safer road. Now, problem lies in if you are doing a pancreatectomy spleen preserving, then you probably go by either Kimura technique or a Varsha. But I would always preserve, you should always preserve, because spleen will sustain on gastrosplenic also. But 10% of these patients might develop splenic infarction, and next day you might have to explore these patients and do splenectomy. That's the worry. So if you preserve splenic artery and vein, you're doing a better job. Can you see on inferior border, there's a vein. That's splenic vein. So how to make sure that it's the art lies in your cameraman. Please keep on teaching him while you are doing. That is the beauty. You teach and learn and relearn. Now you will create a plane. I would say you would create a plane, go above the vessel. Can you see splenic artery and vein? They are down. And I'm trying to find a cleavage. Here I have said that needle holder is a very important. We published this. Needle holder, use of needle holder in these advanced procedures where you are trying to gadding along these vessels which are no reason to injure them. You can't ligate them. So you have to transect. Now the whole plane is available. I will use one fire. For pancreatic transection, the compression time should be more than 5 minutes. Don't just stay there for 2 minutes. Compression time is more. At the end of the day, if you see in this patient, you are using, Now you see the splenic artery has to be preserved all along, and pancreas has to be, lifted along with the tumor in the tail. Once you have done that, part of the pancreas is still attached. When you use the transection, please make sure sometimes the common hepatic is moving on the superior border. Don't transect. Many a times what has happened, transected, the common hepatic is also done. So make sure, check time and again, go up, tell your to rotate it up, cable to see what is happening superiorly. You can see now the whole specimen is ready. In this case, we have to remove the spleen also because we have ligated the vessels. We will remove the spleen. Now spleen, this is hip hip hooray. So single specimen of distal pancreas, that is body, tail and spleen. All is available to you. Now there is another point where you preserve the, now what is like Whipples? Whipples is only courage that you have to stand there for quite a good amount of time in the beginning. But slowly, I think, don't stop good work. Have good mind, have positive attitude, promote all this. Youngsters will be doing. People of our concern, half of our experience outside are doing it day in and day out. So there's nothing great thing. Don't make big news out of it that you're doing. It's only a proper training, your patience, your confidence, your courage that will take you to this game. Okay, now I am getting into the gastrocolic ligament. This is the left gastric. First I will left gastroepiploic take it. Create a window, retroduodenal window, transect the duodenum. If you are doing classical Whipple, you will have to take the distal 1/3 of the stomach, but if you are doing a preserving type, you may preserve. So we have transected, removed the stomach. This is GDA. GDA is clearly available to you at a camel's hump. So if you know where camel's hump is, you will dissect it there, make it naked. You can see the GDA only is ligated, cut. Now, after this, your GDA is gone, you will go to the inferior border. Now you will go to traverse the love tunnel. Now, where is the love tunnel? It is the origin of the gastrocolic trunk, inferior pancreaticoduodenal. Inferior pancreaticoduodenal, once you ligate, look at here, once you ligate, you will enter the love tunnel. Now starts the dissection. So you will traverse superiorly the inferior border of pancreas, posteriorly will be SMV. Now this is what I was saying, this instrument makes my life very comfortable. It is very non-traumatic. I'm negotiating the whole instrument, coming it through the neck of the pancreas superiorly. You can see the portal vein here. So transect it. Now you go to DJ, take 15 centimeters, that is part of the specimen, dissect at the DJ flexure, that is the colic vein there. Now what is cauterization? The true art is extended cauterization. All steps I do between the legs. Now this is aorta here, you can appreciate aorta. So there is this cauterization. We're lifting the pancreaticoduodenal complex, that's the head and the duodenum, and mobilizing this all. Once it falls down, gets medialized, you will relax, have a cup of tea at this time. You may break for 10 minutes, whole team, because this procedure might take in the beginning maybe 6-7 hours, but then we could do the last one in 3 hours. Thankfully, we succeeded. Yes, one patient, we had a leak. He died at sixth week. So this is the head and pancreas. This is the uncinate process. The difficult part is the uncinate dissection. I'll just take a minute, 1 minute, with your permission, or I will close. Eh? No, bell is now, no? So SMV you can see down. Now go up and take the bile duct. Cut the bile duct. Now this is the first anastomosis is PJ. PJ, the problem is of the duct. If you identify the duct, then it is easy. If it is just 5-7 centimeter, 7 mm, it is good. But if it's just 2-3 mm, sometimes you won't see. Then probably Duncan will put a stent and repair it over a stent. Then HABJ would be done. HABJ, posterior I do interrupted, anterior I do continuous. Then I will do GJ. GJ would be the last. That is how the specimen would look like. That's how we done. Thank you very much, sir.
Thank you, Dr. Mustaq, for sharing your technical expert with us. Thank you so much. Because of positive time, we will not be able to get any questions. We would like to call next speaker. Saja, sir.
Now we have second speaker, who is Professor Mubashir Shah. He is one of my department and colleagues. He's going to present laparoscopy and pancreas at Tristat SCIMS. Professor Mubashir.
Dr. Mubashir will request you to please stick to the time, try to finish it as soon as possible.
I'll try my best.
Sorry, my dear friend.
Not to stick to the time. Do it whatever other people are doing. Let him speak.
Thank you, chairpersons. In the constraint of time, I will be trying to present my presentation as early as possible, as fast as possible. So I bring greetings from SCIMS. So we present this pancreatic surgery laparoscopically as is said to be as taming a lion. You know, pancreas has always stayed as one of the most dreaded and feared organs by the surgeons, just like a lion. But the human tendency has been to tame everything, to fulfill his ego, which is even bigger than the lion. Pancreatic surgery stands apart from other areas of general surgery. Why? It's a hidden organ, entangled in surroundings. It has a soft texture, which has a lot of implications. The duct is narrow, and pancreatic juice is potentially lethal. For generations, surgeons have revered and feared pancreas.
resection is challenged, the anatomical and the disposition of pancreas within the retroperitoneum with so many vessels, organs in vicinity. We say that it's a challenge. The resection itself is a challenge because of complex anatomy and major vessels in vicinity, and reconstruction because multiple anastomosis are involved. Leaks are often fatal, and these afflictions are usually in elderly people. So the taming of lion has started a long time back. It was early 19th century when people would start taming lion, and began with half-hearted, shielded and skeptical approach. Persons holding a shield and a whip, you can see in the first picture, and then getting closer, and sooner and later they start getting up, giving up the barriers. And this happened in earlier 20th century, and through the late 20th century and 21st century, they become Pauls. And the contribution goes to these people. And you see, the laparoscopic Whipple has revolutionized surgery, pancreatic surgeries, and now the robotics have come. Minimal access surgery finds its place in pancreas in many afflictions, inflammatory diseases, chronic pancreatitis, neoplasms of pancreas, which are borderline benign, borderline malignant or benign, neuroendocrine tumors, and now we have even switched over to malignancies of pancreas. So I will be just taking you through a bit of procedures that we do in our department, just to take you through a few other procedures that we do. So this is a cystogastrostomy, a large cyst, a large pseudocyst actually involved of necrosis, which couldn't be drained by endoscopically. The treatment of choice is endoscopic drainage. We resorted to doing laparoscopic opening of the anterior wall, opening of the posterior wall and the cyst, draining out whatever necrosis that we can remove without causing bleeding, and then leaving the rest behind, because if you aggressively do the debridement of these tissues, you can bleed a lot. So we just take this and then suture the wall of the posterior stomach and the cyst wall together. This is the cystojejunostomy, which I'll be skipping. And so minimally invasive distal pancreatectomy has been found to be superior than open pancreatectomy in terms of functional recovery, in terms of blood loss, cost, and in terms of less delayed gastric emptying. Morbidity and mortality are probably same. I'll be presenting a video of a patient who presented, a young boy who presented with us with a large lesion in the pancreas, which was causing lateral portal vein, sinistral portal hypertension. You can see the large gastroepiploic vessels, and he presented with GI bleed. And on CT, it was found that he has a large cystic lesion in the pancreas, distal pancreas. We didn't know what was the nature of that cyst, but since he already had portal hypertension and it needed to be removed, there was no other way. We could not aspirate it. We could not, it needed to be removed actually because of the pressure effects of the cyst. And then we go in, open the lesser sac. This is around 12 centimeter cyst. Open the lesser sac, get into the lesser sac, take the lower border of the, so this is, the cyst is adherent to the posterior mesocolon. We'll be separating the mesocolon. Yeah, we are separating the mesocolon from the cyst. And yeah, this is the mesocolon being separated from the cyst. I don't know. So we go under the inferior wall of the pancreas and make a tunnel. After completing the tunnel, you see the splenic vein and the hepatic artery there. After completing and go in the suprapancreatic area, dissect the superior pancreatic vessels, which will be splenic and the hepatic artery. Probably we are dissecting the hepatic artery here. Separate it from the pancreas, and then this is the portal vein, and then may complete the tunnel. I am not able to forward it. Then divide the pancreas and subsequently resect the vessels. Because of the enormity of the mass, we could not, it's advisable to resect the artery first so that it prevent the engorgement of spleen. But here we could not get access to the artery first. We had to resect the splenic vein first. And because of the portal hypertension, we thought that it's better to resect the vein first. So we take down the artery and finally resect the spleen along with the pancreas. I'll skip this. And then we open this, sorry. And when we open this, it turned out to be hydrated fluid with hydrated cysts inside. This is the first reported case in the literature when a laparoscopic pancreatectomy has been done for hydrated cysts with lateral portal hypertension. So I'll not go into the literature, not in the details. I am not here to describe which is good and which is bad. I need to just show you some videos of what we do. You know, spleen-preserving distal pancreatectomy for benign disease or borderline benign malignant diseases can be done through Kimura and Warsha, which our colleague Professor Chalku Saab already said. I would take you to a spleen-preserving distal pancreatectomy. We have already opened the lesser sac, lifted off the stomach, and here we are using an ultrasound. We're lucky to have an ultrasound to see there's a lesion which is a neuroendocrine tumor in the distal body near the neck, and we are demarcating the margin and putting a clip there, dissecting above the splenic vein to preserve the spleen, and then going above, identify the left gastric artery, and then going again through the tunnel, completing the tunnel, taking the splenic vein down, and then separating the hepatic artery, because on the left side it's more important to separate out the hepatic artery, because hepatic artery cannot be dispensed with. You can dispense with the splenic artery, may finally land up in a splenectomy only, but here you have to be very sure that you don't take the hepatic artery. A good landmark is the lifting up of the left gastric and see if it is on the left side or the right side. So here we dissect the splenic vein away from the pancreas, and then comes the splenic artery. Here the splenic artery is actually, you see, splenic artery usually goes over the superior border of the pancreas, usually very tortuous, but away from the texture of the pancreas. But here it's deeply laden, embedded within the pancreas, and takes some time to dissect this tissue. So finally we dissect it almost completely, and till the time we reach the hilum. Now we come towards the inferior border of the pancreas, towards the tail, and lift the tail up, and then complete this dissection. And you can see the splenic vessels are quite away, and yeah, this is the dissection. These are the vessels, and you can see the separation of the tumor from the splenic vessels. Okay, this is the distal pancreatectomy. This is a small slide on a central pancreatectomy. This small girl came to us with a SPEN, solid papillary endocrine tumor, epithelial tumor. So this is just at the neck of the pancreas, mostly exophytic lesion. And we thought that resecting a big chunk of pancreas for her at that age may not be wise. But we did what's called a central pancreatectomy. First of all, made a tunnel, dissected the tunnel, and then took the gastroduodenal artery. And after taking down the gastroduodenal artery, we looped the pancreas just proximal to the lesion, and then divided the pancreas, and then again splitted the vessels, and then dissected the pancreas on the other side. This is the central pancreatectomy. Here the duct was too small that we could not resort to a ductal mucosa anastomosis. Here we did a conventional two-layer anastomosis of the first with the serosa and then other with the through and through layer. Unfortunately, this patient had a leak, but she survived the leak. She was with us for almost 3 weeks, but she's doing fine now. She had a post-operative, and the pathology was SPEN. So minimally invasive pancreaticoduodenectomy, a lot of debate about that. I just don't want to go into that. I'll just demonstrate a small Whipple here, which we have done in our department. So, and this is the laparoscopy. We put in the ports, try to lift the gallbladder so that you get a good glimpse on the hepatoduodenal ligament, open the lesser sac, then take down the hepatic flexure, get a view on the duodenum. This is the duodenum. Now go to the, make the tunnel, divide the stomach, get to the hepatoduodenal ligament, divide this hepatic node, and then do the dissection of the, this is the gastroduodenal artery which we are clipping. We clip it with ligate clips and hemlocks, and we do the dissection of the hepatoduodenal ligament, make a tunnel, complete the tunnel, and then before dividing, we divide the inferior pancreaticoduodenal vein. Now cauterize the duodenum, take the duodenum up. We do an extensive cauterizing. We don't go to the inframesocolic compartment. We take the jejunum away from the right side only. So we do an extensive cauterization. We have lifted the duodenum from our aorta as well as the vein, and we are taking the jejunum out from the right side only. We divide the jejunum, and then we divide the pancreas. This is the neck of the pancreas and the spleen, and then subsequently we take down the uncinate. We routinely do an uncinate first procedure. We don't go up first. We take down the common bile duct in the end. And here we'll see that we'll be going close to the superior mesenteric artery, almost flush. Don't leave any mesentery there. You can see the superior mesenteric artery just adjacent to it. I'm very thankful to the team who are helping me out, and other people also, the support system. You can see this is the final end of the resection, where we do the division of the common bile duct, common hepatic duct. Now we'll do reconstruction. So you can see the IVC, the aorta, the portal vein, as well as superior mesenteric artery just behind it. We could do the reconstruction with the mesocolic tunnel, and then take the jejunum up, make a small hole in the jejunum, and then do a hepaticojejunostomy in an interrupted manner. If the duct is too big, we might do a continuous, but we just do an interrupted. Just a minute, sir. So I think you have given time to everybody, at least a minute more. So I would also need 1 minute. I am trying to do my best. So this is the hepaticojejunostomy towards this end. Now we'll move over to the pancreaticojejunostomy. We routinely do a pancreaticojejunostomy in a ductal mucosa fashion whenever the duct is visibly seen. So this is the first layer, doing the serosa and the capsular approximation. And now we make a small hole in the jejunum, do a small jejunotomy, and take the stitches through the duct and the mucosa of the jejunum. These are also interrupted sutures. Need a lot of help from others to get this done. Sometimes they are very difficult things to do. So we take the stitches first. After taking 2 stitches, we stitch the first one. Usually that helps us, get a good space inside. So once the posterior layer is done, we push in a. So once this is done, we'll push in a tube inside, a feeding tube, which can be 8 or 6 or 8 French, or sometimes 10 if the tube is big, if the duct is big. So we push in 2 centimeters of the tube inside the pancreatic duct and 2 centimeters into the jejunum, and then do the anterior layer. Again, duct to mucosa first, and then the approximation of the, and we'll finish this with a gastrojejunostomy. So this is the serosal and again capsular approximation. So next we'll do a gastrojejunostomy, which is not a big, this is the gastrojejunostomy. We do staple gastrojejunostomy just to the side of the transection of the stomach, and push in a feeding tube across so that patient can be fed in the post-op period before the bowel sounds come or before the leak comes. Then, so not into this. So besides these laparoscopic procedures, laparoscopy doesn't always find place, other people were telling me. So there are some places where laparoscopy cannot be done, at least for us. So we are in the learning phase. So when you have to resect portal vein, you have to usually resort to an open procedure. So this is the portal vein resection anastomosis in a patient who has received neoadjuvant therapy. This is a patient who has undergone hepaticojejunostomy for cortical cyst and developed a duodenal tumor, which infiltrated the rule limb of the hepaticojejunostomy as well as the IVC. You can see the IVC, the tumor is being removed, and the IVC clamped, and the IVC tumor infiltration into that has been also removed. These probably cannot be done in a setting of a laparoscope. Probably you need a robot for that and a lot of training. So Whatever you choose a Whipple or you choose a open, you choose a laparoscopic or a robotic. Open PD is still the gold standard. People who belong to my age and elder would confess. But times and approach change, and we have to accept and adopt changes in order to be relevant in this world. These are our, I don't think we need to
Thank
go
you,
into.
thank you,
Thank you
Mubashir,
so much,
for
sir. Thank you.
presenting a very good.
I am just going to say you thank you only.
In a
I'm
very
waiting for that.
low pitch
So
voice. Thank
the,
you very
the
much.
last slide, please. Can the lion really be tamed? You may not always be able to tame the basic instincts of this beast. And if you fail, you may rue your desire to tame this beast. So give up ego, work with passion, make a team, and stay humble.
Thank you very much. Thank you. We move on to the next, second last speaker of the day. And the speaker is Dr. Rajan Deep Singh Bali. He is speaking on laparoscopic abdominoperineal resection, navigating the correct planes. Dr. Rajan Deep. He started with me as a consultant, and now he is an associate professor who is navigating everything in the surgery. Dr. Rajan Deep.
Thank you, sir. Thank you for your introduction. Thank you for your kind words, sir. I'll stick to what sir has said. I'll not take 15 minutes. It's only 7 minutes. Okay. So we start with the video. It's not a presentation, it's a video. The video is, I'll only be showing the laparoscopic part of the APR. We had a 55 years old male, came to us with bleeding PR. On colonoscopy we saw there was a fungating lesion extended from 3 to 9 centimeters, 6 centimeters long. We did a biopsy, CT grading was CT3B N1M0. We sent him for CTRT. Nowadays they are giving TNT. They gave the TNT and we received the patient after 6 months, and we started with APR. Histopathological report after the APR was total lymph node dissections, complete regression, YPT N0, M0, MX N0. This is the patient positioning. It's a modified Lloyd-Davis position. The surgeon stands on the right side. The assistant, the camera assistant, is by my side towards the head of the patient, and the first assistant, he stands on the left side of the patient. We do a lap APR by standard 5-port technique. The 5 mm port in the right iliac fossa can be substituted with a 12 mm port if we require a. Now we start with the first step, that is to go into the retroperitoneum. So what I'm deperitonealizing the retroperitoneum so that I enter retroperitoneum. The moment I enter retroperitoneum, my first goal is to identify or reach the vessel. That is that can only be done by finding this cobweb. This cobweb space is the space between two slips of fascia of Frudet. Now I'll be doing a limal because histopathologically there is no difference in the prognosis. So this is the low ligation of inferior mesenteric artery. I just dissected the inferior mesenteric artery, but before I clip it, I have to find the ureter and the left gonadal vein. That is the dictum. How do we do it? We keep anterior to the common iliac vessels. You can see it here. My cursor is on it. And I'm actually not looking for the ureter. I'm just keeping anterior to it. And as all of you know, the ureter, before entering into the pelvis, it will cross the common iliac. And you see the ureter identified by the characteristic peristalsis in it. The second thing, after identifying the ureter, see this one is the ureter. The second thing is, I have to look for the gonadal vessel. Again, we do not look for it. We just stick to the planes of free fascia of Frudet. So this is the gonadal vein. Having done this, now I'll come back to the vessel and tie it. We don't normally tie it, but my resident said, sir, could we do it with a tie? And I told them, yes, it can be done with a tie. This is a characteristic sign of GMC, that this surgery has been done at GMC because we have 8 traumatic scissors. They don't cut in the first go. Then my residents told me, sir, we need to be sure. How are you sure that you are doing a limal? Where is the sigmoidal vessel and where is the rectal vessel? So those of you seeing, intently might have seen that I have applied 2 hemolock clips distally. So I dissected the sigmoid vessel and the superior rectal vessel. Normally we do not do it, just for making it clear that we did a limal. So now that we have dissected it and divided the inferior mesenteric artery just distal to the left colic artery, we will start dissecting, looking for the plane of Heald. As I opened this fascia, there is a cavity. This is the plane of Heald, which was described by Bill Heald very clearly. And now we start dissecting in the retroperitoneal space, retrorectal space, keeping ourselves between the 2 slips of the pelvic fascia. Now I am going laterally towards the left side. How do I know that I have reached my destination? It is the left internal iliac artery, which is visible here, this white one. The moment I see it, I do not have to go lateral to it. Now back to the retrorectal plane, I'll keep on developing it. Once I have reached up to the rectococcygeal ligament, then I'll try to mobilize the white line of Tolt from the left side, and I'll complete my dissection from the left, the right, and then anterior to the rectum. As you see, you can see there's pneumoperitoneum already present behind this white line of Tolt, because I have already dissected it from the back side of the rectum, of the sigmoid colon. Now this is the rectococcygeal ligament that I'm dividing. It is better to use an energy source doing this, not a cautery, because most of the nerves, the pelvic nerves, go through here. So if you are using a bipolar or a cautery, so you will cauterize the vessels also. This blue structure that you are seeing here is the very characteristic in males. It is the seminal vesicles, which will be very visible later. As the general rule is there, the fat belongs to the rectum. It should not be anywhere else. If you perforate the mesorectum, total mesorectal excision, if you do not do it, you penetrate it or perforate it by even 1 mm, chances of getting a recurrence or tumor seeding is 10%. So even 1 mm matters. This here is the seminal vesicles. And now I'll be carrying it out anterior between the rectovesical pouch, joining it to the left side. This case was a bit interesting in the sense that normally we are told that we have 2 lateral rectal stalks. I tried to find the lateral rectal stalk on the left side, I couldn't. See, these are the baby buttocks that are very common word used in rectal parlance, rectal surgeons parlance. They always say baby buttocks. There's no lateral stalk on the left side, but when we dissected on the right side, we found a lateral stalk. Again, wise to do the ligation of the lateral stalk with a energy source, no less than a ligashore, because it has middle rectal vessels, so it can lead to bleeding. See, the lateral rectal stalk. It is clearly visible here. So we use a ligashore to ligate it and divide it. The moment you ligate this thing, you already know that you are near about 5 centimeters proximal to the anal verge. So a few centimeters more, and then we started with the rectal part. Unfortunately, we didn't have a head-mounted camera, so we couldn't record the rectal part. This is the division of the sigmoid colon at its junction with the descending colon. We do it, then we inspect everything, complete the rectal part, come back up, make a stoma, and see. This is the inferior mesenteric artery stalk left. Here you can see the common iliac vessels. This is the ureter, which is crossing the common iliac artery, and this is the gonadal vessel here, this one. This is the psoas muscle. This is the cavity, no bleeding. This is the appendix, which we'll see in the video. Common iliacs. See the ureter on the right side, the appendix, and now we are seeing if we can bring the descending colon out, or we have to mobilize a bit more. At the end of the procedure, we just put in a drain, that is the dictum, and then we come out. See, clear. So with this, I end my presentation, and I hope I've been in time. Dr. Sanjay will be very happy. At least he didn't have to stop me. Thank you, sir. Thank you, sir.
Thank you, Dr. Rajandeep. You have really compensated for the time.
Thank you.
So
Before
will
I
like-
leave, I'll just take a minute. I have to thank my guide, who's sitting in front of me, Professor Nisar Saab. He's more of a father figure than a guide. Nisar Saab, Mohammad Yusufani sir, my uncle, he's sitting behind, Dr. Kinu sir, uncle, and Dr. Tanveer sir, Tariq Qureshi sir, he's absolutely, sir, thank you sir. God bless you.
Thank you, Doctor. Now I'd like to call upon the desk Dr. Imran Abdullah Khan. He will be talking about, from Noora Hospital, he will be talking about laparoscopic anterior resections with high ligation. How I do it approach.
PowerPoint could not start. मैंने दे दिया तो ट्राई भी किया था उसने यार नहीं चल रहा यार वो ओपन हो रहा है और हो गया ओपन ही पावर पॉइंट प्रेजेंटेशन खोल दो हो रहा है वो बोल Good evening, dear teachers, organizing committee, my dear colleagues and friends. I am Dr. Imran. I'll be presenting laparoscopic anterior section with high ligation. Our patient is 55-year-old lady with no comorbidity. She is having bleeding PR from last few months. She also had constipation on and off. She underwent colonoscopic polypectomy from sigmoid colon some 7 years back. Histopathology was not known, and then she lost follow-up. Examination findings were unremarkable. Routine blood investigations were within normal limits. Colonoscopy was suggestive of ulceroproliferative region about 27 centimeters from the anal verge. Biopsy of that lesion was suggestive of adenocarcinoma involving the muscularis mucosae. CT chest and abdomen of the patient was suggestive of short segment circumferential enhancing thickening involving sigmoid colon of thickness of 8 mm along a distance of 3.5 centimeter with small nodes. Plan was laparoscopic anterior section. OT setup and patient positioning. Patient was placed in Lloyd-Davis position, left up. Lloyd-Davis is Trendelenburg position, legs shifted with hip flex at 15 degree. Surgeon stands on the right of the surgeon, assistant surgeon to the left of the surgeon, and the scrub nurse to the right of the surgeon. And assistant stands at the left shoulder of the patient. These are the port positions. After creation of pneumoperitoneum, the initial camera ports placed to the right of the umbilicus. The two working ports, one for right hand working port in right iliac fossa and left hand working port in right lumbar region. The right hand working port can be converted to 12 mm once we go for transection of the distal bowel, and then left iliac fossa port is placed. This port works for assistant retraction port, and at the end we can place a drain through this port.
This port, once we go for pelvic dissection, this port works as left hand working port for the surgeon. And left lumbar port works as right hand working port of surgeon when we go for spleen fracture mobilization. This video demonstrates once the diagnostic laparoscopy is being done, findings are being confirmed, the sigmoid colon mesentery is being retracted with the left hand working port of assistant upwards and anteriorly. We identify the sacral promontory, divide the peritoneum over the sacral promontory in a parallel fashion to the underlying vessels and vertebrae. Once the peritoneum is divided, then air ingresses inside the sigmoid colon mesentery and we can now go for the medial to lateral dissection. Here our tendency is always to go for posterior and inferior, but we should go anterior and superior and hug the posterior of the sigmoid mesocolon, as our aim is to push the ureter and the sigmoid, ureter and the gonadal vessels towards the retroperitoneum. You could see that our tendency is here again to go posteriorly inferiorly, but once we do sufficient number of cases, we come upwards towards the sigmoid colon mesentery and we don't lose the plane. If we lose plane here, field will be messy and it will be very difficult for us to find the plane again. Once we have done the sufficient medial to lateral dissection, using the blunt and sharp way, we should do it as lateral as possible. Then we divide the peritoneum over the inferior mesenteric artery up to the duodenojejunal flexure and avoid the additions of the inferior mesenteric artery to the retroperitoneum, taking care of the hypogastric nerves. As you could see here, there are hypogastric nerves going vertically downwards. We have to preserve these hypogastric nerves at any cost. Once the inferior mesenteric artery has been dissected, then we can dissect the we can do the retroperitoneal dissection in the left descending colon. In the same way, the way we did the medial to lateral dissection of the sigmoid mesocolon. We should lift the sigmoid mesocolon with our left hand in order to get the enough space as well as to get the clear vision that separates the two leaves, the torus fascia as well as the posterior sigmoid colon mesentery. After this has been done, then I not confirm how much lateral dissection we have done. We can lift, pull the sigmoid colon medially and see the extent of the dissection. After that, the inferior mesenteric artery is being dissected and it is being clipped. 2 clips are being placed proximal to the left colic artery and 1 clip distal to the left colic artery. The left colic artery is being clipped in order to prevent any bleeding once we divide the inferior mesenteric artery. The left colic artery is again buttressed with 1 more clip. In order, once we divide the left colic artery from the sigmoid vessels, then it will bleed. After this has been done, then we continue our medial to lateral dissection in order to mobilize the splenic flexure. We can mobilize splenic flexure in the medial to lateral way, lateral to medial way, and superior to inferior way. But here, as we have done dissection in the medial to lateral fashion, we continue mobilizing splenic flexure in the medial to lateral fashion. You could see here the post torus fascia is being pushed down, and we are going as lateral as possible under the mesocolon. After the sufficient dissection has been done, then we go for ligation of the inferior mesenteric vein. This should be done as high as possible to the left of the duodenojejunal flexure. 2 clips are being placed proximally and 1 clip distally and is being divided with a sharp dissection. Once it is done, then there is time for mobilization of the sigmoid and the descending colon. We go laterally and divide the attachments laterally. As we could see that enough dissection has been done in medial to lateral fashion, the descending colon is just attached to the lateral abdominal wall by the peritoneal fold. This dissection is done using the right iliac fossa port and the right lumbar port. Once we go for the splenic flexure mobilization, we change our right hand to the right lumbar port. And all the attachments of the splenic flexure with the lateral abdominal wall is being divided. Here we should take care, we should not injure the splenic flexure. Our instruments should always be under vision. If we damage the colon or splenic flexure here, then it will be very difficult for us to salvage the case. Depending upon the extent of the mobilization needed, we can divide the gastrocolic omentum from the transverse colon, or we can separate the transverse colon mesentery from the anterior border of pancreas. Once it has been done, then we go for the pelvic dissection. We should dissect here in the plane of field. As here natural tendency is go posteriorly towards the sacral, presacral fascia, but we should always hug the mesorectal fascia in order to avoid any injury to the presacral fascia as well as to the hypogastric nerves. Here dissection should be always sharp. There should be no blunt dissection here, as it will create a mess. Field will be messy and it will be very difficult for us to look for the planes again. We should combine the posterior dissection with the lateral dissections. As you could see here, the posterior presacral fascia is maintained, and now we do the lateral, we divide lateral peritoneal folds. As this is anterior resection, as it was the anterior resection for the distal sigmoid colon cancer, the anterior dissection was not needed here. Once we have done the enough dissection lower down into the pelvis, we divide the mesorectal fascia in order to prepare the bowel for the transection. After doing enough dissection, in order to look whether we have taken enough margins, we go for the intraoperative sigmoidoscopy. As you could see the sigmoidoscope coming inside, we are looking for the adequate margins proximally and distally. Once it has been confirmed, then the right iliac for support is converted to 12 mm, and we are stapling the distal, we are transecting the distal rectal stump using Echelon flexors with 60 mm 60 mm green load cartridge. Once done, the remnant mesorectum as well as the rectal stump is being checked for any bleed or any leak. After it has been, and now there is a time for the proximal transection of the mesentery that we have marked while doing sigmoidoscopy. The mesentery is being transected up to the marked level. You can see the clip was used as a marker. After that, phalansteal incision is given. The wound is being protected with a polythene bag made of the drain tube, and the bowel is being taken out. Here we check for proximal margins again. If we have not taken the enough proximal margins, we can revisit our margins. After that, the proximal bowel is being divided after checking for adequate proximal margins. And the purse string is being taken from the proximal bowel using 2-0 Prolene suture. Anvil is inserted, purse string switch is tied around the anvil, all the fiber fatty tissue around the anvil is being dissected. Bowel is reposited back, phalansteal engine is closed, and the orientation of bowel is being checked. The stapler is introduced transanally, and stapler should come on the either side of the staple line, in middle, not to the side, otherwise it will cause disruption of the staple line. And the donut is attached to the stapler. While docking the donut to the stapler, care is taken that there should be no rotation of the bowel and no fibrofatty tissue should come in between the staple line. Otherwise, staple line will leak. Once stapling is being done, stapler is taken out, donuts are checked for completeness, and the pelvic cavity is instilled with saline. The proximal bowel is being clamped in order to look for any air leak. The staple line is being immersed in saline, and leak is being checked by insulating the air transanally. As there is no leak, the fluid is aspirated, drain is placed, and all the ports more than 5 mm are being closed transfacially. The histopathology was suggestive of adenocarcinoma, moderately differentiated, invading muscularis propria into pericolonic tissue. There was no tumor perforation, lymphovascular invasion was not seen, perinealular invasion was there, all margins were negative, lymph node examined were 13, and all nodes were free of tumor. It was T3N0M0 disease. Thank you.
Thank you, Imran. We close the last session of the day. Thank you very much.
Thank you for enlightening us. We welcome our former principal, Professor Dr. Syed Tariq Qurashi, for joining us and honoring us with his gracious presence. I request Professor Dr. Tariq Qurashi to come on the dais and felicitate the chairpersons of this session. Professor Dr. Ejaz Ahmed Malik. Thank you, sir. Professor Dr. Sanjay Kumar Bhasin. Thank you, sir. Dr. Shamsul Bari. Thank you, sir. Dr. Manmohan Singh. Thank you, sir. Next in order, I invite Professor Dr. N.C. Digra to please join us on the podium and felicitate the speakers. Sir, please take us. Professor Dr. Mubashir Ahmad Shah. Thank you, sir. Professor Dr. Mushtaq Chalku. Thank you, sir. Dr. Rajandeep Singh Bali. Thank you, sir. Dr. Imran Abdullah Khan. Thank you, sir.
Kindly take a seat, sir. Thank you. That wraps up the academic sessions for today. It was an honor having you here. Thank you to all the chairpersons, presenters, speakers, and audience members for staying intellectually engaged throughout.
We will now take a short break before heading into the next segment, that is the official inauguration of JCASICON 2025. We look forward to welcoming you back for the same in 10 minutes. Thank you.
residents and delegates. Good evening and a very warm welcome to each one of you. It is both an honor and a privilege to inaugurate the 11th annual Jammu and Kashmir Surgeons Association of India conference hosted by the Department of General and Minimal Access Surgery, Government Medical College, Anantnag. We are gathered here not only to share knowledge and celebrate surgical advancement, but to reaffirm our collective commitment to patient-centered care. The theme for this year's conference, Delivering Value-Based Surgery to Your Doorsteps, is both timely and deeply significant. In an era of rising healthcare costs, advancing technologies, and expanding patient expectations, our focus must shift from quantity to quality, from access alone to impact, and from procedure-centered to patient-centered outcomes.
Value-based surgery is not just a concept. It's a call to action. It challenges us to ask, are we truly adding value to our patients' lives? Are our intentions improving not just survival, but well-being, dignity, and accessibility? It's all about delivering high-quality, evidence-based, cost-effective surgical care, especially to those in the peripheral, underserved, or rural regions, where the need is often the greatest and the resources limited. This conference is not just an academic gathering. It's a movement, a dialogue, a shared vision where precision meets purpose, where technology serves humanity, and where ethical responsibility anchors every innovation. Over the course of this conference, we will be privileged to hear from some of the finest minds in the field, prodigies and pioneers, who will guide us through cutting-edge research, time-tested practices, and evolving landscape of surgical care delivery.
I extend a heartfelt gratitude to our organizing committee, speakers, sponsors, and each delegate for your presence, your contributions, and your shared passion for progress. Let this conference remind us why we chose this path, not for prestige or power, but for service and for healing, for making quality surgical care not a privilege, but a right within the reach of every patient at every doorstep. To all our residents and young surgeons, may you find here not just knowledge, but mentorship. And to our seniors and mentors, thank you for the legacy you uphold, one that blends skill with empathy and innovation with humility. May this be an inspiring and an impactful journey for all of us. Thank you.
Now, we shall be commencing the inaugural session for this conference. Beginning the session, I would like to invite our esteemed dignitaries on the stage. Our chief guest, Professor Dr. Shaukat Jilani, who is the founder principal of GMC Anantnag. Guest of honor and patron, Professor Dr. Rukhsana Najib, Principal, Government Medical College, Anantnag. Our guest of honor, Dr. Madhumita Mukhopadhyay. Chairman Jakasi, Professor Dr. Iqbal Salim Mir. Organizing Secretary, Jakasi, Dr. Harbinder Singh Bali. Organizing Chairman, Jakasi-Con, Dr. Nazir Ahmad Wani. Organizing Secretary, Jakasi-Con, Dr. Manmohan Singh. Now, I'd like to call Shananda Shafi on the stage to present a floral bouquet of appreciation to our dignitaries. Professor Dr. Shaukat Jilani, thank you. I request Treasurer Association of Surgeons India, Dr. Madhumita Mukhopadhyay ma'am, to kindly present the badge of honor to Professor Dr. Iqbal Salim Mir, who is the chairman, Jakasi.
Thank you, sir. Thank you, ma'am. Now, I would like to request Dr. Mir Mujtaba, Assistant Professor, Department of General and Minimal Access Surgery, GMC Anantnag, to welcome and address the audience.
Respected dignitaries on the dais, esteemed faculty, honored guests, my dear teachers, colleagues, and delegates. Good evening. It gives me immense pleasure to welcome you all to JakassiCon 2025 that marks the 11th National 11th Conference of J&K State Chapter of Association of Surgeons of India. The theme for this year is delivering value-based services at your doorstep. It is a very novel and a beautiful thought process has been behind this concept. Our resolve and our commitment is for giving equitable, par excellence, and patient-centric treatment to the catering population of ours who do not have an easy access to the tertiary cares. It reflects our collective responsibility, not just to innovate, but to execute the surgical excellence so that it reaches every corner, every community, and every patient who needs it. The theme is a call to action with the idea of decentralization and the concept of reverse referrals. At JakassiCon 2025, we host an excellent scientific program bringing together expert faculty, seasoned surgeons, and young minds who are engaged in meaningful discussions that is aligned with the very concept of the theme. We are honored by the presence of national leader from ASI, Dr. Madhumita, who is the treasurer of association and our guest of honor. We are highly thankful for the able support and guidance from our state leadership in general and particularly from the chairman Jakassi, Professor Iqbal Salim Mir. We are deeply grateful for the presence of our chief guest, Professor Shaukat Jilani, the founding principal of this college who needs no introduction, whose vision has set this college into the motion and the ball is rolling since. Our heartfelt appreciation to our present worthy principal and patron, JakassiCon 2025, Professor Rukhsana Najib, who is an emblem of able leadership and continues to guide us through thick and thin with clarity and purpose. My sincere thanks to our organizing team, ably led by Dr. Nazir Ahmad Wani and our partners for their dedication and hard support and hard work who have put this show together. Let this conference be a platform where knowledge meets compassion and innovation drives the accessibility. I thank you all for the patient hearing or for being here and making this event a success. Thank you.
Thank you, sir. I would like to request all the esteemed delegates to kindly stand in attention for the national anthem. As surgeons illuminate the lives with skill and compassion, we begin by lighting this lamp, a symbol of healing and wisdom. We would request our honorable dignitaries to commence the lamp lighting ceremony. I would like to invite Dr. Nazir Ahmed Wani, Organizing Chairman, Jakasi Con, to address the audience.
Esteemed Chief Guest, Professor Dr. Shaukat Jilani, sir, our founder principal, our Chief Guest today, Guest of Honor, and Patron of this Jakasikon 2025, Professor Dr. Rukhsana Najib, our worthy principal. Second Guest of Honor, our guest from the National Faculty, Dr. Madhumita Mukhopadhyay, Honorary Treasurer, Association of Surgeons of India. Chairman Jakasi, Professor Dr. Iqbal Salim. The Secretary Jakasi, Dr. Harbinder Singh Bali. Dr. Manmohan Singh, Secretary of this Jakasikon 2025. And I am humbled to see all my teachers around in front of me, teachers of teachers, Professor Muhammad Yusuf Wani sir, Professor Nisar sir, Professor Sadru sir, Professor Bashir Kinu sir, and our Professor N.C. Digra sir, and our worthy principal of Sikim's Medical College, Professor Fazal sir, the founder and the torch bearer of this Jakasi 2025. Other colleagues, faculty, head of departments of Government Medical College, Anantnag, and their delegates and guests within the valley or from outside the valley. It is my proud privilege to welcome all of you to this event, which is a 3-day event. And as you all know, that this event was to be planned at Pahalgam Club, because you know our medical college is it's a child of 6 years of age. What can you expect from a child 6 years age? Just playing. So, but this child has proven that he's grown up in 6 years, and we could deliver. When I attended last Jakasi Khan at Jammu 2024, I was skeptical whether to tell my colleagues that I should conduct this at GMC Anantnag. So I told them, I have a wish to do it at GMC Anantnag, but I need permission from my patron, from my principal, worthy principal. When I came back from that place, I wrote an application, simple thing, for permission, and went to worthy principal, Professor Ruxana. She had just 1 or 2 months she had been here. She has been courageous enough to write approved within a second. So that gave me a lot of inspiration that if she is so much courageous to do it, why I can't do it? As you know that we have a very small team of 4 faculty members and a few medical officers, residents and consultants. It was a Herculean task to do it. So I thought my place is not well developed medical college, so let me go to Pahalgam and distract the people from this place and get it done at there so that they can enjoy and they can forget government medical college in Anantnag. But God has to do something different for me, and He told me, no, you have to do it at GMC Anantnag. And you will be very happy to know that this, if you had to come 1 week before to this place, there was a lot of garbage, cement and everything lying here and there. And we made possible using this 1 month only. I told my executive that give me 1 month and we could manage this show, and it's in front of you. I am sure that there will be definite lacunae, for we are doing it first time, such a big national level conference and biggest surgeons association at GMC Anantnag. And I really apologize for any shortcomings, any problems. Many of the colleagues, I think they will understand this, how much painful it is and how much difficult it is to arrange things. And a place where it's new, and all your colleagues, I have just cluster of 2 or 3 faculty, we were very young to use them for everything. I have taken blood out of their body for last 1 month. And luckily, I am very much proud, and I salute them for their dedication, for their work. Every member has put in his efforts, and that is the result in front of you. So without wasting any time, as we are running short of time, I welcome you all, and I am thankful to worthy principal. I am thankful to Dr. Madhumita. She has come all along from Calcutta to represent ASI here. So this is a big encouragement for us. I also am thankful to Professor Sanjay Basin, who is our past president, Professor Ajaz, who is the president-elect, who is about to take, and Dr. Shamsul Bari and others. If I forget anybody, kindly forgive me. So once again, I welcome you all, and I hope that you will have a very good time at GMC Anantnag. Thank you.
Thank you, sir. Moving forward, I would like to request the Honorary Secretary, Jakasi, Dr. Harbinder Singh Bali, sir, to formally address the audience.
Dignitaries of the dais, chief guest, and my guide, Professor Shaukat Jilani, Dr. Ruxana Najib, Principal, GMC Anantnag, and Dr. Madhumita, Treasurer, ASI, Dr. Iqbal, Chairman Jakasi, Dr. Nazir Wani, Organizing Chairman of the Jakasi Code 2025, and Dr. Manmohan, Organizing Secretary, and all my friends, teachers sitting out there. First of all, I must congratulate my friend and ever-energetic Dr. Nazir Wani and his team for organizing Jakasi Khan 2025 at GMC Anantnag despite such a big hurdle.
This is the first state level annual surgical conference to be held in the Peripheral Medical College of the state. Kudos to Dr. Vani and his team. We have been in touch since last 6 months, and we have been discussing each and every little intricacies, like how to go about it, what should be done, and he told you about this auditorium and all that. But I once again congratulate the whole team, GMC Janamnag, and wish them a great success. Now coming to the activities of the J&K chapter of the ASI Jakasi. Since our taking this organization of Jakasi in 2024 May, under the dynamic vision of our chairman, Professor Iqbal Salim, it was our endeavor to take the surgical facilities to the far-flung areas of the state so that the poorest of poor, they get the benefit of the facilities. And involve the local surgical specialists for conducting midterm conferences, CMEs, and camps in different parts of the state. Now coming to that, two midterm CMEs were held in the peripheral places. One was done in last year in GMC Rajouri, which is a medical college, and other CME was held at midterm in SDH Kupwara, which is not even a medical college. So camps were held in far-flung areas like the border areas of Akhnur, then in far-flung areas of Kupwara, Chatru, and where the facilities are very meager. Multiple patient awareness programs were conducted in the different parts of the states. Mega blood donation camps were held in ESCOMs Jammu and GMC Srinagar and GMC Anantnag in 2024-25. Hepatobiliary, this pancreatic colicum was held in GMC Srinagar in October 2024. And the live operative workshop in lab and GI and gynae oncosurgery workshop was held in GMC Srinagar in April 2024. We have achieved some goals, but a lot needs to be done. And we will work with more vigor to reach our goals. I congratulate you all and wish this Jakasicon 2025 a big success. And thank you, sir. Long live ASI, long live Jakasi.
Thank you, sir. Now, I would like to invite Professor Dr. Iqbal Salim Mir, Chairman Jakasi, to kindly address the audience.
Dignitaries on the dais, Professor Shaukat Jilani, the person who molded my surgical career, as have the other dignitaries sitting in the audience, Professor Vani, Professor Kinu, Professor Nisar, then Professor Mumtaz. Then a person whom I call a dynamic principal, the lady who has the courage of a lion. She's a man. I want to tell you people that she is the concept which made us start laparoscopic bariatric surgery. Can we have a real round of applause for her? It was her courage, her words. करो यार देखते हैं कोई मसला नहीं मैं हूँ इधर ICU मेरा काम Dr. Madhumita, thank you very much for being brave enough to not listen to those people who were spreading rumors and coming here and showing that everything is fine in Kashmir. Dr. Harbinder, my secretary and who will change his guard tomorrow, thank you very much for this 1 year. It has been really wonderful. Then the person who has been my colleague in SMHS Hospital, Dr. Nazir Wani, I hope that I see the tag of Professor come in front of him very soon. A big round of applause for him. Imagine having to change your venue and there were just 5 weeks. It was one of the toughest decisions that we as executive took, and he said, I will try my best, and he has really done it. Really great. Keep it up, boss. Then Dr. Manmohan, he is somebody who is starting his career, but he is already leaving his footsteps everywhere. I have so many people in the audience. Professor Fazal is there, then Professor Sanjay Basin, Professor Tariq Qureshi. Well, he has been the principal of this place and a very good friend. Professor Ejaz Malik, Professor Digra. I will be forgetting some people. Professor Ejaz Malik, he'll be taking over tomorrow as chairman of Jakasi. A big round of applause for him. So, I welcome you all. Thank you for turning out in large numbers, not listening to the rumors, and making the world see that everything is peaceful here. It's all because of you that the message of peace will go out, and it will certainly help our people who really need that kick in the back to come back to their life which was once stalled. Thank you very much for that. Is Dr. Babar here? Because I'm going to touch that. Well, Dr. Babar is not here, but his colleague is here, Dr. Altaf. Can we have a round of applause for them? Because I'll be telling you why. These people stood up against political hegemony. They stood up against barbarism. They stood up against those people who tried to treat that hard on doctors that we felt very bad. You guys really rock, and that is what we want from all of us. We do not want any politician to think that I'll come and I'll enter the casualty and I'll treat on these young doctors and young surgeons. That is not the way. It's not going to be like that. We are human beings. We are there for patients, but anybody who has other ideas, then we can really teach him the lesson that he deserves. Our community is facing the attack from social media, and I, as chairman, have not been able to do much in that regard. I really feel ashamed because of that. But it is something that is beyond help. Every Tom, Dick, and Harry with a mobile phone is now posing as a journalist. I have tried my best. I have written to the government. I have written to the people who matter that how do we identify a real journalist? Who is a journalist? And there are no answers. So we as a community have to come up to the level that we do not get out by any of these people. Anybody who thrusts a mic in your face, show it down his throat. And then we'll see what happens because of that. Let's stop being afraid. What are we afraid of? Are we not doing our job? We are paid and we do our job. Are we not leaving our houses in the night, coming here for the patients? Yes, complications are a part and parcel of surgery. That we have to understand. But of course, negligence is not acceptable. We have to think that was this a negligence or was this a complication? That is our side. But nobody comes and tells us that no, ab tumne ye injection mujhe B12 ka injection nahi diya, to that is a negligence. No, nothing doing. We're not going to take it. And I'm sure that ASI with us, once we say that we have to be strong as a community and defend ourselves against these targets. And I hope that I see a change in our community. We have issues. Our colleagues are repeatedly getting assaulted, both by the press, this unfortunate social media, and by the administration. I think we have to stand for each other. If we do not stand for each other, we'll be trampled. So please wake up and start thinking positive. Before I end my speech, I am a man of very less words. There's a request to Dr. Madhumita. We are an emerging chapter. We cannot match West Bengal. We cannot match Uttar Pradesh. Please, in the ASI, there should be something, an emerging chapter award, because we are trying our best to come up to that standard, but it's only you who can really help us in achieving this. And we desperately want to tell people, you must have seen the quality of work that is being done here. The videos were quite evident. And I hope that you will carry this small message from me, that it's time that J&K chapter is recognized as a chapter which is trying its best to come up to the standard that the ASI deserves. Thank you very much. Long live ASI, long live Jakasi.
Thank you, sir. Now I would like to request Professor Dr. Madhumita Mukhopadhyay ma'am, who is the Treasurer, Association of Surgeons of India, to kindly address the audience.
Respected dignitaries on the stage, Professor Shaukat, our dynamic principal ma'am, our chairperson Dr. Iqbal, secretary Dr. Bali, our organizers Dr. Wani and Dr. Manmohan, the dignitaries off the stage, I can see many of them, my seniors, my colleagues, my juniors, and the students. I can see a lot of enthusiastic faces. I just remember some 3 years ago when I first entered the executive committee of ASI, Dr. Fazal was there. And he had introduced himself that he's coming from Jammu and Kashmir. I remember telling among my colleagues, oh, that's wonderful, Jammu and Kashmir. It is so nice to be there. It is not humid like West Bengal. It is so cool, it is nice. And from that time onwards, I always felt that I should need to come over here once. And I'm so happy that I could come over here once. Thanks for all your hospitality. I'm really overwhelmed. Dr. Iqbal was saying that it's an emerging chapter. It's not an emerging chapter, you have emerged. The huge amount of work that you people have done in the Surgeons Week is just commendable. West Bengal has not done that. I'm really happy that the amount of work you have done. And secondly, regarding the RRC TISA, the postgraduate competitions, not only once, twice the winner was from Jammu and Kashmir. That speaks volumes about the teachers here and the quality of education. I'll definitely think about this emerging, okay, I'll speak about this to my colleagues over there, but you people have surpassed everything. It's just wonderful. On any field, Jammu and Kashmir is always at the helm. Since I've come from the central headquarters, on behalf of the President, Dr. Praveen Suryavanshi, President of ASI, I just like to put forward there are a lot of activities which are being done this week from ASI. Not only for the whole year, there are many programs which are planned. There's an ASI College of Surgeons which is being planned, and digital ASI app which is going to be launched. There's going to be a robust endoscopic program, and many other. There's the Surgeons Week which is going to repeat it every year. And I'm sure Jammu and Kashmir will be at the helm of all this and will be doing it with all the best, with all efforts. Before I end, I'd like to say I come from Kolkata, West Bengal, and we are hosting the ASICON this year. So on behalf of the whole organizing team of ASICON 2025, I invite you all to come to Kolkata. West Bengal is a place actually which has quite a lot of things. Maybe the weather is not like this, the climate is not so beautiful, but you have the hills. If you want the hills, you have it. You want the sea, you have it. You want the temples, you want the mosques, everything is there. And there's a Victoria Memorial too. So I'm sure all of you you'll enjoy ASICON Kolkata. Please do come. We'll be waiting to meet all of you. And one more thing which I want to emphasize, as Dr. Iqbal has already said, you say something against a lawyer, the whole organization turns up against it. You say something against an IAS officer, and you just see what happens. But when things are said about doctors, we need to unite ourselves, and we will not take this nonsense anymore. We have to unite and fight as one. So to the unity of doctors, long live ASI. Thank you.
Thank you, ma'am. Now, I would like to request Professor Dr. Rukhsana Najib, Principal, Government Medical College, Anantnag, and Patron, Jagasikon, to formally address the audience.
respected dignitaries on the dais, respected faculty members, respected faculty members from other hospitals, dear students, it's my proud privilege to welcome you here on the inaugural session of a prestigious conference, which is JKCCon. It is the 11th year they are celebrating it. I am very, touched with this conference because every year I used to attend all the conferences regarding the surgery department. Because believe me, I am 50% of the surgeon. Having worked with all the surgeons since 1994, when I joined anesthesia and critical care. So one of the surgeons told me, if we don't do surgeries, what will you do? Then I told him that we'll go to ICUs, we'll go to pain clinics, we'll go to PACs, we will go to MRI. But believe me, we are incomplete without surgeons. So as being at the helm of affairs since so many years, it was my moral duty to have supported the surgeons. If we don't anesthetize a high-risk case, how is a surgeon going to do this? So, Dr. Iqbal, thank you for the kind words, but that was a time when we should have worked. So there was a pheochromocytoma who was not getting controlled, his blood pressure was not getting controlled. So surgeons said that we have to remove the tumor, and this is the first pheochromocytoma we are doing in 2009. I said, go ahead, I'll help you out. And believe me, the physician came, they quarreled with us. Why did you operate upon the patient? Patient has not been controlled with blood pressure. I said, we will remove the tumor and then the patient will have normal blood pressure. And this is how things start. So somewhere we have to take risk. So that is how we started pheochromocytoma. Then we started Whipple's, high-end surgeries. Then we started bariatric. They said that we don't have a bariatric table. I said, we operate upon a patient of 140 kgs. She's pregnant, and we have to do cesarean. Think that she's also pregnant, and we have to, instead of removing the stomach, half of the stomach, we will remove, instead of removing the baby, we will remove the stomach. That is how things start. So before waiting for things to come, we cannot wait for perfect conditions. So we have to get started, and now I think they must have done more than 100 cases of bariatrics. This 154, and the heaviest patient was 168 kgs. So this is how surgeons are giving an instant relief to patients. There is an abscess, they drain it. There is a tumor, they remove it. So you are beautiful people on the earth. It is Tare Zameen Par here. All the surgeons from different parts of country, from different institutions, they are here. And about the conference, once Dr. Nazir Wani said that, I'm going to hold, and can you give me permission? That time, believe me, it was so difficult 1 year back. So over the 1 year, things have shaped. It's not because of me, it's because of the hard work of everyone here. The faculty, the nursing staff, the administrators, everybody helped us in shaping this institution. We are just 6 years old, but having been here since 1 year, I think I am in any big medical college. So after 1 year, I think I am in a medical college which has flourished over the years. It is not only 1 year. It is the hard work put in by Professor Shaukat, Professor Tariq Qureshi Saab, Professor Anjum, and I am taking the reward. So the things are like that. So somebody who comes after me will have an easier job, because once you start any medical college, it's really very, very difficult. So it was an honor and privilege for the Medical College Anantnag to host this conference. And the theme this year is really good, and we have seen things improving over the years. Like once I joined PG in SKIMS, there was a fashion of only open surgeries. So some of the doctors went outside and they started lapro. So we have seen that change from Dilip Kumar to Amitabh Bachchan to Shah Rukh Khan. So now Shah Rukh Khan means now robotic surgeries. So it's not easy to get robotic surgeries done because most of you have been trained for robotic surgeries, and I as anesthesiologist have been attending since 2022 these robotic anesthesia courses. So I have been going to all the places because of these conferences, and it is really important that you all attend these conferences. They really make a difference. You can navigate over the intricacies, how the things are changing over the world, and so that we are also advanced. And believe me, I will congratulate the Department of Surgery, GMC Anantnag, for doing excellent surgeries. They have done Whipples, and now it is a routine for them. They are doing advanced lepro surgeries. That is a routine for them. And what else do we want to see? Now I want them to do at least one bariatric surgery, right? So that should be the promise that should be fulfilled. So again, things, they have been thanking me for providing everything, but it's my duty to get things done. So we personally, supervised what is happening about the auditorium and other things. And I should thank the conference for getting this thing done. Maybe it would not have started for 2, 3, 4 months more. So this is the gift they have given to us. The auditorium has been inaugurated with the conference only. So thank you, Jacasicon, for getting this inaugurated. So it is already inaugurated because of your conference. We don't need to inaugurate. What best can be than getting a national level conference in an auditorium, which had to be started recently. So my best wishes to all of you, and I hope, and I have listened to so many papers, they are all high advanced papers. There was live streaming, I was listening to so many papers, and I saw the quality of the presentations was excellent. It doesn't look like it's a national conference, it looks like as an international conference. Because I have been traveling to some places for international conferences, so the standard of your conference is very good. I again thank Professor Iqbal Salim for taking time out and praising me because they have given me a name now, Dynamic Lady, and a lion. I continue, I will try to be a lion with all the males around. Thank you so much. Thank you, best of luck. And we are here for everyone, any sort of help you need. As an administrator, I'm here for every department. Best of luck. Long live Jacasicon, and long live ASI. Thank you.
Thank you, ma'am. Now, I would like to invite our chief guest, Professor Dr. Shaukat Jilani, Founder Principal, GMC Anantnag, and currently the Head of Department of Surgery, GMC Handwara, to address the audience.
Assalamu alaikum and a very good afternoon. I'm extremely thankful to Principal Professor Ruxana, with whom I have had a personal equation since we were junior consultants in GMC Srinagar. And I was always looking forward to once she will take as the reins of the Department of Anesthesia, and I will have some leisure time. She was posted in our unit in that OT. Once we were there, and we didn't have any problems. We had a long list, and she would tell me, let the list be finished, then we will all leave. Otherwise, before that, I would explain, नहीं बस 2 बज गए भैया अब कोई केस नहीं हो सकता है और आप इसको पोस्टपोन कर दिया, हम नहीं कर सकते, थक गए. लेकिन and then I was looking forward to her becoming the head of the Department of Anesthesia, but I was unfortunate. I didn't. Once she took up the reins, I wasn't there. I was already transferred to in this medical college, and So I miss that period of time with her. And I love that period, what I spent with her. And I'm sure with the kind of commitment and dedication she had at that time, she is working in this medical college with the same zeal that the result can be seen. See, within no time, this medical college will be counted among one of the best medical colleges in the country and in our part of the country. And I'm sure this is going to happen very, very soon. And thanks to Jakasi also, Dr. Dissa, Dr. Fazal, Dr. Iqbal, and so many other people who have worked hard for this thing, this part of the Association of Surgeons of India, and they have been doing a lot of good work everywhere. And I must thank them particularly, and because this is the first conference, probably annual conference of Jakasi in GMC Anantnag, and it's a very good beginning, and there are no barriers for you to go higher and better and bigger and all forwards. And also thank Jakasi Khan, because surgery in Jammu and Kashmir also, surgery did not evolve in a day. There are many stalwarts, some are even dead, peace be upon all of them, and many living legends. Some of them, Professor Bashir Ahmed Kinu, Professor Yusuf, Professor Nisar, Professor Nazil Salro, Professor Digra, and Professor Ejaz, and so many others. Actually, it's difficult to name everybody. And once I was a junior consultant in Srinagar. We were not doing laparoscopy at that point in time. I saw one of my classmates, Dr. Nazir Ahmad Malik. He was demonstrating laparoscopy on Doordarshan, Kashmir, laparoscopic cholecystectomy in Kashmir. And probably he was one of the earliest surgeons who undertook laparoscopy in JLM Ranawari, if I'm not wrong. Then, and I was always telling my colleagues in many other departments, physiology, anatomy, biochemistry, pathology, I was trying to tell them, please organize conferences. These preclinical, paraclinical departments are not lazy. They don't have funds. They have so many difficulties. And I told them, take Dr. Nazir Ahmed Wani, surgery, usse baat karo aap. वो बड़ा इसके लिए अच्छा खास बंदा वो he knows how to manage money, how to get funds, and how to get he's very well has very good contacts, he's politically well established, and he's the person who can do it. And see, he has proved me right, he did not prove me wrong. Although once I was here, we were caught by many difficulties. First abrogation, then COVID for 2 years, and then I was also kicked out. And we could not hold a conference because Najid was there, Mumtaz was there, Professor Mumtaz is there, one of the legends of surgery in Srinagar, and they are the builders of Department of Surgery and surgical skills and surgical everything in J&K. And all those who have graduated from GMC Srinagar, postgraduated in surgery from GMC Srinagar, are working in SKIMS, most of them are working in SKIMS, SKIMS Medical College, Bemina, and many GMC Jammu, and many outside hospitals and medical colleges, even in Europe and America and and the Gulf. So this is a big contribution to from GMC Srinagar, and long live GMC Srinagar, and it is our guide and our torch bearer. Third thing, I had suggested to Dr. Iqbal once upon a time that we have to make efforts to bring the quality of education, medical education, including surgical education and technique and technology on a uniform scale. For that, they have to work hard. Professor Iqbal has head of the Department of Surgery in GMC Srinagar, and Surgery Department of GMC Handwara, Anantnag, Baramulla, and Kotwa, Rajouri, etc., and Udhampur, and so on, GMC Jammu, they have a responsibility. What they have learned, and they are geniuses. Had they been Americas or in Britain, they would have already received a Nobel Prize. But because they live in this part of the globe, they are not entertained. Otherwise, they are as good as anybody. In fact, better than those who are in the West. They are much better than them, but they do not drum it up, because nobody is there to drum it for them, and therefore they are lesser known in the broader world, therefore. So we have to make efforts to bring the quality of medical education on a uniform plate. For that, you need to take many steps. They are wise people, they understand it, they have the pain of the society in their hearts, all of them, and they want to come together and deliver it. And we must have good quality and better quality. And
Dr. Manmohan Singh. Thank you, ma'am. Now, I would request Dr. Madhumita ma'am to kindly honor our esteemed principal ma'am. Thank you.
Accolades and laurels, such as those achieved by the esteemed doctors gathered here today, are nothing short of an inspiration. As we would like to take this opportunity to express our honor and gratitude, for which we shall now proceed with the felicitations. We are privileged to present the Lifetime Achievement Award to Professor Dr. Mohammad Yusuf Wani, a pioneer in pediatric surgery with over 40 years of academic and clinical excellence. He was the first to establish the pediatric surgical practices at GMC Srinagar. With over 24 publications and extensive contributions to national forums like IAPS and ASICon, Sir has guided more than 20 postgraduates and remains a revered name in surgical education. Sir, kindly come on the stage. I would now like to request Professor Dr. Shaukat Jilani, sir, to kindly present the award. Thank you, sir. We are delighted to present an award of excellence to Dr. Bashir Ahmed Kinu, an esteemed surgeon. Sir has contributed significantly to the undergraduate and postgraduate teaching, published several research papers, and actively participated in numerous national and international conferences. His lifelong dedication to surgical education and excellence is truly commendable. I would request Professor Dr. Madhumita ma'am to kindly present the award. We are pleased to present the Award of Excellence to Dr. Nisar Ahmed Wani, having his roots connected to this very place and a pioneer in the field who initiated the surgical oncology services at GMC Srinagar. Sir's efforts led to the establishment of a separate surgical oncology department at GMC Srinagar. I would like to request the dignitaries on the dais to felicitate Sir.
Thank you, the organizing committee, for giving us this award. The only thing I want to tell, I belong to this village and I have my early education from Dalagamundi. I graduated, I am born here and I passed my matriculation with distinction from Government High School, Jalagaon. And this was my dream come true. I will let everybody know it, that it was me who has proposed this place for construction of the new medical college in there. Those days, I was member of the Jammu and Kashmir Waqf Council, honorable member of Kashmir, and I was member of Jammu and Kashmir Hajj Committee also. So I talked with the honorable Chief Minister at that time that we have a place, this was an agricultural farm in my childhood, agricultural farm. Whole land was agricultural farm. So I made him sure and I made him remember that this agricultural farm can be converted. It has not become deserted, nothing is going on here. So kindly take this place and you can construct a very good medical college here. And because Anantnag is very near to it, this hospital is very near to it, so that they can shift from here to there by bus. Almost now it is connected with the Anantnag. But this thing, I made sure that this is here. Thank you very much.
We are delighted to present the Award of Excellence to Professor Dr. Mumtazuddin Wani, who has been a senior laparoscopic and minimal access surgeon at Government Medical College, Anantnag. A top-ranking graduate of GMC Srinagar and with over 4 decades of service in surgical education and patient care, Sir has held academic position and published notable research in various journals. A respected teacher, skilled surgeon, and a lifelong learner, Sir's contributions continue to inspire generations in the field of surgery.
Thank you, sir. We are honored to present an award of excellence to Dr. Nazir Ahmed Salru, a distinguished surgeon and teacher with over 3 decades of experience, including expertise in laparoscopic surgery. He has mentored countless students and contributed extensively to national and international research. Thank you, sir. We are privileged to present an award of excellence to Dr. Nazir Ahmed Malik, a distinguished surgeon and academician. He pioneered the first laparoscopic cholecystectomy in rural Kashmir in 2003 and helped establish JLNM Hospital as a center for minimal and access surgery. With multiple research publications, he has also contributed to the teachings at GMC Srinagar post-retirement. Thank you, sir. It's an honor to present the Award of Excellence to Dr. Muzaffar Ahmad Zargar, a veteran surgeon and a dedicated administrator. He served the J&K Health Department for over 4 decades. We thank him for his exemplary service and commitment to public health. Sir, Sir is unfortunately not present here today. Nazir sir will take the award on his behalf. No, sir, उनका नहीं लिखा है. Sir, we are delighted to present an award of excellence to Dr. Abdul Hamid Mir, a highly respected surgeon from Kulgam. He has dedicated over 40 years to the field of medicine. We celebrate his lifelong commitment to healing and service. We are privileged to honor Professor Dr. Altaf Wani, who has been a former associate professor at GMC Anantnag. हाँ उनका बोला उन्होंने ले लिया Thank you, our esteemed dignitaries. Now, I would like to invite on stage Dr. Zahid Mohammad Rathar, Associate Professor, Department of General Surgery, to present the vote of thanks.
Good evening, all. Thank you is such a prayer that cannot be seen or touched. It must be felt by heart. I feel honored and privileged to get the opportunity to propose a vote of thanks on this special occasion. We are very thankful to Chairman of Jakasi and Executive Committee members that they gave us an opportunity to organize JakasiCon 2025 at GMC Anantnag. I, on behalf of the organizing committee, convey deep regards and hearty thanks to our honorable chief guest, Professor Shaukat Jilani sir, for gracing the occasion with his presence and for his insightful and inspiring words. Your contribution to surgical education continued to be a beacon for all of us. A sincere thank to our guest of honor, our respected principal and dean, Professor Roxana Najib, whose guidance, presence, and support have been the backbone of this event. We are grateful for your unwavering commitment to academic excellence. We extended special thanks to our guest of honor, Dr. Mudumita, Treasurer of ASC, for her gracious presence. A heartfelt words of thanks to Professor Iqbal Salim sir, Chairman of Jakasi, and his team for his continued encouragement and active involvement in shaping this academic platform. We thank to Dr. Harbinder Singh Bali, Secretary of Jakasi, for his invaluable role and visionary inputs throughout the planning and execution of this conference. I would like to thank our head of the department, Dr. Nazir Ahmad Wani, for his constant help and guidance that radiates a source of energy with us. We will ever remain grateful to you, and we thank you for being with us today. Our deep appreciation goes to Dr. Manmohan Singh, the organizing secretary, whose tireless coordination and attention to detail ensured that every part of the event runs smoothly and efficiently. A heartfelt thanks to our distinguished speakers and panelists for sharing your expertise and knowledge. Your presentation and discussion have been incredibly informative and engaging, offering us a new perspective and ideas. I am very thankful to all of our current and former faculty colleagues and non-teaching staff members who always stand by us and motivate us. I feel proud and thankful for making this event a successful one. An event of this dimension cannot happen overnight. The wheels start rolling months in advance. We have been fortunate enough to be backed by a team of very motivated and dedicated student committee and volunteers. I cannot thank everyone for the involvement they have shown and the willingness they have been expressed to take on the completion of tasks beyond their comfort zone. Thank you all once again for your invaluable contribution and participation. You made this conference a memorable and impactful experience. Have a great evening. Thank you. Long live ASI, long live Jakasi, and long live JMC Anantnag. Thank you.
Thank you, sir. The future doesn't begin tomorrow. It begins the moment we carry today's lessons forward. This national conference has indeed been a treasure trove of knowledge and shared experiences. We would like to conclude today's session, which has definitely been fraught with ideas and discussions, and we shall be continuing tomorrow with the same fervor with which we have carried this conference today. There'll be an executive body meeting followed by dinner in the catering area. We would like to thank our esteemed delegates. We wish you a pleasant evening and a delightful stay, and we look forward to your presence tomorrow too. Thank you.
Esteemed guests and heads of department faculty will go for high tea in council room just on the second floor. And there will be an executive body meeting of the executives of Jakasi in audiovisual room adjacent to the PMC, where the PMC's office.